I would like to extend a warm welcome to all the guests and speakers who have assembled here for the OSWB District Outreach Program. We hope for a fun-filled session with interesting talks and fruitful discussion. We've tried to include interesting topics which are of importance to our clinical practice. We'll be first having our keynote by Dr. Ashim Kumar Shil, followed by the cataract session. Sir, please.
Very good morning to everybody. At the outset, I would like to thank Anirban for inviting me. So, little bit of different topic. I told Anirban who is going to listen to me. He said, okay, you present something that somebody else will find something there. So, I am trying to share some information about the economic loss due to blindness in India. The reason being, recently I had been part of a team that studied on this topic, and I am going to show you the salient findings. So how do you look at that, how we are contributing to, eye care contributes to the economy. If you look at this picture, I took this picture in Murshidabad last winter. You can see one lady sitting with a thick glass. Definitely she has received eye care, and she is watching this crop as well as taking care of her grandson. So that's how a person can contribute economically in our country. So despite several progress we made in our country, the burden of poor eye health still continues. And still we have 4.8 million people with blindness and about 30 million people with moderate or severe visual impairment. So that was the last report of population-based survey conducted by RP Center all over the country. So we need to understand the economics little bit so that we can do proper resource allocation, and the evidence should guide us. So the study that I told, it was published in IJO. So the salient features are that the cost of moderate or severe visual impairment and blindness in India in 2019, it was estimated to be 1,158 billion Indian rupee. And the large cost was because of loss of employment, and the caregiver's time. I'll go into different components of it. And what is most alarming, that poor eye health imposes a non-trivial recurring cost to the Indian economy equivalent to almost 0.7% of our GDP. This figure was purposefully taken up to 2000, in the year 2019, because after that COVID pandemic has changed everything. So to avoid that, 2019 data was taken for this analysis. And there are two things, like one is the GDP. We are most familiar with GDP, but now more accurate is the gross national income, GNI. Why I have quoted this thing? There is another study that tells about the economic loss in terms of GNI. Actually, GDP plus income received from the overseas, that constitute GNI. GNI is our own domestic production, and GNI is what we are receiving from outside. And some nations like India that receive substantial foreign direct investment, and foreign corporate presence is very significant in India. So it's better to consider economic loss in terms of GNI. So India's per capita gross national income is about 1,40,000. So when we look at in terms of GNI, if we look at in terms of GDP and then look at the blindness in terms of GNI, it is much higher. So it is saying the cumulative loss of gross national income due to avoidable blindness in India is close to 12,000 billion rupees. It's a huge loss. So what are the different components that determines the economic loss? One is the because of blindness, there is loss of employment, and there is elevated mortality risk, there is education loss of the children, and there is reduced productivity in the employment, and caregivers need to devote much time for taking care of the person who is blind or severely visually impaired, and there is productivity loss of the unpaid workers. An unpaid worker is a big factor in this country. If you think of the ladies who are homemakers, they are actually unpaid workers. Almost 50%, 45 to 50%, they are unpaid workers in the country. It's very difficult to measure their contribution in the economy. So if we think of the elevated mortality risk due to blindness, if you look at the figure, it goes on. If it is less than 6-12, 29% elevated mortality risk, and ultimately less than 6/18, 43%, and ultimately it is almost 90% elevated risk of mortality because of blindness. And if you look at the issue of children, the children with blindness live shorter. It is 40 to 55 years, average life expectancy of the children with blindness. So the life years lost are converted to welfare losses. So in brief, I'll show the slide later. Again, we are very much familiar with this school eye health program. Definitely we should take care of the children. Children with poor vision suffer from learning deficit. But what is most alarming, that less learning in the school implies lower earnings in the adulthood. That is the implication. And if we look at this figure, so loss of employment is 30% because of blindness as well as visual impairment. And then productivity is lost is 20%, and caregivers loss, if it is severe visual impairment, is 5%, and 10% if it is blindness. So ultimately these are the determining factors. So there are some thoughts for the policymakers. The absolute cost of poor eye health will increase over time as the India is aging and is becoming wealthier. Proportionately, the economic loss will be higher. And how do we find the patient? How do you reach to the patient? The screening camps and vision centers, this is a study from the Lancet, which I was part of it. We found that although we are very much fascinated by school eye health is a very resource-intensive approach. So the yield is not that much, especially in the rural areas. So if we need to concentrate on school eye health, school screening, it should be in the urban areas where yield is more, not in the rural areas. And the good news is that the recent study published by WHO, they are saying that there is a best investment in healthcare, any social sector, is the eye care. So $1 invested in eye care gives a return of $36. This is much higher. Nutrition project gives $13 return, non-communicable diseases $9 return, and all the other developments give $6 return. So 36 times return we get if we invest in eye care. So these are some of the pictures. Look at this girl, totally blind. She used to be taken care by her brother. So this is talking about the caregiver's time. So we changed her life. So after cataract surgery, she is able to enjoy her own picture. So that's how we eye care providers contribute to the economic growth of the country. This is the picture of two girls with the mother. It's a very sad story. Ultimately, we could turn their life better. When she was, it's a hereditary cataract. When she was of this age, she had undergone cataract surgery in Sundarban in one camp by some unqualified person without proper anesthesia. Her hands and feet were tied with the chair, with the table, with the ropes, and somebody butchered in her eye and she lost one eye. So she was not ready for surgery of her daughters. So I had to visit their family, talk to them, counsel them. She agreed, she came, she talked to the anesthesiologist, and she saw the anesthesia machine. She just wanted to make sure of anesthesia. Then the surgery was done on the same day and they all became well. That's how we change our life. And I thank you with this picture because this boy, when I got, he was a crawling baby. The blindness runs in their family. It's a hereditary cataract. His father also had cataract. And when the mother brought this baby to me, he said, how I am going to live? I have married a blind husband and I have given birth to a blind child. How is my life going to be? So there was 9 members in the family. Out of 9 members, 5 were bilaterally blind. And we could do something. So that's how we are contribute to the economic growth of the country, and we will continue to do so. Thank you.
Anybody want to have any question to Dr. Shil? Yes. It's an interesting topic.
No, just a comment, since sir is also from Arvind, so this is a very common quotation that we used to say in Arvind, and it's also part of the very nice documentary, that Infinite Vision, the life of Dr. GV. So it says a blind person is only mouth and no hands. So that basically sums up pretty much the entire economic and social burden that a blind person has on the immediate family and the community.
Thank you, Ashimda. We can move to our next session. We have a cataract session now, and good morning, everyone. Welcome to outreach program of OSWB. It's a outreach program of North Chobbish Pargana. Probably North Chobbish Pargana has most concentrated ophthalmologists in North Chobbish Pargana. If you consider Salt Lake within the North Chobbish Pargana, actually Salt Lake in the North Chobbish Pargana, and North Chobbish Pargana has at least 15-16 eye hospital. So it is all the big hospital here, starting from Global to Renuka to Disha to Neha, ASG, Netralayam, Shankar Netralaya, Shushrut, and Disha has 4 branches as the same district. So this should be a very academically rich program, and I would like to invite our chairperson, Dr. Ashish Chakraborty, Dr. Rothish Chandrapal. Ashita, please have your seat. And in this session, we have a esteemed panelist, Dr. Love. Can I have the front seat at least, or dais? Dr. Sanjeev Banerjee, I think Dr. Sanjeev is not here. Dr. Pradeep Ghosh, sir, the same, or you can have the in dais. Dr. Kaushik Basu and Dr. Arinam De. Arinam? Kaushik, come forward. So our first speaker, Dr. Siddhartha Ghosh, his topic is target emetropia. This is the biometry of today.
Good morning. At the very outset, I would like to thank OSWB and especially Dr. Arup Bhomik for the invite. Well, as cataract surgeons, all of us know that, we have a large number of biometers today available, and also a large number of formulae, IOL power calculating formulae, to understand which IOL power is suitable for which eye. But, it's a very common understanding. Then when we have a lot of choices, we really sometimes have a lot of debate on which formula to choose over which other. And is a single formula good enough? Or should we plug in these numbers into multiple formula to find out one or compare? Or sometimes how much difference does it make to actually use a formula which uses 7 variables compared to 2 variables? Like, all these questions have very complex questions and have a very interesting answer, but and we have seen that most cataract surgeons would disagree about the answers. Well, in the next few minutes, we are going to talk about target emetropia, the biometry of today. To begin with, let us first look at the types of biometers that we have today. And as we all know that basically of 2 types, one optical biometry and the other is the conventional US ultrasound biometry, A-scan biometry. A-scan biometry are of 2 types again. One is the immersion type and the other is the applanation type. But optical biometries are of various types, and depending on the technology they use. The one with partial coherence interferometry that came first, and then came the optical low coherence reflectometry principles. And thereafter, the swept source OCT principles came, and there are other machines which actually combine technologies. We'll talk about them a little later. We all know that optical biometry is the standard of care now, but let us remember that there are situations, there are advantages of optical biometry, long list here, to differentiate from US biometry, but there are situations with very extremely dense cataract, with corneal opacities, some patients with nystagmus and all. These are situations where we have to fall back to our good old friend, the ultrasound biometry, for appropriate results. So it is important that even in this era of new technology, we need to have, there is a place for all these old and new technologies at this point of time. There is a good place for both of them. Well, as for the optical biometers, as I said, depending on the principle they use, the PCI interferometry, that PCI is used in IL Master 500, that came first. And OLCR technology is used in Lenstar LS900 and ALScan. And the swept source OCT technology is used in IL Master 700, Argos, iStar 900, and Anterion. And it is interesting to note that even if both all these four machines use the same technology, but they may differ in accuracy because they use the technology in different ways. So the accuracy may differ in different machines, even if they are using the same technology. Well, we can come to that during the question and answer session. And the anterior posterior segment OCT with optical biometry is available with Reno NX 130. Optical biometers combined with OLCR technology and with Placido's ring, Placido disc corneal topography is available with Aladdin and OA 2000. Well, OCLR technology with rotating Scheimpflug camera is available with Galilei G6, and PCI technology with rotating Scheimpflug camera is available with Pentacam. So there are a lot of biometers and a lot of good technology are being used. And it is interesting that with all this, we also have a lot of formulas for IL power calculation. Earlier, we used to talk about theoretical regression and mix of both first, second, third generation, but today we classify these formulas into 5 groups. The first one, as you can see here, is the historical or the refraction based. The second being the regression analysis based. We all know about all these. These are things of the past, but the Vergès formula are being used now a lot based on Gaussian optics, and depending on how many variables each one of them use. Some formulae use 2 variables, some 3. Like the Barrett Universal 2 uses 5 variables, and Holiday 2 uses about 7 variables for calculation. The other kinds of calculations can be taken from artificial intelligence based formulae like the Hill RBF and the Clark neural network. And the last one is the ray tracing formulae, which are used in oculics and phaco optics. Let us remember that we have the latest generation formulae, lots of them, but the input needs to be very accurate. The right kind of input needs to be fed in the formulae to get the optimal results, and any error would give us suboptimal results. Let us remember that the input should be very accurate when we use whatever formula you use. This is just to give an example that 1 diopter of keratometry reading error may lead to 0.9 diopters of IL power error. And similarly, 1 millimeters of axial length error may lead to 2.5 diopters of error in IL power. These all we know. And these are certain variables that are being used in each of these formulae. Of course, there are certain formulae which are more suitable for longer eyes, and some are more for shorter eyes. And we need to know the anatomical factors and the IOL related factors that may affect the effective lens position. So we need to take care of all these measurements very accurately if we think of targeting the right effective lens position. Well, most commonly used formulae now, and some are very readily available free of cost online, like this Barrett Universal 2. But the pertinent question here is which formulae amongst all has really hit the target. This particular publication has shown that Barrett Universal 2 is the closest in respect to all kinds of axial lens in the range of IOL powers or lens thickness, AC depths, and a range of keratometry averages. Barrett Universal 2 gave the best fit results. This talk would be incomplete if I don't mention about these intraoperative aberrometers, the ORA and the HOLOs, which actually give the IR power calculation intraoperatively after the cataract has been removed. These are especially useful in so many situations, special reference to, post-refractive surgery, cataract surgeries, where after removal of the cataract, if you know the real IOL power calculation, only disadvantage is that you need to have a large inventory so that if you have a change in power, you have to have that lens immediately. Of course, digital markers and planners have, like Varian and Callisto, I have really increased our accuracy, the outcomes in respect to torics that are increasingly being implanted. So to conclude, using the correct IOL power calculation formula is important for good surgical outcomes, and the accurate input counts and the choice of biometer is really very important. And formula versus the intraoperative aberrometry or intraoperative refraction, it depends on the availability and the choice that is available. Well, thank you. Thank you so much.
Excellent, Dr. Is, within 10 minutes, you complete almost touches all the topics. So before our next speaker is Dr. Love, and in between we can Sagar, and we can take up a few questions. And I just want to ask, which is the formula you are using? Most of us are using Barrett formula.
Barrett.
Do you, in any case, you try another formula?
Post-refractive surgery.
Post-refractive surgery. In any other? Post-refractive surgery, what you do for the LASIK?
See, now
you use a Barrett True-K mainly?
And
or any other?
Barrett True-K, and most of these machines now have software for post-refractive surgery.
Yes,
so
LVC.
And
LVC.
what we do, that we do in 2 different machines, and with the topo value also we do. And then we see whether all are matching or not. But only thing is that if it is a post-refractive, be extra careful.
Otherwise,
with 2 different machines.
We blindly follow Barrett, Barrett Universal 2. Do you prefer Barrett Universal 2 as you have a IOL Master 7 or 2K, TK?
No, Universal 2.
Universal, not TK. Anyone using Arindam in your hospital? I seen you are using TK.
We use Barrett 2, but for post-refractive surgery, we generally rely on intraoperative retinoscopy. Make the patient effective retinoscopy. Make the patient aphakic and. No, it is a very simple retinoscope. We first get the spherical. Yes. Yes. First we do intraoperative retinoscopy. Then we get the spherical equivalent of the patient. Then we subtract the working distance and multiply with 2. If it is more than 23, then yes.
That is a macula algorithm. Yes, the macula. Yes. It is 8. It is 8 to 13. 7 to 13. You have to 1.75. If it is more than 13, it is 1.5 into. It is less than 7. It is 2. Yes. Yeah, it's a very accurate. But even then, Barrett True-K, I'm using now laser vision correction. Basically, Barrett there, IOL Master they are using Barrett True-K. It's a pretty good, except I think except RK, sometimes it gives abnormal result. I just asked, do you think hypermetropic I need to be very careful? Barrett is not able to give.
Refractive error. When the axial length is.
This is the topic.
Axial length is on either on higher side or lower side. Then Barrett 2 is most reliable.
What about premium lenses? What extra do you see?
Premium lenses,
Like trifocals.
Trifocal lenses. Premium lens, biometry is very important. And so you go for TK and universal 2, we see this how much cylinder, one part, and it is better to biometry this patient, and then I keep the ready the 2 to 3 lenses, 0.5, and the day of operation, before putting any drop, I do biometry once again.
And what about angle, alpha, angle?
See, now over the year we are using lot of cases now, we have a very fair idea what is the angle kappa. Now, to be frank, angle kappa has a very little value. It has very little value, and it is already published. It is very rare, a very high myopic, abnormally myopic or abnormally hypermetric. Otherwise, most of the cases, even blindly, you can see this angle alpha is within 5, within 6. So you can ignore now. The concept is the ignore angle of alpha until unless it is a post-refractive. Because many surgeons are not always, now in the DIAS they are telling ignore angle alpha. Because the newer model
post-refractive, that is very
yes, the
important.
only thing is a post-refractive and
Post-refractive better not to. Better
and
not to.
Kaushik, which machine in your ILMaster 7?
I have Master 5-1.
Oh, that's the low coherence, partial coherence. Don't find anything corneal. ILMaster 500 is good. Anything problem is a corneal curvature measurement, I think. No. I am talking about the anterior corneal curvature. Their technology is slightly limited to measure the anterior.
Actually, ILMaster technology, both 500 and 700, there is one limitation. For longer and shorter eyes, they are not so accurate because they use GRI, the group refractive index. And the newer machines like Argos and all, like where they have segment summation. So that gives more accurate results.
More accurate, and corneal curvature, Lenstar is the best machine because they measure 500 point.
Exactly.
5,000 point.
5,000.
So, but yes, overall in package, most of these surgeon having the ILMaster 700. Yes, good. Even Aladdin corneal curvature is very good. Okay, I will move to next topic. And we have a speaker, Sagar. Cataract surgery in small eyes and post-RK.
Good morning, everybody. At the outset, I'd like to thank OSWB and Dr. Arup Bhaumik for this invite. So I'm going to speak about cataract surgery in small eyes and post-RK eyes. So as we go along in our cataract practice, I think none of us can escape this. Somewhere down the line, you will have to have these patients who will come to you in your clinic and you will be required to operate them. So how should we consider them is what we will discuss. So what exactly is small eye? There is multiple terminologies which are there in the literature and it's very confusing. So a simple way of looking at small eye is these 4 terminologies. A simple microphthalmos, which is nothing but axial length which is less than 2 standard deviation of the population mean. Generally anything below 21 millimeters would qualify as simple of microphthalmos. You can have complex microphthalmos, same definition with axial length, but intraocular structures are they are not developed properly, like colobomas, like persistent fetal vasculature or dysplasia. So anything in combination would qualify as complex microphthalmos. Then you have nanophthalmos, where you have a small eye with thickened sclera. And finally, you have this something called as relative anterior microphthalmos, where axial length may be normal, but the anterior segment will be crowded. So we will come to that one by one. So this paper actually nicely sums up these 4 things. So this is a normal eye. This is a ophthalmic eye. You can see symmetrically the eye is small, but there are no structural problems. But here the eye is small with a thickened sclera, and here the eye may be of the normal dimension, but the anterior segment is quite crowded, to the extent that anterior chamber depth, anything below 2.2 qualifies as a relative anterior microphthalmos. So what should be the approach in such cases? Very important that we all know small eyes will have a chance of angle closure glaucoma. A gonioscopy is very important because if you have an occludable angle, this needs to be treated first because you will reduce the chance of developing glaucoma and ultimately medication for this patient. Also, it helps intraoperatively in reducing the chances of malignant glaucoma on table. Optical biometry is most important in these cases because you cannot afford an axial length error because smaller errors will lead to bigger errors in the final refraction outcome. Appropriate formula, so there are a lot of studies that have been done on these eyes, and of late the best formula for that is Kane. Now why Kane? Because Kane has a data driven approach and it combines the theoretical optics as well as the lot of database they input to come out with solutions, and it is constantly improving because it has an element of AI also inbuilt. So as of now, Kane remains the best formula for such eyes, and we have to consider certain additional investigations also because shallow anterior chamber will have issues with regard to the endothelial problems, so you need to document specular microscopy. Ultrasound, if the vision, if the fundus view is not good because you may miss a shallow choroidals in the periphery. UBM at times, if you're dealing with the nano-ophthalmic eye, a very subclinical uveal effusion can be picked up in UBM. OCT is important because these patients may have foveal hypoplasia that can be picked up on OCT, and you can actually prognosticate the case, and PAM and RAM will actually tell you what is the visual outcome of these patients. So most important thing is deciding which viscoelastic will you take in these patients. So obviously in this small eye you want space and you want endothelial protection also. So basically the best would be using a combination OVD which will give you both space as well as endothelial protection. So right now we have these two options. One is from Alcon, the other is from Entode, which has this combination, and it works out very well because it gives you the space as well as the protection of the endothelium. And if you don't have this, one can use a soft shell technique where you can use a dispersive viscoelastic to coat the endothelium, and you can use a cohesive viscoelastic. My preferred choice would be Hilon 5 because it gives a good space to work with. So let's come to the cases. So this is a patient who was a 48-year-old status post vitrectomy with silicone oil in situ for TRD, and the VR surgeon didn't want the oil to be removed, so this was on table. We have to do the cataract surgery. So these were the parameters. So here you can see the axial length is okay, but the ACD is just 2.15. So here we are dealing with a relative anterior micro-ophthalmos. See the lens thickness is almost 5.82. So it's a very thick lens with a very small anterior chamber. So how does it go about? So let's see the case. So you can see that there is a posterior synechiae out here. And with this irrigation, with the saline irrigation, I'm trying to open up because the staining would be difficult in this case unless you do remove this posterior synechiae. So the posterior synechiae is being opened, and of course one has to be very liberal in using the hooks. So here a dispersed cohesive viscoelastic we are using to bring about the capsular rhexis, and it was tough. The space is very limited out here. So we came out with a small rhexis. We will enlarge it later on. So here we proceed with the procedure, with the surgery, and we did a right chop, and then we take care of the nuclei. The point here is that you have to maintain this phaco tip in the center because there is hardly any space. So if you take it up, they are going to hit the endothelium. So just keep it at the center. Let the fluidic does its job. Let the fluidic do its job. So you basically keep it in the center, and all the things can be removed comfortably. All the pieces can be removed comfortably, and then one can always enlarge the anterior capsular opening, and then the implantation of the lens. So relatively, it's not very complicated. This procedure. We move on to the next case. So this was a 71-year-old gentleman, had a Yark PI, had cataract changes in both the eyes, and pressures were normal, but importantly the optic disc was normal. So when we did the investigations, ultrasound showed a sclerochoroidal thickness of 1.9. So we know that anything above 1.7 would qualify as nano-ophthalmos, and the axial length was not very, it was just borderline 19.27. The IOL power came between 38 to 41. And the anterior chamber depth was shallow. So here obviously we are dealing with a patient of nano-ophthalmos. Now again, a lot of controversies. How do you deal with nano-ophthalmos? Should we do openings or not? But what we have to understand that nano-ophthalmic eyes will have issues because you can have intraoperative complications like PCR and aqueous misdirection. We have to deal on table. Intraoperative uveal effusions can happen actually, intraoperative and post-operative. And very rarely you can encounter supracaudal hemorrhage in these patients. So some of the things that we need to decide before taking up this is that you need to have a pre-op mannitol to decongest the vitreous. Best is to do a sclerotomy plus minus sclerectomy. Cornea is relatively thicker in the periphery, so when you are making the entries, you have to remember that because you may make a larger entry. And intraoperatively, you have to avoid anterior chamber collapse and keep a VR backup handy because if there is an intraoperative aqueous misdirection, you will have to do a vitrectomy. So let's see this patient. Here we are doing a sclerotomy in the inferotemporal quadrant. So basically, you are going 2 millimeter behind the limbus and creating a 4 by 4 millimeter scleral flap, and in the bed of the scleral flap, again around 4 millimeters from the limbus, you basically carve out a scleral block tissue. So here we are dissecting the scleral block tissue and exposing the supracaudal space. So this looks difficult, but it's not very difficult. We have to be very careful with the dissection, and with loose sutures, you can put the flap back. So basically, we have done a sclerotomy in this patient, and the procedure went on smooth only. Only thing is, well, again, as I told you, the anterior chamber should be maintained all the time. This was a 40 diopter lens. When you're implanting this a 40 diopter lens, you will always see that it comes out with a thud. It comes out with a jerk. So we have to be careful at that point because there are times when you can actually rupture the posterior capsule with that. So this was the end, and the outcome was quite okay. There was no choroidals, and the patient did well. This is a final patient who goes to the next level of spectrum, 54-year-old gentleman, and look at the axial length, around 15.67 and 15.49, sclerocaudal thickness of 1.9, and dense thick lens, and the power was coming between 35 to 55. And in this case, we basically used this approach wherein we did anterior lamellar sclerectomy. We made the flap and excised the flap. And inside we made a V-shaped sclerotomy and excised the tip of the sclerotomy. I'll show you the video of this patient. So we are, in this case, the only difference was that we did it in all the 4 quadrants. Now the recommendation is in extreme nano-ophthalmos, you can do it in 2 quadrants. In this case, we actually did it in all the 4 quadrants. Exactly it's the same way we created the scleral flap, and we excised this. So you can see that that thing is excised. And then a V-shaped incision is given in the bed, and the apex of the V is dissected. So apex of the V is dissected from the bed and actually excised. So that small area, you are exposing the supracaudal space for whatever is uveal effusion happening to kind of continuously drain. So, and of course the surgery was challenging. Again, you can appreciate that the eye is very small, the pupil is small, you are basically dealing with a very small eye. Such cases, when you are doing hydrodissection, you have to be very careful, do a very minimal hydrodissection in multiple levels because there is no space for even the fluid to pass. So, so the surgery again went on smoothly. So this is the lens. Again, we implanted a 40 diopter lens in this patient. And then final conjunctival closure was achieved. And this patient did have, in spite of having 4 sclerotomies, had a choroidal effusion which eventually cleared in 4 weeks, but she did well with a refraction of 4.5, achieving a BCV of 6 by 24. So this was the picture now. This patient has completed almost 12 to 13 years with me, and she is still maintaining 624 in this eye. But have a look at the other eye. This was a surgery done elsewhere, and this patient had an ascites in the other eye. The lens was implanted in the sulcus, and patient eventually developed a corneal decomposition for which it became a painful blind eye. Patient eventually needed a evisceration. So the take-home point which I want to tell you was that this cases should be addressed earlier. Don't allow the cataract to become very dense. Don't do a ascites in these cases because you will not be achieving a in-the-back placement of the lens. Because if the in-the-back placement, the cornea remains fine, and the long-term, even though the vision may not be very great, but they will maintain a vision. So I think I should finish with this. Thank you. Any questions, I'll be happy to answer.
Thank you, Sagar. As usual, this is an excellent talk. I think it's a really, really difficult case to take as per for the if you don't have a such experience, it is better not to take these cases. And yes, a relative anterior nanophthalmos, it's a much easier to manage. You have to be very careful regarding the regarding during the your procedure phacoemulsification, because everything is okay, only the anterior chamber. And Dr. Abhay Vasavada is respected all over world for this his work in relative anterior nanophthalmos. I want to start with the love. What is the highest diopter you implanted?
I don't give more than 30.
Oh, you
Rest
don't
I
give
give.
it.
Rest I give.
Sagar. So
Which company are you all?
yes, I do. Yes, last week I have to implant 62 diopter lens.
62.
Yeah, bilateral
company?
62. I don't care.
You can
This is a
customize. The only
customized
problem
lens.
with is the
Customized lens.
is the
62
quality of-
diopter.
How is the quality of
Axial
vision,
lens
sir?
कितना?
How is the quality of vision post surgery?
क्या quality patient का vision देख रहे quality? What is the quality? Because in USA you will get regular up to 60 diopter.
Yes.
In India, unfortunately,
But
you
is
have
the-
only 40 diopter
40.
is available.
Is the
So
size of these
anything-
lenses smaller than
No.
normal
No, slightly
13
larger.
13
Yo,
millimeter.
it is a,
It's a thickness
this is a
issue.
thick, and it is like
but-
a central
Button. Lenticule.
lenticule, which is a more diopter. See, it posterior pole, but it is now it is abandoned because
Not advised.
Dr. Snyder has a huge report regarding that vitreous tap and blind vitrectomy for the nanophthalmic eye.
The problem
and
is
the chances of choroidal effusion
yes,
is very high. So now with invent of femtosecond flags, the algorithm is give mannitol, capsular rexis by flags, femto, and if pupil is dilated well, then the multiple quadrant aspirate news material and implant eye and make a that's half thickness and radial cut. They are not using that punch. They just make a full
This is a radial
punch,
cut.
just
The problem
expose.
is exposure is not great.
Not
Or
great,
you
a multiple radial
You have
cut.
to do a multiple radial cut.
Radial cut.
The one
This
which I
is-
showed the
yes.
first case, that gives sufficient exposure, you can cover it with the
Yes,
flap.
yes.
The other one, you can actually excise the flap.
Anything, Arindam, which is, what is your experience of these cases? This is very difficult to handle these cases.
A real problem arises when it comes with iris coloboma or lens coloboma. Right. Then everything gets subluxated, and flax is mostly not possible because mostly pupil is not dilated. So flax, yes. If pupil is dilated, then flax is good, if possible.
See, I had a patient. I had to operate both eye. She's a daughter of one of the health director, and he's absolutely clear lens because of uncontrolled glaucoma and crowding of the anterior chamber. The lens has to be removed advised by the glaucoma surgeon, and I did the surgery. And I did the same procedure. I do the femtorexis. I didn't take any risk, because if you rexis extend, then
You are gone. There is no backup. There is no backup.
And in femto, you can use pupil maximized. In
Yes, maximum pupil maximum. Okay, Sagar, thank you so
Thank
much
you.
for. Yes.
Usually, I give oral glycerol before the surgery instead of giving mannitol, IV mannitol. And I have managed so many cases of 30 or 30, maximum 32 diopters of biometry. It reduced the IOP. I learned it from Junjunwala Lions Eye. Is equally good like that of mannitol.
So for sclerotomy, I have to have a diagnosis of nanophthalmos. It's not the axial length related diagnosis. Nanophthalmos is the key. If there is a nanophthalmos, I will do a sclerotomy. The reason is now there is a study from Arvind which has clearly proven that if you have, they have two groups, 60 eyes, sclerotomy, 30 eyes normal. The group which had sclerotomy had 50% less complication rate than the other. So you would definitely want a safe surgery. So 1.7 millimeter and above, the scleral thickness, the sclerocoronal thickness, 1.7 millimeters and above. You can safely do a thick sclera.
Chances of complication. And for retina surgeon, I think sclerotomy much easy for you.
And one more point.
It's really difficult for us, but very easy for you.
One more point I would like to add. Probably single piece lenses will be better in smaller eyes because
Definitely.
it's a smaller axis.
Either way you have to put in the bag.
Yeah.
In the bag, single piece lens always better than any other lens. And to be frank, only acris of single piece is available up to 40, and other is available up to 32. So definitely, if nano-ophthalmology, we have to choose a single piece. Thank you, Sagar. And now next speaker is Shivashish. You are not ready. Your program. Managing subluxated cataract.
So, good morning, everyone. Thank you for turning up, and I would like to thank Renuka Anirban for organizing such a great event and such a great meeting on behalf of OSWB District Outreach Committee. All the credit goes to you. So today it is more like it is more of a case discussion kind of thing. The difficult case that I faced. The case had two difficulties. One, it was a subluxated cataract which I discovered on the table. On slit lamp examination also I did not find any gross subluxation, so there was no gap. And the second was, it was a local councillor's mother-in-law. Mother, acceptable. Mother-in-law is still, it puts in a more of 5% of more pressure on the surgeon. So on the start of the case, so at the starting only, just on making the side port, you can see this small strand of pigmented strand which has come out. That was, and I lost all the red glow. Just when I had stained the capsule. While doing the rexis, I could see that the whole bag was moving. So now at this point of time, I realized that there is something wrong because the bag was not stable, and this small thing which was peeking out, on pulling it, it was a vitreous strand. So on pulling this, the whole bag was also moving. So the plan was to try to complete the rexis. But as the bag was not stable, so I had to complete the rexis after multiple attempts of refilling the anterior chamber with viscoelastics. In these cases, I am a little generous with viscoelastics, as many viscoelastics as I require, just to be a little on the safer side. So this is the area where the subluxation is, or the weak, the zonules are a little weak. I would not say subluxated, but the zonules were weak. This patient had very conveniently, the patient has very conveniently omitted giving a history of trauma after the surgery. When we asked her that, after repeated questioning, she had revealed that yes, she had fallen down, hit her eye on the edge of the bed, but she did not find that it to be a very significant history that she needs to reveal. So we planned, so I tried to go ahead with doing the phaco. The main plan was to chop into as smaller pieces, take each piece out of the bag, and then continue with eating away the pieces. They were not very hard, moderate grade, NS grade 3, maybe 2 to 3 cataract. But the problem was that I was not having any zero glow. I was not having any glow because through that weak area, through that subluxate area, the trypan blue had gone into the vitreous cavity. So after doing a few chops, I realized that I was not being able to take the small pieces out of the bag. I was having some partial chops also. And I was afraid to do a aggressive lateral separation because already the bag was weak. So at this point of time, I realized that I was not able to complete the chop. So I refilled the anterior chamber, came out. I was trying to assess what is the status of the bag. Still the bag was in place. So I thought that I can go ahead with completing the phaco. So still my try was to do as many smaller chops as possible so that a smaller piece, if I can take it out of the bag, the rest of the pieces, it becomes easier to tackle the other pieces if one small piece comes out. But at this point of time, I was facing difficulty with taking out even the smaller pieces which was chopped. So as the pieces were not coming out, I realized that there was restriction in the movements. And there was some vitreous which was coming through the sides. Although the bag was in place, but some vitreous was seeping in through the sides. So I decided to refill with viscoelastic come out. Then after refilling, I thought that it would be better to take care of the vitreous strands which were coming through here. So I take a cutter, anterior vitrectomy cutter, and on the cut IA mode, just trim the vitreous strands which were coming through the sides. To be careful not to touch the bag in that area while doing the vitrectomy in that side. On the other side, just cutting away the vitreous strand which was peeking out through here. Then it was more or less visible that there were no remnant of vitreous strands in that area. Every time before coming out, refilling the anterior chamber with viscoelastic. Going ahead with phaco again, trying to complete this case. At this point of time also, I was not very sure that whether I would be able to complete the case without any use of any other device. But as there was no visible still subluxation, so I tried to complete the case by taking out smaller pieces out of the bag. I was able to do with a few pieces which I was able to emulsify. But then again, there was some restriction of movements in the way, and at this point of time, on forcible manipulation, after some point, we'll see that I was having a gross subluxation in this case. So some pieces, I was thanking my stars that I am able to take away take out some of the pieces, and the surgery was going on fine. But this was like a nightmarish situation for me. Yeah. At this point of time, I realized that there was a gross subluxation here. The bag has shifted this side. There is a gap here. There is a gross subluxation here. So the next step was to stabilize the bag. I made a side port incision. I used a capsular hook to stabilize the bag in that subluxated area. So after putting in the hook, it was much more easier. The bag was stable. It was easier to take away the pieces. After that irrigation aspiration, the cortex was cleared. Then we had put in a CTR to stabilize the bag. The only difficulty again that was lack of the fundal glow. So it was more or less of a blind procedure. So after placing in the CTR, the IOL, a single piece IOL was implanted in the bag. Post-operatively, the patient did fine. The only thing was that for 3 weeks she was seeing all blue because there was strip and glue in the vitreous, and that is the end of the case. Thank you.
Hello, Kaushik. How differently you do this case?
Three things I would do differently. First is, as soon as vitreous is identified, dictum is first to deal with vitreous and then go for phacoemulsification. So when it was coming from side port, first do a vitrectomy there, remove the vitreous from there, and then next was while doing rexes, if you seal that area with chondroitin sulfate, specifically viscoat, then the dye would not go posteriorly. Then the red glow would have stayed back. And third was when after removing the first, suppose first chop and first piece of nucleus, at the earliest possible instance, I would have implanted a CTR because that will help.
So, as Kaushik will start with the capsular hook first, you will start without capsular hook?
First CTR and then capsular hook.
Oh, first CTR and then capsular hook. Arindam?
House may not agree, but if subluxation is detected during capsular rexis, then first we need to assess whether it is horizontal instability or vertical instability. Here
Okay.
it is horizontal instability.
Horizontal, yes.
For horizontal instability, capsular tension ring is recommended, and for vertical instability, capsular hook is recommended. So it is a localized horizontal instability. So for me, after doing hydrodissection, I would put CTR in this case.
Okay.
Number two, consistency of the nucleus. Right, if it is a soft nucleus, for all subluxation, I generally try to do a bigger rexis. Bigger rexis, that gives a very little tension on capsular zonules.
If we have time, then I will discuss this case because definitely I would like to put. I like to put the capsular hook first. And our next speaker is Dr. Minmoy Das. His topic is how safe is the bucket of IOL complication.
Thank you, OSWB and Dr. Arup Bhumik for intraocular lens in this case. It's a video already I made beforehand. So sound is also there. Sound
is considered one of the easiest steps in cataract surgery. But there may be a lot of hiccups during this relatively simple and easy maneuver. Here we can see the tip of the cartridge is not in the proper place.
Intraoperative
tip of the cartridge should be inside the clear corneal wound during injection of intraocular lens. The wound-assisted implantation technique may sometimes cause the IOL to get stuck at the entry point. The lens has to be taken out with McPherson forceps and needs to be reloaded in cartridge. If required, wound to be extended a little bit, followed by reinsertion of intraocular lens in usual manner.
Same thing can be happen with multi-piece IOL also. It also can be stuck in the wound sometimes. Here is also I just take the lens out and again reload it and then increase the incision and put it in the bag.
The single piece acrylic intraocular lens have a tendency to be sticky, causing either the haptic stuck or in that case, with a capsulorhexis forceps or by using two blunt instruments, the haptics can be easily released.
So this is a haptic optic stock, and here I used the capsulorhexis forceps and with a ball dialer to release this stock.
Sometimes the IOLs tend to flip in entry chamber after implantation. In that case, entry chamber needs to be deepened, and then by using two blunt instruments, the intraocular lens can be flipped back into normal position.
So this is a case of PCR where the multi-piece
Here is
lens.
a case where a multi-piece intraocular lens was flipped in the presence of a posterior capsular rent. After injecting viscoelastics with the use of two dialers, intraocular lens can be flipped back in its normal position. We also noticed a strange phenomenon of plastics-like material sticking to the back of the optics. These plastics are most probably originating from Teflon coating of cartridge walls. But these sticky materials can be removed by using irrigation aspiration or Simcoe cannula. In this video, after successful multi-piece intraocular lens implantation, it was seen that the leading haptic was torn and PCR happened. The lens was then taken out from bag into entry chamber. And cut with Vanna scissors in two halves. And taken out through the main phaco incision. And another multi-piece intraocular lens was implanted in sulcus. This video showed that the haptic is already broken in the cartridge, so intraocular lens injection was stopped at the earliest. In this video it was shown that one haptic of multi-piece intraocular lens was detached from optic during insertion. The surgeon reattached the haptic with the optic just by pushing it into the haptic groove and dialed it into the bag. In this video, during dialing of a multi-piece intraocular lens, the posterior capsule rent happened, and somehow the surgeon was able to catch hold the one haptic of IOL and managed to put the lens in sulcus.
So first vitrectomy done, and then the lens was placed in the sulcus.
Surgeon injected the single piece oil in usual manner, but it went in such a speed that the intraocular lens injured the zonules and it was seen behind the posterior capsule in the vitreous cavity. Patient was referred to VR surgeon for further management.
the lens was taken out, and after vitrectomy, a multi-piece lens was put in the sulcus.
Meanwhile, how many minutes do you have?
This is last.
Okay.
After seeing different complications of intraocular lens implantation, we can conclude that this step also needs full concentration. So don't relax after successful phacoemulsification, and don't let your guard down before intraocular lens implantation, because any untoward complication can occur during intraocular lens implantation which can affect surgical outcome.
Thank you, sir.
Oh, wonderful, wonderful, all the complication. Excellent video. Meanwhile, one comment, Pradipda, just one comment, we're short of time. Just one comment.
Amongst these complications, I have faced so many. I have personally faced so many. In one case, I can remember, it was PC rent. I was putting three-piece lens after vitrectomy, but just one haptic broken, and it
goes down. Yes, sir.
Okay, thank you. Meanwhile, it's a wonderful bucket of oil complication. And I think there are many surgeons, not only you, many surgeons. I see the Twin Chaudhary case, Dr. Owen Manto's case. My case is also there, probably. There's a lot of complications. Any comment? Sing one line. Dr. Love, one line.
One thing I faced, this Alcon PP is breaking, I faced quite recently and multiple times.
That's a very common nowadays. Just after spanglification, after 2018 or 19, I've said that the material of the Alcon multiple lenses has changed, and that the haptic is very breakable.
Multiple times. I
have
3-4 cases
it happened
in which it is
to us.
breaking.
At least one batch, multiple times. Okay, our next speaker is Dr. Kakuli Sen. Her topic is early detection and management of PCR. Welcome, Dr. Oh, sorry, Rakhi Sen.
Good morning, respected panelists and colleagues. I'm thankful to OSWB for giving me this opportunity. After such informative sessions, I'm going to talk about a very basic concept of early detection and management of posterior capsular rent. Now, posterior capsular rent is a breach in the posterior capsule during cataract surgery, which is quite inevitable complication and can happen in the very best of hands. So, no need to panic. What we need to do is to detect it early and manage it properly. Why detect early? To prevent devastating complications like IOL or nucleus drop, vitreous loss, which may cause retinal detachment and giant retinal tears subsequently, and in chronic cases it may lead to cystoid macular edema and chronic inflammation. A very careful preoperative examination is very important to detect any pre-existing posterior capsular weakness, like in case of posterior polar cataracts, in vitrectomized eyes or eyes that have received previous intravitreal injections which may cause needle track injury, or in pseudoexfoliation syndromes where there may be zonular laxity. Now, alarming signs to notice during the surgery is a disruption or irregularity in the posterior capsule margin and a clear red reflex. The nucleus fragments and the cortex material may vanish from view from the anterior segment to the posterior segment. An important sign, which is very difficult to assess but very helpful, is the snap sign. It is a sudden jerky pupillary constriction and backward tilting of the nucleus during hydrodissection. It happens due to accumulation of fluid between the nucleus and the posterior capsule, causing a blowout of the posterior capsule, causing backward tilting of the nucleus and sometimes nucleus drop. Other signs are sudden deepening of the anterior chamber, due to vitreous prolapse, excessive sideways tilt of the nucleus or the IOL during IOL implantation, inability to rotate previously mobile nucleus or nuclear fragments, and partial descent of the nucleus into the anterior vitreous space. The vitreous in anterior chamber can be easily diagnosed using preservative-free triamcinolone acetonide. It is very important to locate the vitreous strands that enter the ports, which have to be removed by anterior vitrectomy. Now, management of posterior capsular rent. First, what are the management goals? Removal of the lens matter, prevention of vitreous loss, prevention of further extension of the PCR, placing an intraocular lens finally, which may be primary or secondary, and providing the patient the best possible visual outcome. To manage, we have to make our plans according to the stage, which stage the PCR has occurred. During hydrodissection, if there is no drop, the lens is just tilting or there is partial descent, then better to convert it to SICS and do any amount of anterior vitrectomy if needed and place the lens if possible. If the nucleus has already dropped in the vitreous cavity, then no trying to fish out the nucleus, please. It may lead to giant retinal tears. Just suture the ports and refer to vitreoretinal surgeons. During phacoemulsification, our immediate reflex should be not to pull out the phaco probe or the IA probe. Instead, return to foot position 1, reduce all the phaco parameters, inject dispersive viscoelastic substance to seal the posterior capsule and create a barrier between the vitreous and the nucleus fragments. Now, if the fragments are small enough, then we can continue with phacoemulsification. But if they are larger or the nucleus is hard, then better to convert it to SICS. If the nucleus has already dropped into the vitreous cavity or into the anterior vitreous cavity, then as I discussed earlier, suture the ports and refer. An important technique is the IOL scaffold technique, where we place the lens between the posterior capsular rent and the nucleus fragments, so that it creates a barrier between the vitreous and the nucleus fragments, and we can easily complete the phacoemulsification. If needed, anterior vitrectomy can be done. Best method is by the pars plana route, because it provides the least traction on the vitreous base or on the retina. After all this nucleus and vitreous management, we have to see if the anterior capsular margin is intact. If possible, then a 3-piece IOL is the best option, placing it in the sulcus and doing an optic capture. A single-piece lens could cause subsequent glaucoma or erosion of the iris, so a 3-piece IOL is the best option. If no capsular support or an extended rhexis margin, then we can always go for a pars plana vitrectomy with secondary IOL like iris claw lens, SFIOL or a glued IOL. Thank you for your patient hearing.
Thank you, Dr. Raki. It's an overview of PCR management. Thank you, excellent talk. As we are running very late, we will not taking any question for this session. Thank you so much. Thank you, OSWB once again, and thank you, Renuka, for organizing a wonderful CME program.
So we'll be moving on to the glaucoma session. The moderator will be Dr. Shutapa Roy, and she will be starting.
Welcome to our glaucoma session. We have esteemed panelists. First, I will request Dr. Sanjay Thakur sir, Professor sir, HOD, Sagar Datta Hospital. Please come to the dais. Then Sumit Chaudhary sir, Senior Consultant, Disha and Ramakrishna Mission Seva Pratishthan. Please come to the dais. Dr. Nilay Majumdar, sir, HOD, Shushrut, Glaucoma Services. And Dr. Abhijit Pal, Senior Consultant, Disha. Please come to the dais. Okay, so in this session we have 4 talks. First of all, I am starting my topic on, today my topic is management of uveitis glaucoma. First, in 1813, Joseph Beer was the first one to describe arthritic iritis, and Priestley Smith was the classification of uveitic glaucoma. We get around 10 to 20% of patients with uveitis having glaucoma, and it is mostly seen in the 3rd to 4th decade of life. Females are more prone. Anterior uveitis, older age, chronic inflammation are all related to higher prevalence. Certain types like JIA, sarcoidosis, Fuchs, herpes simplex keratouveitis are associated with higher prevalence, and unilateral glaucoma should always raise the suspicion of an inflammatory glaucoma. These are the common conditions that can cause raised IOP or glaucoma in anterior uveitis, intermediate and posterior uveitis. And when we come into the pathogenesis of the glaucoma or raised IOP, first is secondary open angle glaucoma that may be due to alteration of aqueous humor consistency, leading to reduced permeability and trabecular meshwork obstruction, trabeculitis, Schlemm's canal and venous outflow obstruction by trabecular precipitates, steroid-induced rise of IOP, and permanent direct trabecular meshwork damage and post-trabecular meshwork damage or hypersecretion. There may be pre-existing POAG or pre-existing PACG. Or angle closure glaucoma may be due to PAS, posterior synechia causing pupillary block, granulomas, membranes neovascularization in the angle, or secondary angle closure due to swelling or rotation of the ciliary body and choroidal effusion. Steroid is a double-edged sword, and it can cause uveitic glaucoma up to 42% of cases. And mass trial has shown that implant-associated eyes have 4 times greater risk of IOP elevation and glaucoma. So when we deal with such a patient, we should not miss the subtle signs in the slit lamp, in the anterior chamber, cornea, iris. This is very important. And gonioscopy. Angle neovascularization, keratic precipitates, pigments, even retained lens fragment in the angle presenting late after surgery. So in gonioscopy, if open angle, we should look in the iris for sectoral atrophy, heterochromia, pigment dispersion. If everything is normal, then look for or think for Poschner-Schlossman or idiopathic. In close angle cases, in goniosynechia, sarcoidosis, toxoplasmosis, Behçet's, or ciliary body rotation, if we find in UBM, VKH can be suspected. So uveitic glaucoma is a complex disease, and there are many challenges to deal with such a patient. First is corneal opacity that causes difficulty in gonioscopy and disc assessment. Small pupil, complicated cataract, opaque vitreous, everything causing difficulty in disc assessment. We have difficulty to perform the perimetry or perform the OCT-RNFL because there is misinterpretation. Chronic recurrent uveitis causing closure of PI, failure of filtration surgery. We cannot give prostaglandin analogs to these patients. And pediatric patients, they have lack of history, late diagnosis, and difficulty in examination. And definitely failure to control surgery, that causes failure of surgery. So treatment is complex and challenging, and we should understand the underlying mechanism and individualize the treatment accordingly. As a glaucoma specialist, our role is to manage in these cases to manage short-term angle closure management, in longer term to take the pressure out of equation, so that it does not restrict the management of uveitis. There are different mechanisms of angle closure, and we should manage accordingly. Like in pupillary block, there may be pre-existing, relative, or absolute. and chronic angle closure and central AC shallowing. So when we come to the treatment guideline, first to treat the underlying systemic disease, specific anti-infective treatment if anything needed, non-specific anti-inflammatory immunosuppressive biologics, and treat ocular inflammation, specific and non-specific, anti-inflammatory pupillary dilatation, treat elevated IOP medically, surgically, or laser. In glaucoma medications that are unique to uveitic patients are, we cannot use pilocarpine and prostaglandin because of more chance of inflammation. Whereas ROCK inhibitors are the new drug in our armamentarium that is giving good results in this patient along with anti-inflammatory effects as well. So what are the dilemma in laser PI? We need multiple large chance of PI, chance of failure is more. Even we release the iris bombi, there may be goniosynechia or angle closure due to PAS formation. So in these cases, surgical PI or surgical intervention is needed. According to studies, 30% of uveitic glaucoma patients need surgical management, TRAB with MMC, glaucoma valve, ALT, SLT, goniotomy or mix, cyclopio or cyclophotocoagulation is better avoided. So when it comes to the decision making, whether it is combined or not, depends on concurrent disease, cataract, range of IOP, inflammation, AC depth, and number of anti-glaucoma medications patient is using. What I do when TRAB or tube? When there is no failure, no risk factors, high IOP and optic neuropathy, I go for TRAB with MMC. And when there is risk factors are there and significant risk of chances of failure are there, and in special cases like JIA, VKH, Behçet's, I go for tube first. Unfortunately, tube versus TAB study did not include the uveitic glaucoma in it. Surgery is always complicated because people are small. We need to put many devices, sometimes hooks, expansion devices, sphincterotomy, and chances of inflammation is also more. So PARLS to have a successful glaucoma surgery is to treatment modification to reduce post and pre and post-op inflammation. Surgeries should be avoided whenever possible in inflamed eyes. In active cases, aggressive perioperative steroid therapy, injection, long-term topical use, and immunosuppressive, and proper counseling and follow-up of patient is very important because patient should not have a sky-high expectation in these cases. AGV shunts are effective and AGV is preferred in valve shunts. Inspection of conjunctiva to rule out scarring before a plate positioning and angle evaluation. In a narrow angle patient, we can place the tube in the sulcus or pars plana and avoid the short tube. Higher risk of CME, post-op hypotony and cataract tube erosion is there. We can keep some cohesive viscoelastic in AC to prevent the early hypotony and adding cycloplegics. After all of our effort, even we can have 1/3 of uveitic glaucoma cases. Second or third operation is needed. And activity of postoperative inflammation is a critical factor for longevity of glaucoma. Complications are definitely high and we should look for these things in this patient. Tube should not touch. And these are the other things that can be done like express glaucoma filtration devices and the newer one that is that is mix in the uveitic glaucoma and it is showing a promising result. Trabectome, eye stent, bleb forming devices like gel implant or pressure flow implant with MMC. GAT, bang or Kahook dual blade and NPDS are giving good results but need longer follow-up and studies to say definitely. Future direction, value of OCT angiography should be more evaluated, because in these patients we have difficulty in disc assessment along with field. Place of MIGS, that will tell in future, and reassess the role of TD CPC, micropulse wave transcleral diode CPC is giving very good results in some studies. Thank you. I will request panelists to comment anything on this.
Uveitic glaucoma is definitely very tricky glaucoma to treat. I want to highlight a few cases which have uniocular glaucomas like Fuchs and this Posner-Stossman syndrome. Especially in Fuchs, if any young patient comes with uniocular cataract, we should always look for this entity. Because the eye is white and there is inflammation, and if you are going to deal with the cataract, you have to be double careful, treat the uveitic part, take care of the post-operative inflammation. And so far as A is concerned, this Posner-Stossman is concerned, you have to be careful, because though it is uniocular, it can alternate with the other eye, and chances of development of POAG in the later life is more. So for that they need longer. Thank you.
Sumit sir, any comment on MIGS in these patients?
Frankly speaking, for MIGS, this is not a suitable cases. Ideally, even the TRAV is also not suitable here, because the failure rate is very high. In these cases, the valves are better, and try to avoid the entrance placement. Better to go for the posterior placement behind the iris. Another thing, just MIGS, still no. Still no. If you go for the want to do, if you can't afford the valve, go for the trap. But with the mitomycin C, and also aggressive use of steroids to avoid scarring. It should open. Otherwise, not open. No.
Professor Thakur sir, you want to add anything, sir?
No, these, I think they have covered it very well. It's a difficult case to manage, and as was suggested, that whenever a young patient, pre-senile patient comes with cataract, pre-senile cataract, young patient coming with pre-senile cataract, then I always take a history of redness or pain, recurrent history of, because uveitis is a very common cause. So we have to be careful and check the IOP in those cases.
I want to add something. I think PGs are there, PGTs are there for them. In uveitis, we most of the time we also encounter cataract also. So sometimes there is a crucial thing to decide when to operate. So first thing I want to highlight that uveitis interval cells-free period should be at least 3 months. Sometimes it happens like that, uveitis is gone. In my PG period, I was in confusion. Uveitis is not there, whether to do the cataract or not. So the dictum is at least 3 months. And before doing the surgery, at least before 1 to 2 weeks, we should start preoperative topical, and or it's an aggressive one, we can consider systemic steroids also. Yeah.
Okay. Thank you. Now our next talk is on PSCD. Sir, Dr. Niloy Majumdar sir.
Thanks OSWB and Dr. Shutaparay for inviting me. I'll be speaking on primary angle closure disease. So primary angle closure glaucoma as such accounts for 25% of all glaucomas worldwide. But it is responsible for nearly half of blindness due to glaucoma. And there is threefold increased risk of bilateral blindness in this disease compared to POAG. So it needs earlier detection and more careful management. These PSCD eyes are shorter with smaller corneas, shallow anterior chamber and thicker lenses. The basic pathology being relative pupillary block and iotrabecular contact or ITC. Primary ankylosing disease classification according to ISGO is mainly in 3 groups. Primary ankylosing suspect or PSCS, where there is greater than 180 degree or 270 degree by some other researchers, or iotrabecular contact or ITC under defined gonioscopic condition, other things being normal like IOP and disc. Primary angle closure means ITC with either pass and or increased intraocular pressure, and primary angle closure glaucoma means primary PSC and glaucomatous disc. And some authors included acute angle closure crisis as a 4th criteria. This instrument is of utmost importance in the diagnosis and management of this primary angle closure disease, a 4-mirror gonioscope. Anti-7 OCT and UBMs are also useful tools. My main highlight will be on the management part. The treatment options specific for PSCD are either pulling the iris away from the lens or angle with pilocarpine or iridoplasty, bypassing the block by peripheral iridotomy, and removal of the lens. Lens extraction is a choice. If the angle doesn't open after PI, failure could be due to extensive peripheral anterior synechia or other mechanisms of angle closures like plateau iris, ciliary block, and the lens itself, which is at fault. How to diagnose that the lens is at fault? AC doesn't deepen after peripheral iridotomy. Lens is thicker and the anterior surface is bulged, and the tip of ciliary process is visible with gonioscopy. Normally they are not visible. Lens vault measurement is an important tool to diagnose. The challenges for lens extraction in such cases starts from accurate biometry, doing biometry, to managing intraoperative complications like choroidal hemorrhage and post-op complications like choroidal detachment and malignant glaucoma. So the operative strategies to tackle these are adequate control of intraocular pressure preoperatively. Incision should be more corneal. The parameters of phaco should be reduced. Liberal use of OVDs. Pupil dilating devices when needed. Suture the incision when needed. And tackling post-op inflammations. Many researchers have found that yes, lens extraction helps with regards to reduction of intraocular pressure and opening of the angle, but complications are also higher. One well-known study, Eagle study, showed that clear lens extraction reduces the intraocular pressure slightly more than the laser PI or medication group in PSC or PSCG. But the problems are the cases had early glaucoma and gonioscopic data was missing, and accommodation loss in younger patients was a possibility. The cartoon. This case had acute angle closure in the left eye. IOP was not controlled with maximum medication and PI, and the patient had cataract. So I did phaco under mannitol, and after surgery, the patient had almost disease-free life without medication, and vision was also restored. Filtration surgery in these diseases is also problematic. Initial intraocular pressure and extent of synechia may not accurately predict the need for TRAB. If the disease is of short duration and stable, then cataract extraction and sometimes goniosynostosis may help. But if TRAB is done, the failures and complication rates are higher. How to tackle this? Pre-op mannitol, thicker scleral flap, ostium should be placed more corneally, large PI, maintaining anterior chamber all the time during the surgery, more careful suturing of the scleral flap and conjunctiva, and use of cycloplegics. Management of acute angle closure crisis, we all know that we have to urgently, on emergency basis, reduce the intraocular pressure, and once the pressure comes down to below 40, we can give pilocarpine and do the laser PI as soon as possible, and PI to the fellow eye also. If the IOP is not controlled or there is still corneal edema, then we can think about iodoplasty or laser PI, followed by laser PI. Sorry. Paracentesis may be a possibility, maybe an option. Surgical PI, if laser PI is not possible, trabeculectomy, especially in patients with peripheral anterior synechiae more than 180 degree, and lens extraction if there is cataract. This case had acute angle closure in the left eye, but it was managed timely with medically and IAC PI, and after IAC PI, surprisingly, the patient didn't recover. Management of primary angle closure and primary angle closure glaucoma are more or less same. Medical management to control the intraocular pressure followed by PI, but greater than 40% ultimately need surgery. If the peripheral anterior synechiae is less than 180 degree, iodoplasty if the lens is clear, SLT if the angle is open, lens extraction if there is cataract, and if the PAS is more than 180 degree, then you have to think about trabeculectomy combined with lens extraction if associated with cataract. And lastly, management of primary angle closure suspect. Laser PI is not mandatory in such cases because it is seen that conversion from PSCS to PSC is not very high, shown by Dr. Thomas and other studies also. JAP trial is one well-known study where the incidence of conversion of untreated PSC to PSC or AAC in 6 years is low, and LPI has only moderate prophylactic role. But this study did not include the provocative test positive cases. PI in PSCS is indicated in the following situations: fellow eye with ASCC, patient needing frequent pupil dilatation, history suggestive of intermittent angle closure, and when regular follow-up is not possible, and there is strong family history. And we also remember that if the patient is taking any sympathomimetic medicines, that may also cause angle closure attack in PSCS patients. Other reasons are very narrow angle, high hyperopia, and bilaterality. This case came to me with mild headache, vision okay, there is no suggestive family history, IOP okay, only thing was that the angle was occludable. I advised PI, the patient refused. This was the Van Eyck's photograph. Angle is reduced to a chink. There is a gonioscopy, totally closed, and the patient came back after 4 to 5 months with acute angle closure attack. So in conclusion, the main pathology in this disease is relative pupillary block or ITC or the lens itself. Gonioscopy is an indispensable part of the management. Pilocarpine and PI are major initial tools. In acute angle closure crisis, initial medical management followed by PI or iodoplasty. If uncontrolled, lens extraction plus minus trabeculectomy. In PSC and PSCG, laser PI plus minus medicines initially. If uncontrolled, lens extraction plus minus trabeculectomy. PSCS, LPI only in high risk cases. And you have to remember lastly that trab and cataract surgery in this entity requires special attention. Thank you.
Thank you, sir. Thank you, sir. I want to know something from you. I just wanted to know whether in chronic angle closure patients, when you are doing the trab, then are you doing routinely goniosynechiolisis?
No, no.
Okay.
I usually don't do goniosynechiolisis, but if there is any obvious peripheral anterior synechia, we put visco to release the synechia. If it is not released, I don't use instruments to disturb it. Usually.
Any other comment from our panelists?
That's what Niloy was said. The patient didn't come for the PI.
Yeah, yeah.
Yesterday, my experience to me, I advised PI for one patient 6 months back. He said, okay, I will do it. Then I gave him the consent form. He took the consent form, read it out, and said, I won't take the risk. He refused. Yesterday, the patient came with an acute attack. This is the experience. When you give the consent form, if the patient sees and everything is written there, all the complications, the mind comes, I made her do it. But today, yesterday night, he suffered. So you have to be very careful of that.
Yeah, and it is in fact both
ways. That's a counseling.
In fact, I think the degree of angle closure matters. With the angle of this amount of closure that I have shown, probably PI is definitely indicated. But in a patient with Schaffer's, maybe grade 2, etc., etc., I have seen patients.
You can wait.
I advised PI, and patient came after 10 years. He is doing fine, no problem.
You can wait.
Okay, our next speaker is Dr. Nazneen Nazam. She will talk on lens-induced glaucoma.
Cells in the anterior chamber.
Cells.
Cells.
Yeah.
Cells. Cells
Because,
in the anterior chamber.
and for that, for medical management, we have to use steroid also. I have written that in that slide.
Recently, just I was going through a literature that this type of cases, you should always do an ultrasonography, USG B scan to see whether you are missing a case of intraocular lymphoma or something.
Definitely.
Because you can't see that because of corneal edema, maybe some amount of cataract is also there. And this has occurred that the patient has come with iridectomy, but the intraocular pressure is not controlled for a long time. So we have to keep an watch that you are missing a case of
definitely.
intraocular tumor.
Definitely. But here I am only covering primary angle closure disease.
As a masquerade.
Definitely.
About a patient being advised PI and patient refuses and nothing happens for a pretty long time. He may seek a second opinion also. And then he comes back to you, see, nothing happened, you just advised me for no reason. So
that's why you have to explain. I use the data of Dr. Robbie Thomas. I say that 80% cases we will not have anything. But in 20% cases you may have. So it is your choice whether you fall in this 20% or 80% group.
Want to do advise a PI. Patient accepts something.
Yeah.
I want to gain the vision or I want to relieve of the glaucoma.
That you have to explain.
I won't have the glaucoma.
This is like taking a vaccine.
That's right. They want something. Because if I do the PI, the patient, nothing happens to the patient.
In fact, some complication may
money
occur.
goes. The price is there and nothing else. Because he was, what was he before, after, all the same. That's the problem.
I'd like to thank OSWB for giving me the chance to present here. So I'll be talking about lens-induced glaucomas, nothing new, just a short overview because all of you as cataract surgeons are already managing such cases. So what is lens-induced glaucoma? It is a type of secondary glaucoma where the lens plays a role by virtue of either its size or position or because it incites inflammation. It's an important cause of irreversible vision loss, especially in developing countries like India. It is more common in older age and in women. Now, lens-induced glaucoma can be phacomorphic, phacolytic, lens particle glaucoma, phacoanaphylactic uveitis with secondary glaucoma, and phacotopic glaucoma. So, phacomorphic glaucoma is the commonest type of lens-induced glaucoma, which is a secondary angle closure type of glaucoma precipitated by an intumescent or mature cataractous lens in an already predisposed eye, which is a small and a hypermetropic eye. So the mechanism is the swollen intumescent lens causes a pupillary block which precipitates an angle closure. This causes an outflow obstruction of the aqueous and a rise in the intraocular pressure. The patient comes with acute pain, blurred vision and the perception of colored halos around light. The visual acuity is reduced to PLPR level. There is lid edema, ciliary congestion, corneal edema, shallow AC, presence of cells and flare, pupil mid-dilated fixed, intumescent cataractous lens, very high IOP, and gonioscopy revealing 360-degree closed angles. So the management is first to reduce the intraocular pressure by giving IV mannitol, oral Diamox, topical anti-glaucoma medications, and to remove the cataract. The definitive management is cataract surgery, but sometimes we may go for combined surgery, a trap with a cataract surgery, especially if there is a synechial angle closure in more than 3 quadrants on gonioscopy, or if the IOP is not controlled with medical management for more than 7 days and there is evidence of optic nerve head cupping on B scan. The second most common type is phacolytic glaucoma, which is an open angle type of glaucoma associated with hypermature cataract. So here there are microscopic leaks in the capsule in a hypermature cataract, which leads to the release of high molecular weight lens proteins. Now these high molecular lens proteins by itself, either they cause the obstruction of the trabecular meshwork, or the macrophages which have engulfed these high molecular weight proteins, they block the trabecular meshwork, leading to a rise in the intraocular pressure. Again, the patient comes with severe pain and a history of diminution of vision for the last few months or years, because after all this is a case of mature cataract. So this is the picture of a patient who came to me 1 week ago, and he had red eye and this kind of a picture, and he was applying lubricating eye drops because somebody told him that he had conjunctivitis. So the patient comes with corneal edema and AC cells and flare, and lots of lens particles floating in the anterior chamber, mature cataract, high IOP and open angles. So the treatment again is IOP reduction, and to give anti-inflammatory treatment like topical steroids, sometimes oral steroids also, cycloplegic drugs, and a prompt lens removal. The third type is the lens particle glaucoma, again a secondary open angle type of glaucoma, which is precipitated due to the retained lens fragments in the anterior chamber post cataract surgery, or due to a penetrating lens injury. The treatment again is to remove the residual lens matter. Phacotopic is a type of secondary glaucoma occurring due to subluxated or dislocated lens, and of course you will find the signs of subluxation, asymmetrical anterior chamber depth, iridodonesis, phacotonesis. The treatment again is to reduce the intraocular pressure and lens removal. So a brief word about cataract surgery in such cases. Reduce the intraocular pressure preoperatively. Go for a slow globe decompression when you do paracentesis. These cases may be complicated because of hazy view, because of the corneal edema, and shallow anterior chamber in case of in these cases sometimes. CCC may be difficult because of the possibility of rhexis runaway in intumescent cataracts. Keep CTR and other disposables, vitrectomy and etc. ready in such cases, and rigorous post-operative anti-inflammatory medication is important, and IOP control. So to conclude, lens-induced glaucomas are a common subset of glaucoma in India and developing countries. The commonest is phacomorphic glaucoma. We need to aggressively reduce the IOP before surgery. Early cataract surgery, with or without trabeculectomy, aids in visual recovery and IOP control. And post-op follow-up to monitor IOP and inflammation is important, and visual rehabilitation. Thank you.
One of the picture, she showed that there is a totally the anterior chamber, you cannot even see any structure. So in these type of cases, we have seen that patient has been diagnosed outside as a case of endophthalmitis or panophthalmitis and has been referred to medical college or somewhere for treatment of the panophthalmitis. So how to diagnose, differentiate between these two conditions?
Same thing I saw a few months earlier. The patient came complaining of a foreign body sensation, and the patient was given Milflox, but the patient received Milflox DM from the pharmacy, and the patient instilled that, and after a few days the patient came with a totally chalky white cornea. So the patient was admitted, and they thought it was a case of endophthalmitis or infection, whatever. The patient was admitted and given IV antibiotics and acetazolamide, because digitally the tension was high. Only after 2 to 3 days could we see the clearing of the, could see somewhat the anterior chamber, and then we saw the lens matter in the anterior chamber, and then the IOP was reduced and the patient underwent an uneventful cataract surgery.
So the color of the material in the anterior chamber is very important. In case of this phacolytic glaucoma, the color of the material is white.
White.
Whereas in the case of endoff or panoff, it will be means yellowish type of color. And another thing is that when this type of case come to us, we should add anti-inflammatory topical, that means steroid. That is a must. Steroid.
Definitely.
That you have to keep in mind means.
I want to ask one thing. What are the precautions you all take while doing the capsular rhexis in these cases in phacolytic? I mean, if you do any lens tapping or lens fluid tapping or anything before the rexis starting rexis or directly start? Or
You see, phacolytic glaucoma capsulorhexis is not very difficult because there is always a liquid cortex. Once you puncture, the liquid will drain. Problem is a phacomorphic intumescent cataract. Once you puncture, it can extend. So there's a different technique. The most useful technique is to do a smaller one first, and then expect some amount of cortex, and then if you can identify where is the fluid entrapment, you can do if you do the OCT, you can see the different pocket of the fluid. So better to avoid the area where the fluid is maximum. So then make a small one, and again you can do small one and then extend the rexis. This is a better technique. But even then, some cases, if you puncture, and then immediately it can extend. So it always really a problem. So one technique is that Pinaki Nag always shows, when you puncture, simultaneously you aspirate. So keep the needle with the aspiration tube of the phaco tube, keep your aspiration on and puncture, and immediately some kind of aspiration and immediately remove, and definitely visco conduitin sulfate, viscoat has an immense role to flatten the post anticapsule.
Thank you, sir. Anyone?
Thank you, OSWB. Thank you, Ashida, Anirban, and also Sudhapa to bring me here. 6 minutes for neovascular glaucoma is quite tough. Let me try. Okay. Yes or no? Huh? Okay, this is some of the pictures of the neovascular. This is a florid type of neovascularization with there. Even you can see the gonioscopy, you can see the blood in the antechamber, or the neovessels are there, fine neovessels are there. It's a blinding disease with an intractable disease also, and difficult to manage, because we need two types of doctors are there. One is a retina surgeon and one is the glaucoma, and it's a teamwork, so we can save the patient. Results in disastrous visual loss. Goal of treatment is avoid or reduce the visual loss, because whatever loss is there, it won't regain. But we must try to maintain as much as possible. The prevention is better than cure in this neovascular glaucoma. Have a high index of suspicion of its development. Be aware of the ocular disease that can cause neovascularizations. If it occurs, early diagnosis and rational management is essential to minimize visual field loss. In this era of high diabetes mellitus, even the general physician we see or we find in a chamber, they are not requested to see an eye doctor yearly or something like that. When the patient comes to us with a low vision, it is already in the advanced stage of neovascularization. The pulse for early diagnosis looks for neovascularization, and it should be done in the undilated slit lamp evaluation. Look at the iris. The pupillary area is very important. You must see with a high magnification and also angle by the gonioscopy. Management by more than one physician team approach. Clinical course is a pre-glaucoma stage, the normal IOP and the open angle. Nothing to worry. But the open angle stage, florid NVI is there, inflammation and the open angle, still no. But the worst is that the chronic closed angle stage, where the ectropenia angle is closed with the wrap type of neovascularization. Differential diagnoses are there. The pre-glaucoma management, how do you manage it? The pan-retinal photocoagulation or pan-retinal cryotherapy. And the latest are the anti-VEGF. Lots of anti-VEGFs are being used. You should use, but it should be combined with the pan-photocoagulation if needed. It all depends on the retina surgeon. The neovascularization has to be reduced. And the patient, retina surgeons, the patient has to refer to the glaucoma people to see the angle, to see the pressure, and see the disc. It has to be regular follow-up. Closed angle glaucoma stage management, retinal ablation, anti-glaucoma medications, avoid the pilocarpine and the prostaglandin as much as possible. Anti-VEGF therapy by the retina surgeon, even everyone is given the anti-VEGF therapy now. Filtration surgery with metabolites, mostly with the mitomycin C, 5-fluorouracil, very rarely used now. Aqueous drainage device, this is the ideal cases in this of neovascular glaucoma. And last, if there's a painful eye, we can go for the cycloablative procedure or the endotherapy. Medical management, everyone knows that, but topical steroid and topical atropine is a must to avoid the cyclitis and give relief to the pain and to the patient. Trabeculotic and neovascular action, make sure the primary disease is taken care of. That's with the glaucoma and the retina. It is taken care of, and the diabetes also, where we find the most of the cases of neovascularization. Preoperative anti-VEGF to reduce the rubeosis before going for the trabeculectomy. At least the 15 days time gap should be there within the 15 days. Once I give the anti-VEGF, within the 15 days is the ideal time to do a trabeculectomy, because here you find the angle, the neovascles are less, there are emptiness of the neovascularization, so there less bleeding and the filtration sometimes stays. Major cause of failure of trabeculectomy is excessive healing at the conjunctiva teres fossa epicentral. That's where the trab is being done. And if you find any thick conjunctival vessels, that's means it is a time of failure. You have to go for aggressive opening of the trab. How to avoid the scarring? Risk factors for scarring to be assessed: neovascular glaucoma, failed filtrates, etc. Conjunctival inflammation is very important. Look for drug allergies also. How to avoid scarring? Perioperative tricks, good hemostasis, but hemostasis to train the trap only near the trap area where you're going to go the trap, don't make it white all around. And minimal diathermy, that is. And good wound closure, that is very important, the tight wound closure. Postoperative tricks, minimize inflammation, give frequent steroids, use a topical steroid, and if we need the re-injection of mitomycin C of 5-fluorouracil in 180-degree opposite to the trap side or near the superior rectus where you're going for the trap. Antimetabolites, antifibrotic agents, mitomycin C mostly used now, 5-FU is not so much effective. Wound titration, tight wound closure reduces complication. Don't go to give the loose sutures of the trap. Post-operative titration control the flow. This is a small video which shows the titration is a releasable suture. Just go for the half thickness bites of the cornea. Take this with a 10 or nylon. Again half thickness and come near the limbus area. Now the scleral sutures is between. Just look, the three stay, 1, 2, 3. You can even go for the 4. No. And just pull it, make it tight. Now see, if I remove this one, then it opens up. This is called the titration. Laser suturitis, again to go for the good or to maintain the flap. Clinical pulse effect in the window period, that's when ideally if you go for the laser suturitis, it should be done within 15 days when you're using the mitomycin C, not before 15 days, after 15 days. It works much better. Cut the crucial suture one by one. Cut one at a time. But be aware of the hypertony. If you cut all the sutures at a time, you may land up in hypertony. Again, how to do the laser suturitis? With the Hoskin lens, just focus into Hoskin lens with the Argil laser, with a 50 watt micron, 2.5 joules or something like that. Just put it, you can see it opens up, it clears up. And just press it, you'll find the bleb. And this is again a wound titration. Neovascular drainage device, mostly used in the case of neovascular glaucoma, where trab is contraindicated because there is a florid rubeosis. And this is a small video clip of that. It was an old case of retinal detachment done with the plum, and later it landed up to the pear-shaped eye, where the patient said before the operation I was in emmetropy, but after the operation it came to -5 or 6 diopter, and the neovascularization started. So my colleagues of retinal surgeons said, as there is a trap, belt buckle is been done, remove the buckle and do the valve, and later we'll give the anti-VEGF. Just hit there, just removing the conjunctiva here, just pulling the suture where the blade buckle was done, just pulling it out. The plum came out. This is the plum which was just too tight was there, and the eye was a pear-shaped one. And maybe that caused the neovascularization later on. But why, I don't know. So I decided to go for the AG valve. Here the AG valve, it is put inside in that pocket. The valve body has been sutured with a 9-0 line-all. Two sides has to be sutured here and there. Now the trimming of the tube is beveled up. With the 23 gauge, I am entering the anterior chamber. And the tube is being inserted. And the close of the conjunctiva is separate conjunctiva, tenons separate, and the continuous suture of the conjunctiva. Okay, thank you very much.
Thank you, sir. Any comment from panelists or anyone wants to add anything?
Sure.
Valve one for
yes?
GDD. When you put a GDD, you always put a valved one, AGV. Did you use a non-valved one in any case?
In our hospital, in the Disha hospital, I'm going for the valve. Suchanda is doing for the Adi.
Okay.
Wait a minute, I don't do the Adi.
Okay. You don't do non-valve?
Yeah. Because Adi, you need to use the diamos for 1 month again. And most of the patient doesn't suit it. But the problem is another one is the price cost is coming out.
Yes, yes.
Price is, this Adi valve is much cheaper with the 4,500 to 5,000. And here this price came to 28,000 now.
28,000 now. Yeah.
It's really costly.
What was the time gap between the retinal surgery and the development of neovascular glaucoma?
More than 6 years.
And the band and the buckle came out very smoothly.
I don't know how. Yes, it came out smoothly.
Yeah.
It's very out smoothly.
I think you
most probably there were less support stitches were there.
I think you should report it. I don't know whether it's common or not. I think it should be reported.
No, it comes out.
Neovascularization
after that. It came out smoothly. No. Why neovascularization?
If the buckle is very tight, there is anterior ocular ischemia which can cause neovascularization.
Yes.
So it is a known situation in the literature, and the buckle comes out easily once you are dismantling the sutures. It's easy as it is shown in the video.
No, but it should have been much earlier. Such a tight buckle.
It can cause an anterior ocular ischemic syndrome, which can cause neovascularization.
It should not be so delayed.
The patient came to me lately.
It's quite a long time.
Patient came to me, it was said high myopia with the neovascularization. I gave some anti-glaucoma medication, doesn't work. I said, let's go. And the patient was ready to go, take the risk. Yes. 6:36 till now. Patient is with me. Yes, patient is with me. But one thing is that the patient power came down to minus 1.5 or something like that from 7. Because of the plumb shape, it got released. I came shorter. Okay. Thank you very much.
Thank you, sir. So here we come to the end of the glaucoma session. I will request the panelists, sirs and speakers to come forward for a group photo and hand over the mic to cornea session moderator.
Just before you start the cornea session, I'd like to announce we have birthday of Dr. Shivashish Das today. So I'll just have a small celebration on stage to commemorate his birthday. Please, Shivashish, come. I'd like to call in our past president, Dr. Kajal Ghosh, to be on the stage, sir. Mrinanda, please come. Oshimesho. It's a birthday celebration. Dr. P.N. Bishes, sir, please come, sir.
So now we'll begin the cornea session. I would like to invite Dr. Kushal Chaudhary to the stage. And we have 4 talks, so 8 minutes per talk and 2 minutes of discussion. I request all the speakers to stick to the allotted time. So I would like to invite Dr. Shoham Bashak to the stage to begin with the first talk for this session. Over to you, Dr. Shoham.
A very good morning, everyone. Thank you, Dr. Anirban, Renuka Eye Institute, and OSWB for this opportunity. So we'll begin the talk on the Blink Meet. So this is a sponsored talk from Alcon. So I'll be talking mostly about the newer things that we have come to learn about, one, how Blink relates to dry eye, and two, a very easy method of sort of diagnosing and managing dry eye in your clinics. So prevalence in India, newer studies, almost 50% of the urban population has dry eye. Risk groups would be the digital or the screen users. And if you look at the subtypes, highlight here is majority are the evaporative dry eye and the mixed kind of dry eye. So basically, we have things involving the lipid layer, which is getting involved in most of the patients that we see in our clinic. So almost 80% would fall in the evaporative or the mixed dry eye group. And if you look at the dues to risk factors for evaporative dry eye, so here I would like to highlight just on 2 things for this talk. One is the meibomian gland dysfunction. The second is how the blink affects the dry eye. So blink is very important now. This is research which has been coming up in the last 3 to 4 years. So blink relates very closely to the tear film homeostasis. With blink, complete blink is when your upper lid touches the lower lid and there is a squeezing action. So that releases the meibum secretion. Then it helps to spread evenly on the ocular surface, and that basically maintains a good healthy tear film. So what happens with digital screen users or in digital eye strain is, one, we tend to blink very infrequently, and two, the blink transitions from a complete blink to an incomplete blink. So it's basically a psychological thing that happens. We don't want to miss even those milliseconds or microseconds of the screen time. We are so addicted and the eyes want to see so much more. And that also negatively affects the overall meibomian gland health. So poor blink causes, again, gland obstructions, eventually leading to gland atrophy. And this leads to more inflammatory collection of inflammatory cytokines in the tear film. And also we have these proliferation of these bacteria and all these mites, which again negatively affect the meibum quality, again leading to dry eye. So this is a very good demonstration. This I show everywhere. These are my glands. So you can see all the three things that have evaporative dry eye. I have digital eye strain, lot of screen use, I have poor blinks. So in both the eyes, the partial blink is 100%. And there is MGD. There is significant gland loss with poor lipid layer thickness. So this is what the entire, how our current lifestyle is leading to evaporative dry eye. Now coming to, this is a very new addition which has come up in the last 1 year. So this is a very simplified detection of subtypes of dry eye disease in your clinic. So normally, now the point is, since everyone is seeing these patients, so we need something so that we can identify and treat them easily without going into too much sophisticated machinery or referring to your cornea colleagues. So this is the dry eye wheel. This has been proposed by Dr. Craig from New Zealand and recently published in the World Council of Optometry conference and journal. So what it has is basically these three circles. So the outer bronze ring, middle silver ring, and an inner gold ring. So we move from more simpler to moderate and then finally complex levels of treatment, diagnosis, and everything. So if we look at the two highlights here, one, the thing is the comfort time after blink. So the concept is, ideally if someone has good tear film, after blinking a couple of times, they'll be able to keep their eyes open comfortably for 10 seconds. If someone is unable to do that, they definitely have tear film instability, or there is a component of dry eye symptoms kicking in which forces them to blink. So that is one. And the second thing is the blink completion. So whether your upper lid is touching the lower lid, that is something we have to be consciously observant of when we are looking at all these dry eye patients. So this is where Alcon comes in. This is the Alcon device which was launched, which was shown at a meeting earlier this month. This is the comfort time after blink screening device. So what it does is you blink a couple of times, then you look at a screen which is playing a short 10-second clip. There is an integrated camera which captures whether we are blinking in that time period or not, and it gives a printout which can be then shown to your doctor. This is a very simple screening device, and it is basically something which you can have in your waiting area. So as the patients are waiting, everyone can get screened for it, and they walk into your clinic with that slip, and you know whether how fast they are blinking or whether they have a comfortable blink or not. And if you're looking at this, the dry eye wheel, so basically in the measurement part, we have this comfort time after blink and the questionnaires. So these are very simple things, non-invasive tests, which can be done to all the patients. If you have something positive, then you move on to the fluorescent staining or lissamine green staining, look at the tear meniscus height, look at the meibomian secretion, and if you have devices, then go for meibography or the tear film osmolarity. So this is one thing I disagree with. So osmolarity, I would put it in the gold ring rather than the silver ring, because that again requires a highly specific equipment. Then coming to the management part, you have simpler management with lubricants, warm compressors, and blink exercises. Then moving on to more complex treatments like the vector thermal pulsation therapy, some therapeutic contact lenses, and then punctal plugs. And then in terms of mitigation, you ask them to basically modify their lifestyle initially. Then we move on to some hormonal treatment or see if they are on certain medications which is affecting their tear film. So this I would highly recommend everyone to take a look at this dry eye tear film. It will help you in basically easily identifying dry eye patients and then also managing them. And then finally coming to management of the evaporative and mixed dry eye. So this is what Alcon is all about right now. So this is the first time and the only drop so far which is having a lipid-based artificial tear film. This is Cysteine Complete. And since most of these evaporative dry eye patients have problem of lipid layer, till now there was no replacement for it rather than some ointments which were very sticky and not easily usable throughout the day. So the advantage is you have the lipid replacement, plus there is hydroxypropyl guar which helps in the retention of all these molecules in the tear film, adding to a prolonged action of duration of action. So very briefly, the main components which make Cysteine Complete unique is one, the HP guar, which forms like a mesh network which sticks onto the corneal epithelium and the mucin layer, and it helps retain all the moisture plus the other molecules. Then there is the lipid layer, which is the DMPG, dimyristoyl phosphatidyl glycerin. And then that is further broken down into nanoparticles by a emulsifying agent, that is the stearate 40. And then that breaks it up into small particles. Then there is reduced blinking, and also it mimics the naturally occurring tear film lipids much. And if you look at some of the data from the clinical trial, so this is something which is very nice. So one drop actually offers comfort for up to 8 hours in all the different subtypes of tear films. And then this was a crossover study, so comparing a nanoemulsion versus a non-lipid containing eye drops. And then if you look at it, so patients who actually benefit very well are the people who are starting with a low lipid layer to begin with. So there the benefit and the increase in lipid layer thickness is much. If someone is starting with a high lipid layer, the benefit is there but not as much. And if you are comparing with the other cysteine group, the cysteine ultra, which we are all familiar with, again cysteine complete causes higher improvement in the lipid layer thickness. So in conclusion, most of the patients that we are seeing in the clinic are evaporative or mixed dry eye, and we can use the tear film wheel and comfort time after blink as a very quick diagnostic tool in the clinic to identify these patients. And lipid layer replacing or additive eye drops can really help in improving the symptoms of them. Thank you very much.
Thank you, Dr. Soham, for a wonderful talk. So we all know post-COVID era has dynamically changed our lifestyles. And what we are not seeing much of before, after COVID, now we are seeing is the pediatric dry eye.
Yes.
Because all of them are glued to the screens, the classes are online, physics wala is online, everything is online. So any tips from you, sir, and the other esteemed members, that what do you counsel the parents? Because everybody is like, class korta hobe, tuition hi korta hobe. So one thing I tell them that take printouts of the PDFs at least. That's not environmentally friendly, but at least it saves some part of the eye. Anything else?
I ask them again, so this again becomes, if you ask them to switch to a bigger screen, that might theoretically help, but that again becomes an economic burden to these patients, to the parents actually.
Yeah.
And the problem is, even after COVID, everything else has become physical, but somehow the classes, they have stuck to being online.
Yes.
So this has to be a policy level change from the government. We as doctors can only make suggestions to the government. We have to do something like what China is doing, where they're actively curbing screen use of the kids, basically. Anyone under 18, they have time limits on, especially online games. So after 10 p.m., they cannot log in. Okay. So these are like government directives. So things like that would make like major changes, I feel. Bigger screen, the comfort level is better, so that's the only thing. So when they're looking, so now blinking, it won't reduce. Just that the overall comfort is better, so that
the viewing distance also increases as the sign. So.
Yeah. So and the other thing that happens with these children is, it's beyond the scope of this. There's myopia also, faster progression of myopia.
Anything you would like to add?
See, the total screen time can be divided broadly into things which the kids have to do. Yeah. They have got these classes which they have to undergo, the tests which they have to undergo, and then there are recreational screen usage. So I think we have to divide them into absolutely necessary things which you can't do without, and things which they can give up. Like the very important point that Soham mentioned, lot of myopic epidemic which we are seeing is now being currently related to the increased screen time. So to reduce the screen time, especially the non-essential part, I think we should sort of club them together, and so that our message goes across a little bit more strongly, and maybe let them go out and play and all the other things. And also, if we can tell them that while they are using the screen, they are not blinking regularly, one important thing which helps a lot, I guess, is if they look away from the screen now and then. Because the kids are doing a lot of unnecessary net searches for things which are really not needed, and for stuff which they just put in their classwork or homework, and then 1 month later they conveniently forget about it. These are not things which are really needed, but they do this just to get some extra marks. So much of research at class 5, class 6 levels is really not needed. This can be done without. So we have to basically counsel the parents regarding the unnecessary usage of the screen time, even whether academic or non-academic. I guess it will have multifarious effects.
Yeah, so I'll begin the next talk in the session. So basically, we are all facing patients in this season. Some are perennial, some are seasonal. So just 10 pearls I have learned from my practice and some knowledge of the literature, that how do you better manage the patients of allergy presenting in your clinic. So I have no financial interest to disclose. So basically the first question you need to ask yourself is it allergy? So not all itching is allergy and not all itching is due to allergy. So basically if it is not itching in the first place, most likely than not, it is not any form of ocular allergy. But if the patient says, yes, my eyes are itchy, you have to ask them what happens when you rub your eyes. So if there is improvement after eye rubbing, most likely the etiology is dry eye or meibomian gland disorder or blepharitis rather than rather than allergy. And if the eye rubbing makes it worse, if the eyes become more itchy once you rub them, it is allergy because of the degranulation of the mast cells, which releases more histamine. Histamine in turn incites the allergy. And another quick test you can do in your clinics is basically instill 1 drop of 0.7% olopatadine and wait for a while and then ask how is the patient feeling. If the patient is saying that the itching is less than before, then you are dealing with a patient of ocular allergy. If the patient reports that no, I am feeling the same, nothing has changed, most likely you should look towards dry eye. So more often than not, we see many patients coming to the OPD with complaints of itching, but finally we realize later on that it is actually dry eye which we have been treating as ocular allergy. So and also ask where the itching is. Is it on the eye or is it on the eyelid margins or the lashes? So if it is in the eye and it is more towards the nasal canthal region, most likely the patients point it out themselves. It is ocular allergy. If it is on the eyelids or the lid margins or the lashes, maybe you are dealing with blepharitis or demodex or contact blepharoconjunctivitis. So this is most likely at what you see on the slit lamp, this stringy ropey discharge, which is a huge pointer towards allergic conjunctivitis. You invert the upper lids, you see this papillae. And if you look at the eyelid, this collarate formation is more likely pointing towards demodex and not ocular allergy. So the differentials you have to keep in mind in your history is basically dry eye disease. Infectious conjunctivitis can mimic this. Contact lens users, drug-induced blepharitis, giant papillary conjunctivitis, and mucus fissing syndrome. So more the discharge, sometimes these patients have a habit of keeping on pulling it and tugging at it, which worsens the cycle of itching. The second pearl is history, which we don't often ask, but you have to ask pointed questions, leading questions, that how long is the allergic disease for, what is the chronicity, what is the geographic location, where do they stay, do they stay in a dusty environment where they're continuously exposed, or their occupation is such that they're exposed to some dust or powders, what are the acute or the chronic and the exacerbating factors. Important history from the ENT point of view is basically rhinitis or otitis media, sinusitis, polyps, respiratory tract infections, asthma and eczema. So these we are not generally beyond the domain of ophthalmology, but we need to ask, especially in the patients with chronic allergy. Most of them will say yes to one of these questions. Allergies do run in families, so family history is important, especially asthma and eczema. Nasal salute, that they keep on rubbing the eye like this, you see a nasal crease. Are their throat or the ears itchy? So that points to combined etiology and of course contact lens users. So 75% of the patients with seasonal or perennial allergy will have some form of acute or chronic rhinitis, and more than 40 patients of rhinitis conversely will have some form of ocular allergy. So history taking is very important. Learn to classify the disease before you treat it, as that again comes from the history taking. One point to note is GPC is not a true allergic condition, but more of a hypersensitivity reaction. Still, we are including this for the sake of completeness. The environment, as I said, so basically tell the patient to avoid the triggers, dust mites, pets in the house. pollen, fungi, insects. All of them are important environmental triggers for allergy. Changing the pillowcases frequently, dusting the mattresses is extremely important in the tropical country like ours. Cold compresses are underutilized. They are extremely magical in reducing the allergic symptoms. Absolute no to eye rubbing. It is a huge risk factor for keratoconus. If they are a contact lens dependent person, try and ask them to minimize the use or switch to daily disposable if the contact lens cannot be stopped. Cooled artificial tears. So ask them to keep the tears in the fridge, and so that it gives a more soothing sensation. Fingernails is extremely important because the fingernails can accumulate certain particles which can induce allergy. So hygiene of the fingernails, and sunglasses which are not sleek but actually a little bigger in size and wrap around the eyes. The fifth pearl is basically promote the using of dual action drops, that is the antihistaminic mast cell stabilizers, which are now easily available in the market. They block both. They block the degranulation and the role of the histamine on the receptors. So they are quite rapid in onset, but they last for a longer duration and they are well tolerated. Now, the important thing here is to know when to start these drugs. So basically, if the patient has a seasonal allergy, the important thing is to start at least 2 weeks before the patient knows that this time of the year I am going to get my ocular allergy. Because once the allergy is well established, these drops do not work as well in reducing the ocular allergy. So the timing is important. Then it becomes like the drops are not working, I need to use steroids. So if the patient is aware enough that this is the month I am going to get my symptoms, so ask the patient to start the drops at least 2 weeks before the first onset of the itching. The sixth pearl is artificial tears. They are important in diluting the antigenic load, so they prevent the interaction of the antigen and the mast cells. They have a protective effect in reducing the blink microtrauma, especially in the giant papillary form. And a new molecule has come in the market which is called as ectoin. So it is now being marketed with the combination of sodium hyaluronate. It has a protective barrier. So basically it absorbs the water and forms a shell on the ocular surface which prevents the contact of the antigen. So we need more studies on this to see the actual effect of this. Now the older generation is basically just the mast cell stabilizer. These are not the dual action drops, and the NSAIDs. So earlier it was the first line therapy in allergic eye disease. It takes around 2 weeks to act, but the NSAIDs especially have a huge chance of corneal complications like melt. And now there are better and safer drugs available, so it is best to avoid this category of drops in ocular allergy. The eighth pearl is using of steroids. So they are, as we all know, they are one of the most potent anti-inflammatory agents, but usually not first line unless the presentation is severe enough at the baseline, because they have vision threatening side effects. You can give them topically, you can give them supratarsally, especially in GPC. But look at the intraocular pressure and the disc at each and every visit, as long as the patient is on the steroids. A higher potency steroid in a pulse form works much better in reducing the inflammatory burden, by which the dual action drops can take over. Even if the IOP is normal, just look at the disc each and every time. The ninth pearl is immunomodulators. We have two groups available in the market. One is the cyclosporin A, and one is the tacrolimus. Tacrolimus in India at least is available only in the ointment form. It's an off-label use, mind you. They are never the first-line agents. They are only for refractory, atopic and the vernal form of the disease, but they are important in steroid sparing. Give them 3 months at a time. Ask the patient to apply a thin layer on the upper lids. This is important because these agents are very irritating in nature. The compliance is poor, especially in pediatric patients. The application on the upper lids is working as well as applying directly on the ocular surface. And the last pearl is the role of immunotherapy. This is a separate talk by itself. It's now globally the second line of management in the role in the management of allergic conjunctivitis. It can be a subcutaneous or a sublingual form of the drug, but we need to tie up with a trained allergy specialist. The therapy lasts for 3 years, but it reduces the drug burden. I have many patients who are on this therapy, and the requirement of the drops has gone down drastically, especially steroids. They can just be maintained on artificial tears or sometimes the dual action agents. Thank you for the kind attention. Any comments from the panelists or the speakers?
It's a wonderful summarization of a very difficult topic. Just one point I will raise, Aditya, what is your take on that? The problem is, quite often we get dry eye and allergy coexisting together.
Yes, yes.
So what's your basic line of management on that?
So
how do you differentiate?
Yeah, that is the first slide which I showed you is you need to ask whether it's actually allergy. But if it is coexisting together, we have to manage both. But paradoxically, if you see long-term use of topical antihistamines or the dual action itself leads to dry eye. So that is another side effect we need to worry about. So with the imaging techniques which Dr. Soham has shown in his talks, maybe you can get a better idea of which is more, if it's the allergy or the dry eye which is causing the itching symptom, and treat accordingly. And yes, the antihistamines do cause dry eye on their own, so need to be careful with that.
And the thing is, if you get both of them coexisting together and the patient rubs, that takes care of the dry eye part or
yes.
DED part a
Yes.
little bit, but worsens the allergy.
Worsens the allergy, yes.
So the patient often doesn't understand the fine distinction between two. It's basically discomfort. So they keep on rubbing and something happens here and there, and you know the symptoms keep changing from one to another, and that's very difficult. I think in such cases where the straightforward relief we are unable to provide to the patient, I think we'll have to take a relook as whether we are missing something.
Yes. We'll move on to the next topic of the session. So Dr. Mrinmoy Das will be talking on the management of cataract after therapeutic penetrating keratoplasty.
Thank you once again, Dr. Anirban, Renuka Institute, OSWB, and Dr. Soham for including me in this presentation. So, in our day-to-day practice, we usually do a lot of therapeutic keratoplasties in non-healing corneal ulcers. But after 3 months, most of the graft failed. There are a lot of cataract surgeries, we have to do it. So in those cases, we usually do cataract surgeries along with sometimes optical PK, DSEC or DMEC. So there is a summarize and this is a summary of post-therapeutic PK cataract cases. It's a video presentation. So
In this case, therapeutic PK was done 6 months ago. Specular count of this graft was 1869. As the graft clarity was 4+, phycoemulsification with foldable oil implantation was planned with special precautions. 2 side ports and main port were made between sutures and through recipient cornea. To protect the endothelium, dispersive viscoelastics was used. Anterior capsulorhexis was difficult in these cases due to capsular fibrosis. Low parameters phaco is desirable in these type of cases. BSS plus should be used as irrigating fluid. Single piece IOL is implanted into the bag with copious viscoelastics. In most of the cases, main port and side ports suturing is required to make these wounds watertight, especially in ectatic corneas where the recipient cornea is thin and scleral rigidity is low. Piano nylon monofilament is used to suture the wounds.
You have to suture the side ports also. Otherwise, to maintain the antechamber is difficult in these cases.
This was a case of failed graft with relatively poor visibility through cornea with cataract. Therapeutic PK was done 3 months back. DSEC plus SICS plus PCIOL was planned. SICS plus PCIOL was done in usual manner. After implantation of IOL under cohesive viscoelastics with reverse Sinski and with reverse Utrata forceps, Desmet's stripping was done. Sometimes there are retrocorneal membranes also. So during removal of the Desmet's membrane, you have to remove those retrocorneal membrane also. And I am using this Utrata forceps, reverse Sinski hook and reverse Utrata forceps to remove those bits of Desmet's membrane. Thorough anterior chamber wash was done, pilocarpine injected and inferior PI was made. So usually then inferior PI was done made in this on an artificial anterior chamber. So with this dissector, I have to dissect the tissue. I have to prepare the tissue for dissect. Then manually created donor button was marked with S mark. And I am putting Hilon over there to put the graft over there. And I am using needle to introduce the graft into the anterior chamber. And injected into anterior chamber by needle technique. Air was injected and graft centration was made with external stroke with reverse Sinski. This was a case of failed graft with total cataract with relatively clear cornea. So DMEC plus phaco plus IOL was planned. Before donor preparation, phaco plus foldable lens implantation was done in usual manner. Slowly and with much difficulty, the Desmet's membrane was separated from pseudophakic donor cornea. A hole was made in donor stroma with 3 mm punch and marking was done with S mark through the hole. Then predetermined actual size graft was refined. Graft was then loaded in injector and injected intracamerally. And through the side port you have to remove those anterior chamber fluid and to make it shallow so that the graft will open. With tapping and shallowing of the anterior chamber, you have to open the graft totally. Sometimes you have to tap over the cornea. Graft unfolding and centration was done with proper technique. Air was injected to keep the graft pressed with recipient cornea. This was a case of cataract with failed scarred vascularized graft. Plan was optical PK plus open sky cataract surgery plus IOL implantation. The first donor graft was made. It was done to remove the scarred graft. Capsulotomy was done with envelope technique. Here the anterior capsule and iris was so, there is so much of synechiae that I have to cut the anterior capsule to take the nucleus out. Cataract extracted with the help of cystitome. With Simcoe cannula, cortical wash was done. So it's an open sky procedure. And I usually implant the lens after putting 6-7 sutures applied. PMMA IOL was implanted under copious viscoelastics and centration of the lens was done with ball dialer. Then suturing of the graft completed. So the take home messages are: In post-therapeutic PK cases, in clear graft, FICO can be done with BSS plus and dispersive viscoelastics. Optical PK, DSEC, DMEC can be added in failed graft. Wound suturing is required in most cases. Thank you for your patient hearing.
Thank you.
Thank you, Dr. Nirmay, for a wide variety of challenging cases. So, sir, would you like the sutures to be out first before you do the surgery?
Usually, we usually remove the sutures after 1 year. So, as it is a therapeutic PK done 3 months back, I don't usually remove all those sutures at that time, because otherwise you may put the sutures in the center and periphery, there may be wound gap. So always wait for sutures minimum 9 months to 1 year. Then you remove in 2 to 3 settings. Not all the sutures, you should not remove all the sutures at the same setting.
Dr. Bhaumik, sir. Sir, any tips for more tips, any precautions you would like to take before tackling such cases?
Any tips for Aditya, please?
Sir, to protect the endothelium. Because most of these counts, especially the therapeutic grafts, have a poor endothelial reserve. So anything extra you do?
So I think you start from the planning the surgery. If cataract is very hard, I think you should use BSS plus. This is one thing. BSS plus is much better for this situation, you know. And the viscoat, you have to use the dispersive viscoelastic, and phaco. If you had a hard cataract, you make a central catar and make a small pieces, and as many pieces you can, and to emulsify as far as possible from the endothelium, so that and keep your ultrasound in relatively low power mode, so that it is not that you can prevent the chattering. Once you can prevent the chattering, in that case I sometimes prefer to switch off the IP mode. If cataract is relatively soft, the IP mode keeps some kind of chattering. It is better to keep phaco power modulation in only Ozil mode. If you keep the Ozil mode, yes, it is not possible if cataract is very high, but it's a relatively softer cataract. You can increase little bit of Ozil mode, but you keep the IP mode off, because IP mode gives some kind of chattering. These are the things you can keep in mind, but definitely it's a very tricky situation. Even I have seen, I have sent my cases, I have did almost 2006 case, Aditya, you've seen my cases, bilateral corneal grafting. The patient that time 6 years old, and now he's past engineering. So bilateral, one day I did the bilateral grafting, and I am doing the follow-up of this patient like quite last 10 years, his count is 700, but the cornea is a crystal clear. So even in keratoplasty, your cell count will not indicate that. Even in the low cell count, it may clear even longer period than the normal cornea.
Sir, one last question. Any situation in this where you would consider SICS over phaco?
If not able to do the capsule rupture, or you cannot do the but closed chamber is better, definitely. SICS better abandon. Yeah.
Okay.
I have one question. We saw when the graft is clear, we can do a phaco. Of course, it needs a very high level of skill, and we have to be very careful about how much of damage we are doing to the structures. But when the graft is failed, we have to do a regraft of some sort, either endothelial or full thickness or whatever.
Yes.
My question was, in therapeutics, policy-wise, what is the quality of tissue that we are using?
Yes, sir. Usually in our institute, we usually use For optical PK, it should be more than 2,500.
No, not optical, for therapeutic.
For therapeutic, is less than 2,500. Means around 2,000 to 2,500. So lots of tissues they can be clear for lots of months also. Means we have seen that 5 to 6 years graft is clear, but not all. But percentage is less. But if we can start steroid early, and if the ulcer was more central, not and the graft is smaller graft, not much larger graft, so in those cases the chances of means graft survival is much more.
What I wanted to know is what's the main reason for the failure? Is it because of the poor quality of tissue that was used, or is it because of the inflammation that is associated with it?
Yes, that is both. Because yes, we most of the time we don't use those tissue which have more than 3,000 count in therapeutic PK, because we don't know that the infection will go or it will retain. We may go for another PK, so we don't want to waste those good quality tissue.
That's fine. I wanted to bring out that point. Is that
no, we can use, but always there is a scarcity of good tissues. Tissues are there. Lots of, but good tissues, scarcity of good tissues, of course, are there.
I remember one period, almost 1 year, our tissue was much more than the pending cases. That time, Som can answer there. Before Som joined this, one period, we have a lot of HCRP program, and 2-3 center HCRP in our hospital. There's a lot of good tissue, but the cases number of cases was enlisted was less. That time, if your cornea is available,
yes,
you should use best quality. And the failure of therapeutic, not the corneal problem, it is an inflammatory cascade which actually failed the cornea.
Yes,
because you should
that toxin which that means bacteria or fungus they are releasing, that can also.
Yes, for the tectonic graft you can use the old cornea, but for the therapeutic one, if possible, use best quality tissue. Because you never know that even after therapeutic, that cornea will survive next 15 years. And we have a lot of case that I did once with Pseudomonas perforated corneal ulcer, that the cornea is still good, more than 2000 count after 15, 17 years almost.
Yes, lots of cases are there, but most usually our protocol is like this.
No, agreed with Dr. Bhomik. I mean, if you have tissue, surplus tissue, use the best tissue. And sometimes it boils down to luck. Sometimes you have a good optical quality tissue which is going to expire on a certain date, and you do not have a suitable candidate, and there is a therapeutic patient coming in, you can definitely use that optical tissue for it.
That's Optizol, that the system, we can able to use good quality tissue in the therapeutic.
Yes, definitely.
Because we can keep good quality tissue at 3 to 4 weeks.
So we can keep it for 2 weeks also in cortisol.
Cortisol, yes, 15 days.
So with that, we come to the last talk of the session. So Dr. Soham can take over. So he will be talking about simplifying DALC for all. Over to you, sir.
Yeah. Good afternoon, everyone. So I'll be going very briefly over the DALC for everyone to understand, and no financial interest in this talk. So DALC, or deep anterior lamellar keratoplasty, is for corneal stromal pathologies where we have a normal DM endothelium complex, classically used for keratoconus, stromal dystrophies, and corneal scars. And the commonly used techniques are manual dissection and big bubble dissection. So brief history, it was described back in 1940s by two of the giants of cornea, Castroviejo and Barraker. And in 2004, we had one of the biggest landmarks, that is the Anwar and Tishman described the big bubble technique. And there have been multiple modifications of lamellar technique and instrumentations. And the newest thing is the technology, the femtosecond laser and intraoperative OCT. So indications very briefly, if you have anything wrong with the stroma, but there is normal or near normal DM endothelium complex, that patient is suitable for a DALC. So common examples would be something like this, keratoconus. This is a big bubble DALC for this patient, so you can hardly make out any distinction between the graft and the host. Again, a very advanced keratoconus. This is a manual DALK. If you see the anterior segment OCT, you can make out some amount of stroma of the host which is remaining. This is a case of vascularized corneal opacity with partial LSCD, and this is a manual DALK done for the same patient. This is corneal ulcer, underwent conjunctival hooding elsewhere, and eventually DALK done to get rid of that scar and that huge vascularized pannus kind of a structure. This is macular corneal dystrophy. This, sometimes if you have a good endothelial and DM anatomy, you can go for DALK, otherwise PK is indicated. This is lattice corneal dystrophy with scarring due to multiple recurrent corneal erosions. And we have short videos. So this is manual dissection. So this is case of advanced keratoconus with a lot of apical scarring. And the descent integrity was in question, so big bubble was not done. So manual dissection is basically you go layer by layer dissection. So there is a peeling technique, or what I use is a groove and dissect technique. So you usually use blunt instruments to take out layers, going as deep as possible sequentially, and we judge the depth basically based on the stromal fibers that are seen. So the pattern changes as we are going deeper, the clarity improves and the layers become more shiny. So as you can see, once the central part is removed, that shiny reflex is indication that you have reached very close to the descemes membrane, and that is a good endpoint to stop. And then it is a matter of suturing the donor tissue. So donor tissue is basically any quality. Here we are not bothered about the endothelial cell counts because we usually remove the descemented endothelium and we just suture in the graft, either interrupted or running sutures. In big bubble DALK, initially we start with the anterior stromectomy. Usually about 50 to 60% of the stroma is removed using blunt dissection techniques. So you can use lamellar dissectors or a crescent blade. So here the idea is not to go too deep. We want to remain some amount of stroma, and that would allow the introduction of a needle or a specialized big bubble cannula. So this in keratoconus can be tricky because we have got differential depths. So make sure that in the central part you have not gone too thin. This I am using a 27 gauge needle, go in and then inject air. So that is the type 1 big bubble. Then that is opened up using a side port blade, inflated with viscoelastic, and then divided into 4 or multiple petals. This should be done very carefully so as to not injure the underlying descemetes, pre-descemetes layers. Once you have achieved these petals, then using corneal scissors, those are slowly dissected out. And that gives a very clear base. So the base, in this case, it's a type 1 bubble. So what we are seeing here is actually the pre-descemetic layer. So once you have achieved a clear base, again a donor graft is sutured in. So it's basically you remove the punch and remove the DM endothelium and then suture it in. So ideal cases for big bubble DALK, conventionally keratoconus and lattice and granular dystrophy. Borderline cases would be macular dystrophy, scars and post-RK. Not ideal cases are the full thickness or previous history of eye drops. A little bit about classification. So two types, descemetic DALK where we are going till the descemetes layer and pre-descemetic DALK where some amount of stroma is left. In view of the recent Duas layer, so this is a new proposed classification. So these are the layers. In descemetic DALK, this is Sarnikola's group which have proposed the classification. We have DALK where some amount of stroma is left behind. Then there is subtotal anterior lamellar keratoplasty. So this is pre-descemetes, descemetes and endothelium. Then finally, this is a total anterior lamellar keratoplasty. So this is only descemented endothelium. Total anterior lamellar keratoplasty is not desired. So this has very high chances of perforation and technically very challenging. So what we prefer is doing a STALK or a deep keratoplasty with residual stroma less than 80 microns. So that gives good visual outcomes. Briefly between type 1 and type 2 bubble, type 1 forms between the stroma and the pre-descemetic layer. Type 2 is forming between the pre-descemetic layer and the descemetes layer. Again, this has a very high chance of perforation. Some of the specialized instruments that are used are the cannulas which for air injection. So it can either be the TAN cannula or Fogler cannula. Then we have these dissectors also which help in the dissection once we have achieved the big bubble. And then finally, the newest thing is the technology-guided DALK. So we can make really nice, predictable dissections using a femtosecond laser, or we can judge a depth on the go using an intraoperative and OCT. So some of the complications of DALK intraoperatively we can have is perforation. So once you have a perforation, you can either be rescued, or if not rescuable, then convert to PK. And the second complication is unique to DALK is a double anterior chamber, where there is a gap in between the descemetes and the host stroma. Usually this settles with air injection. Other postoperative complication is loose sutures. Graft rejection is very rare. Infections can happen. There can be high IOP due to prolonged use of steroids, cataract formation, and recurrence of primary disease. This is an unfortunate case of acute interface graft infection, and this therapeutic keratoplasty was done, which was done using an optical quality tissue, as Dr. Bhaumik was describing. And this is a lattice corneal dystrophy which recurred 5 years after the graft done, and it was treated with a phototherapeutic keratectomy. Postoperative care is similar to PK, but it's much less intense. So initially we have hired the stronger steroids and can be switched to a softer steroid by 6 months, earlier if there is IOP rise. Antibiotics for the initial till the epithelium heals up. Lubricants, anti-glaucoma as and when required, tacrolimus and cyclosporin in very selective cases. And suture removal can be done earlier in DALK, usually 9 to 12 months, and can be done in a topography guided situation so as to do some astigmatic manipulation. Visual rehabilitation can be in the form of spectacles or contact lenses. PRK can be done to reduce higher order aberrations. And eventually when a cataract forms, we can safely implant a toric lenses. So what are the advantages over PK? So visually, outcome is same. Advantages is it has got less rejection rates because there is no endothelium which is getting transplanted. Lower endothelial cell loss rates also, so that gives a longer graft survival. And since steroids can be tapered earlier, so there is less steroid complications and less IOP rise. Complications of open sky procedures are avoided. More donor tissue is available. We are not relying on certain cell count cutoffs, so more availability of tissue. We can treat a larger area without risking rejection, so that gives better control in especially the peripheral ectasia like pellucid marginal degeneration or keratoglobals, and it is more technically stable. So that is the overview basically. So for anything wrong with the stroma, you can do DALK, although technically more challenging, but there are benefits over penetrating keratoplasty. These are my references, and thank you very much.
Thank you, Dr. Soham, for simplifying a very complex surgery. So I think if there are no questions, we can hand over the session. I just call all the speakers for a quick photograph on stage.
So we'll be starting with the Peds and Neuroopthal session. We'll be having 4 talks, and they'll be of 6 minutes duration and 2 minutes discussion. We'll take the discussion and questions towards the end. I would request the panelists to take the stage. Dr. Oppala Bhattacharya ma'am, Dr. Paramita Shonatani, and Dr. Anuradha Chandra. Kindly take your seats. So I'll be giving a brief overview of the signs and symptoms in children which are not to be missed. Sometimes the guardian or the parent states that the child is not seeing the face. So we should think in terms of delayed visual maturation where the tracking behavior and the fixation patterns are delayed. This might be isolated, associated with systemic or ocular disease, or is cerebral visual impairment, in which case there is a pathology in the pathways which is posterior to the lateral geniculate body. For example, we had a patient presenting with an optic nerve hyperplasia, which usually presents with a double ring sign. In these patients, it's important to rule out other pituitary abnormalities, septic optic dysplasia, as well as an agenesis of the corpus callosum. Birth history is important to rule out any asphyxia, neonatal hypoglycemia, cerebral insult. Developmental anomaly may reveal microcephaly, hydrocephalus. An optic nerve evaluation is always important, and neuroimaging is also mandatory. In cases of doubt, we can go ahead with an electrophysiological tests like the ERG and the VP. Sometimes the child presents with the misalignment of the eyes, so it is important to note what is the direction of the deviation, whether it's inward or outward, whether it is constant or intermittent, whether it's associated with distance or near, or whether there are associated signs like nystagmus or undercorrection, underaction, overaction of the muscles. For example, we can see a photo of a child presenting with a right pseudoexotropia. This is because of a temporal dragging of the macula. In these patients, it's important to note the angle kappa. In patients with pseudoexotropia, there is a positive angle kappa. We should also note the motor and sensory evaluation and the stereopsis. Cycloplegic refraction should be done, and also a detailed anterior and posterior segment evaluation. Sometimes the parents state that the child is shaking the eyeballs. So we should always think in terms of the common causes of nystagmus, which include infantile nystagmus syndrome, visual deprivation nystagmus, or nystagmus which is secondary to the developmental anomalies like coloboma. This is a patient presenting with albinism, in which case we are seeing a depigmented fundus and foveal hyperplasia which can be detected on a macular OCT. Also in these patients, we should get an electrophysiological testing done to rule out rod cone dystrophies. Sometimes the child presents with a frequent blinking or the watery of eyes, so in which case we should rule out what could be the causes. It could be allergy, it could be constant or occasional discharge. We should note the nature of the discharge. In patients who present with allergic conjunctivitis, there may be papillae follicles, and we should also note if there's any corneal involvement there. Roplas is again mandatory to rule out if there's an NLD obstruction. My child is tilting his head. What are the things we should take care of in abnormal head posture? We should see whether there is any head tilt, whether there is any face turn, and also we should note the chin position, whether it is up or down. We can see a patient with right hypertropia, which is worsening in the left gaze and worsening in the right head tilt. This is suggestive of a right fourth nerve palsy. In these patients, it's important to note the nystagmus, the null zone, and also cycloplegic refraction should be done to rule out any astigmatism. Again, we should also note the status of the macular torsion. In case of macular intorsion, we should get the fovea which is located above the center of the optic disc. In one of the red flag signs which we should notice is subnormal acuity. In these patients, we should also think in terms of poor night vision, photophobia, like in case of the retinitis pigmentosa spectrum. Eccentric viewing, whether it is unilateral or bilateral. Unilateral in case of dense amblyopia, bilateral in case of retinal dystrophies. Positive angle kappa should be ruled out. And paradoxical pupil phenomenon, which is basically the constriction in the scotopic conditions, may be present. High refractive error again should be ruled out. Pupil evaluation is a must in kids. We should rule out the efferent pupillary anomalies. Horner syndrome, which could be because of a damage in the oculosympathetic pathway. Third nerve palsy, which again could be either congenital, traumatic, or other acquired causes are there. Light-near dissociation, which could be because of a dorsal midbrain syndrome, or also because of a lesion of cilia ganglion. Afferent pupillary anomalies should also be taken care of. Abnormal red reflex, we should think of the common causes like, for example, retinoblastoma, Coats disease in case we're getting a unilateral presentation, non-genetic predisposition, persistent fetal vasculature, and familial exudative vitreoretinopathy. Coloboma and childhood cataract should also be ruled out. When a child presents with blurred disc margins, we need to differentiate whether it is a papilledema or whether it is a pseudopapilledema. These are very difficult to understand usually, but we need to do a proper clinical assessment, rule out the signs and symptoms of raised intracranial tension, and also do an assessment of the optic nerve disc. For example, in pseudopapilledema, there is a lack of hyperemia, there is a lack of obscuration of the blood vessels, there is anomalous vascular pattern, and also there might be refractile deposits on the optic disc suggestive of optic disc drusen. You can see in the USG there is a bright spot which is again going in favor of optic disc drusen. Ancillary testing is done if in cases of doubt, like for example we can get an autofluorescence done for an optic disc drusen. Sometimes we should suspect childhood glaucoma. So in these cases the child usually presents with epiphora, blepharospasm and photophobia. A corneal inspection is very important. We should see the status of the cornea, whether there is edema present, and also sometimes the breaks in the Descemet's membrane, they are horizontal or curvilinear, known as Habs striae. Tonometry is mandatory, and even though anti-segment examination is difficult in kids, it should be done. Gonioscopy is again mandatory, and the optic nerve should be evaluated in every sequential visit, along with axial length. Kids do present with systemic disorders, so it is necessary to rule out inborn errors of metabolism, like for example cystinosis, which could present with corneal clouding, phakomatosis, the neurocutaneous syndromes, they can present with leash nodules, like in the case of neurofibromatosis, or a port wine stain in the case of Sturge-Weber syndrome. Other systemic diseases like Morphin syndrome can also present with a subluxation of the crystalline lens. Just trying to cover it up, the clinical pearls, we should spend time observing the child as soon as they enter the clinic. We should spend time taking a detailed history. We shouldn't dismiss a parent's observation without thorough examination. We can plan an examination to anesthesia, and we should not hesitate to call the child for a short follow-up to confirm the clinical findings. Thank you for your patient hearing. So, we'll take the questions later. I request Dr. Anuradha to present.
Good afternoon, everyone. Today I'm going to present on practical approach to visual loss in children. Suppose parents come to us with a 7-month-old child with poor visual behavior. So what do you mean by poor visual behavior in an infant? This is lack of eye contact, lack of social smile beyond 3.5 months of age, and if the child fails to reach out for objects or does not recognize familiar faces or objects beyond 9 to 12 months of age. So first, we have to rule out obvious structural anomaly of prenatal onset. After that, refractive error. High myopia is quite rare in infancy, but if it is present, it denotes syndromic association, retinal dystrophy, and some non-axial high myopia, such as ROP, spherophakia, and keratoconus. For these things, axial length and keratometry to be done at the initial checkup. High hyperopia is commoner than high myopia in infancy, and it should be treated promptly because it is associated with risk of deep amblyopia, strabismus, and accommodation dysfunction. Threshold for correction is more than 6 diopter without strabismus and more than 4 diopter with esotropia for less than 1 year of age. Suppose there is a child with poor vision since infancy with extreme photophobia and bilateral aniridia. What should we think of? It can be a part of WAGR syndrome, that is Wilm tumor, aniridia, genitourinary abnormalities, and mental retardation. The child will present with nystagmus, strabismus, very poor visual acuity owing to optic nerve head hyperplasia and foveal hyperplasia. Optimum refractive correction with amblyopia therapy and timely management of glaucoma, keratopathy, and cataract to be done. And whenever we come across a case of bilateral aniridia, we have to send the child for abdominal USG for Wilms tumor screening. Now, this child with poor vision, congenital nystagmus, with a tendency of constant rubbing of eyes, presence of consanguinity in parents, and when we do the fundoscopy, the fundus can be typically normal, and ERG will be severely extinguished ERG. So this is a case of Leber congenital amaurosis. And wherever possible, genetic diagnosis is required because some subtypes are associated with end-stage renal disorder. This is suppose there is a child with poor vision since infancy with nystagmus, with fundus showing loss of RP and prominence of choroidal vasculature with foveal hyperplasia in OCT. And refractive error giving mild to moderate hyperopia. So this is a case of ocular albinism. If it is present with hypopigmentation of hair and skin, it will be oculocutaneous albinism. At clinic, we have to do non-illuminated chart visual assessment for these children to avoid the effect of glare. Genetic diagnosis, again, wherever possible because of its syndromic association and some malignancy-related syndromes. Optimum refractive correction, tinted glasses, and counseling for systemic associations. Now, suppose this is a 3-year-old child, we can see that the child has not yet achieved neck control. She's being shown grating visual acuity, and there is periventricular leukomalacia in the MRI picture. So, we are talking about cerebral visual impairment. General examination and perinatal history are of utmost importance for the diagnosis of cerebral visual importance. Intrauterine infection, preterm delivery, neonatal sepsis, hypoglycemia, all these lead to hypoxic damage to the frontal and parieto-occipital cortex, which will lead to dysfunction of the ventral and dorsal system of vision pathway. In refraction, generally they are myopic, but hypermetropia with accommodation dysfunction is present in cerebral palsy children. An assessment in them should include grating visual acuity and not the vernal visual acuity. Perception of color, ability to see contrast, and central visual field assessment, and also to look for the field in which the child has better vision, because this will help us to do the visual stimulation therapy. Along with visual stimulation therapy, additional therapy of speech, occupational, and physical rehabilitation. Now coming to a child with acute visual impairment. After ruling out the history of epilepsy, headache, and viral infection, and initial visual and ophthalmologic fundus evaluation, MRI brain and orbit with contrast is the investigation of choice, along with VEP, EEG as the case demands. Now, if there is inconspicuous MRI and other evaluations, we should think about psychogenic visual loss. However, important differential along with this is a chronic inflammatory disease where the initial MRI can be inconspicuous, especially in female child with recurrences. And if we go through the differentials of pediatric patients with sudden vision impairment, we will see infectious causes are the most common one. Now, how can infections cause visual loss in children? It is either by a post-infectious optic neuritis or by meningoencephalitis and encephalitis. So, optic neuritis can be infectious or demyelinating in children. Preceding viral etiology, most commonly sphenoidal sinusitis. Normally, this is bilateral with a female preponderance. They usually have a better prognosis, except there is NMO association. Risk of MS is more if there is sequential or recurrent optic neuritis or demyelination is present outside visual, anterior visual pathway in the MRI. Idiopathic autoimmune picture is seen mostly in the female children with more than 7 years of age, and long-term follow-up is important in them. Neoplasia of the anterior visual pathway or posterior fossa tumor, which can increase the intracranial tension and thereby cause optic nerve compression and vision loss. IIH, how is it different in children is that in pre-pubertal age group, males are commonly affected. In post-pubertal age group, obese females are affected. Diplopia, headache, and transient visual obscuration can be found in elder children. And one most important thing in children is to we have to rule out underlying endocrine conditions such as Cushing disease, etc. and possible iatrogenic causes like vitamin A therapy, withdrawal from chronic steroid use has been done or not. One clinical confounder here is optic nerve head drusen, which should be differentiated by EDI OCT, USG-B scan, and fundus autofluorescence. Coming more into the differentials, epileptic visual loss can occur with occipital epileptic discharges. These are acute episodes of visual blurring. Fully reversible monoocular visual disturbance can occur with migraine type headache, and some drug-induced optic neuropathy we always have to remember, which are anticholinergics, antibiotics such as linezolid, and immunomodulators such as cyclosporin and tacrolimus. And lastly, not to be missed, psychogenic visual loss in school-going children. After ruling out all the differentials, some quick subjective tests in clinics such as eye contact, room with obstacle, showing the child mirror and moving the mirror vertically and horizontally, and to see whether the child moves his eyes with the mirror or not, then at least hand movement vision is present. So to conclude, detailed perinatal parental and systemic features evaluation with developmental milestones needed for infants with subnormal visual behavior, acute onset vision loss in young children, important to rule out infectious etiology. For school-going children, functional visual loss to be investigated once all the organic causes have been ruled out. Thank you.
Good afternoon, everyone. I would like to thank OSWB and Renuka Institute for giving me the opportunity to talk this morning. This will be a case-based presentation on practical approach to diplopia in children with a few words on why is it different from adults. So pediatric visual pathway is immature and it has the ability to selectively exclude any unwanted visual impulse. So any abnormal binocular interaction will lead to suppression. Further, children may often be unable to express or appreciate the diplopia, and they need thorough systemic evaluation to exclude any life-threatening conditions. The common causes include refractive error, uncorrected vision, anisometropia can cause such diplopia and confusion. Strabismus or misaligned eyes, cranial nerve palsies usually acquired due to viral infections. Trauma to the eye causing any structural change. Trauma to the orbit or brain causing compressive neuropathy or muscle entrapment, muscle weakness. Ocular myasthenia gravis should not be underestimated in children as a cause for diplopia. Congenital conditions like DRS, MED, and Brown's may present with diplopia in a specific gaze or due to decompensation later in life. Intraorbital or intracranial tumors, neurological conditions like meningitis and encephalitis are also known to cause diplopia. Such a case needs a detailed history with age, onset, duration, any preceding history, complete ophthalmic assessment, the type of diplopia, whether it is horizontal or vertical, whether it is crossed or uncrossed. Imaging and systemic evaluation wherever it is necessary. The treatment options include glasses, orthoptics, vision therapy, prisms, Botox, and surgical intervention. So the first case is a child with uncorrected visual acuity 6/36 both eye, and we see there is an astigmatic refractive error. This child was given glasses and the vision improves, her diplopia resolves. So children may sometimes appreciate the decreased vision due to high refractive error as diplopia. Next case is that of a boy with sudden onset squinting since 2 months. There is no preceding history for fever, trauma, headache. Uncorrected visual acuity both eye is less. There is hypermetropic refractive error with a large angle squinting. This child is given full cycloplegic correction, the vision improves and the diplopia resolves and the child becomes ortho. So this is a case of refractive accommodative esotropia. Moving on with the sudden presentations, there is a boy with sudden onset diplopia and squinting since 1 year with a preceding history of fever. The photograph shows that there is a large angle deviation and there is a right face turn. Since this was acute onset, we advised neuroimaging and we found that there were certain lesions at the thalamus and cerebral peduncle. Systemic evaluation reveals hyperpigmented patches and plexiform neurofibroma over the neck. Slit lamp examination had shown lesion nodule. So this is a case of acute esotropia in neurofibromatosis type 1. Since the angle of deviation was stable and the history was more than 1 year, we took him up for surgery and he's doing well post-operatively. So AACE or the acute acquired comitant esotropia can have neurological associations and need systemic and neuroimaging. Now going ahead with the acute presentation, another case where there is sudden onset squinting and diplopia since 3 months. If we see there is limited abduction in the left eye. This is a case of suspected 6th nerve palsy. And these cases, neuroimaging is must to rule out any neoplasm or secondary cause for raised ICT causing such a picture or an intraorbital pathology which is causing the limitation of movement. These cases will usually require surgical intervention once the angle has become stable when the neuroimaging is clear, usually about 6 months after onset. When there is limitation of abduction, we also need to look for narrowing of palpebral fissure in adduction, widening in abduction, any associated upshoot or downshoot or globe retraction in adduction, because these cases are that for the DRS. So this is a congenital condition where there will be such a picture. Clinical diagnosis more than neuroimaging is what we rely on. These children will adopt an AHP. They will appreciate diplopia when they are looking towards the direction of the limited eye movement. The aim of surgery is never to correct the limited eye movement. It is basically to improve the AHP and any squinting in primary. Intermittent exotropia is a very common presentation in our clinics wherein the child may complain of on and off doubling of images. These cases do very well with orthoptics and vision therapy. Now when there is exotropia and diplopia, we always need to keep the third nerve palsy in mind. These cases, we will need surgical intervention to correct the diplopia as well as improve the alignment. The limited movement will, however, persist. Neuroimaging prior to any surgical intervention is important to rule out neoplasm or intraorbital pathology causing such limitation. Now this 9-case photograph is showing a left hypertropia. There is a significant abnormal head posture, and on measurements, the left hypertropia was worse in the right gaze and better in the right head tilt. So we are dealing with fourth nerve palsy. So this, if congenital, you may have facial asymmetry. Usually they will not complain of diplopia unless later in life where there is decompensation. Traumatic acquired SOPs are also known. They will require surgical intervention. Again, we usually wait for 6 months before proceeding for surgery. Other causes for the vertical diplopia can be acquired MED, acquired Brown's, or any vertical muscle palsy, wherein the Park 3-step test helps to diagnose which muscle is affected. A few words on myasthenia gravis in children. This should not be underestimated. Though it is a rare presentation in our scenario, the pre and the post ice pack test, we can see that there is a significant improvement in elevation of the eyelid. Variability of ptosis and diplopia are the pointers. However, very small children, it may be difficult to do the diplopia test or the fatigue test. The child may not look at you, may look in some other direction, have chin up and down for us to appreciate the diplopia. Here we need to rely upon the history of sudden onset drooping, more towards the evening. We need to do a thyroid profile to rule out any associated anomaly. The receptors, antibodies, AChR receptor antibody is the most common. A CT scan to rule out thymoma is important. Pediatric neurologist has to be roped in. They usually do well with short course steroids or the pyridostigmine. So the takeaways, first and foremost, we correct any refractive error. We look for anisometropia. If there is high anisometropia, high ametropia, we can even give a trial of contact lenses. Now for the diplopia, if it is horizontal, we see if it is an ET or XT. If there is esotropia, we keep the refractive accommodative esotropia, the AAC and the 6th nerve palsy in mind. If there is exotropia, we keep in mind the intermittent exotropia, 3rd nerve palsy, any orbital tumor or trauma causing entrapment. If it is a vertical diplopia, 4th nerve palsy, acquired MED, acquired Brown's, any inferior rectus entrapment after trauma should be kept in mind. The prevalence of OMG is on the rise after the pandemic. Those studies are still ongoing because there may be associated antibodies leading to such a condition. And a thorough systemic evaluation and neuroimaging to rule out any underlying pathology needs to be emphasized. Thank you.
Good afternoon, everyone. Thank you, OSWB and Renuka Eye Institute for this opportunity. Today I'm talking about unmasking the maze of neuro-ophthalmology for optometry students. So neuro-ophthalmology is a challenging topic to teach optometry students. For teachers to find simpler ways of teaching these complex topics was an extremely uphill task. While teaching neuro-ophthalmology, my students often gave a common refrain, but these topics are so difficult to understand, ma'am. My students were crying out for help. I had to try something. So the purpose of this study was to see if a novel technique of teaching supranuclear gaze palsies, or SGPs, especially horizontal gaze palsies with simple flow diagrams, improve learning in optometry students. Materials and methods, a single-center retrospective study. SGPs was taught in the standard way from the textbook and a written test taken. and were then again taught by the same tutor to the same group with the additional aid of some simple flow diagrams, and then a written test taken again. The data was then reviewed and assessed. According to the standard method of teaching in horizontal gaze palsy, there is a lesion of the horizontal gaze center in the PPRF. This causes an ipsilateral gaze palsy with an inability to look in the direction of the lesion. But in the novel method of teaching, which is more interesting and easier to understand, we see a lesion of the horizontal gaze center in the PPRF leads to an ipsilateral horizontal gaze palsy and an inability to look in the direction of the lesion. Standard method, internuclear ophthalmoplegia, lesion in the MLF, straight eyes in the primary position, defective adduction of the eye on the side of the lesion, and nystagmus of the contralateral eye on abduction. But in the novel method, a lesion of the MLF marked with the yellow X leads to an ipsilateral third nerve nucleus which malfunctions. That causes defective ipsilateral adduction and also affects the contralateral sixth nerve nucleus, leading to defective contralateral abduction. Results. Simple mean comparisons on the average test scores in the two exam treatment conditions were conducted. A one-tailed t-test revealed that these students scored significantly higher in their exams after this novel teaching technique. The p-value is much lower than 0.01, indicating that the results are significant at 99%. This study shows a statistical superiority of using this novel method of teaching horizontal gaze palsies over a standard didactic method where p is less than 0.001. Students also mentioned a subjective improvement in understanding the topic after the novel teaching technique. They could now independently work out the clinical deficits in different gaze center lesions from the diagrams without having to resort to rote learning. This study compared two teaching methods, the standard didactic method and a modified novel method for teaching horizontal gaze palsies to optometry students. Despite studies on new teaching strategies, practical methods to improve the teaching experience are not common. Teachers need specific and practical methods to help them improve their teaching. Novel ways of teaching are now coming to the forefront. Educators introducing new teaching methodology must evaluate the outcome of these experiences. Study limitation, improvement in test scores may be due to reinforcement of teaching. However, the feedback of subjective improvement suggests otherwise. Visual learning is one of 5 main types of learning styles: visual, auditory, reading, writing, kinesthetic or the VARC model, and multimodal. There are many advantages of visual aids. They help store information longer, make communication quicker and simpler, aid better comprehension, act as stimulators for emotions, drive motivation, and suitable visuals equal happy learners. So my conclusions on teaching methods: didactic lectures alone are no longer adequate for training. Simple practical techniques must also be considered and incorporated. Novel practical methods should shorten the learning curve. My study gives an insight into the fact that this simple novel technique should be used to teach neuro-ophthalmology. It could also be adapted to teach other topics. These are my references. Thank you.
Any comments from our panelists?
We're running late, so I don't want to say too much. I just want to say that when we're dealing with pediatric, and especially pediatric neuro-ophthalmology, history taking is so important. Nowadays, with people who are dealing with cataracts and we have this trend of the optometrist taking the history, and then the patient comes in, and you just look at them and let them go. But with pediatrics, this just doesn't work. You have to take a very good history, the birth history, because it points to so much more. And what you said about not ignoring what the parents say, that is also so important. They can say simple things like, the child doesn't see in the dark. That points to, you think about RP. They might say things like they're walking down and they trip over their toys, and maybe that's a CVI and they've got an inferior visual loss. So it's so important to take the history very well, both from the parents as well as from the child, which is often an indicator to psychogenic visual loss. So history, I think.
The continuation of Paramita's talk on history. The history is important very much. Few cases I have come across where a child has brought to me with sudden drooping of the eye along with the diplopia. So history of fever, that is very important, because the sudden viral fever of 1 or 2 days can cause viral mononeuritis, that is the third nerve palsy. And these are the cases which you can confuse with the case of myasthenia gravis in children. This is one thing. And you will see after giving, either doing nothing, or if you put the child on oral steroid, low dose oral steroid, then the child becomes okay within a week or 1 or 2 weeks. That is one. Another thing is that regarding someone, Anuradha, ocular, that is the rubbing of the eyes. Many times you will see in the clinic a child is coming with a very much rubbing the eyes. So this is a condition known as the ocular digital syndrome. Ocular digital syndrome can occur in many conditions where there is dimness of the vision or poor vision. Like it can be in a case of tendinopathy of prematurity, a case of Nuri's disease, or many other conditions. Bilateral, even bilateral congenital cataract also. A child was brought to me at the age of 9 years old with bilateral congenital cataract. The sign is that one is that the child is rubbing too much, another is that there is an ophthalmos. Because of the too much of rubbing, it causes atrophy of the fat, and there is enophthalmos. So these are the things you have to just look at the child and come to, because most of the things you have to observe.
Yes, Chandorinde, I was going to mention that you need to spend some time with the child. Thank you very much for your comments.
Okay, I wanted to add something. Here, Tulikadi.
Sorry.
Okay. First thing is that, like in the first presentation, it was shown the symptoms and signs, like symptoms, the mother or the parents, they are coming with the symptoms. But the problem is that in pediatric ophthalmology, there are lots of cases where there is no symptoms at all, because the child cannot say that my vision is abnormal. So a routine checkup at around 2 to 3 years is very important, because like astigmatism and hypermetropia, they get undetected. They go undetected for this reason. And another thing that Stuti mentioned, that's diplopia. That is also another problem. Small children, then they cannot perceive or tell diplopia. And the suppression is much more commoner in children. That is also a problem. And like Tulikadi, your teaching method, that is very impressive, because yes, didactic lecture is not at all working nowadays, and the students are not also interested. What we do in paramedical students, they come in small groups, na? So we also go for small group discussions. That is much more convenient useful for them also. They can ask the questions, and we can also deliver whatever their points they need to be clarified and all.
Absolutely.
So small group discussions are always better. And if it is interactive, then it has some effect on the students.
Yes.
Otherwise, didactic lecture will never teach neuroophthalmology, not even in PGs.
No, first I had to understand it. So I was drawing the diagrams to understand myself.
We also get confused during teaching.
Yeah. So I drew the diagrams for myself. And then I thought, okay, I can use this as a teaching aid. Yeah. And it worked.
Thank you.
So
I will also try this method.
Thank you.
Thank you.
The retina session will be starting soon. It will be moderated by Shudiptu sir.
Very good afternoon. So we'll come to the retina and EVR session now. So I think we are 20 minutes late. So just to start with, we have our esteemed panel with us. I think Dr. Debashish Das, Dr. Debashish Boiragi, Dr. Amitav Kumar, Dr. Debmallo Das. I think 4 of you want to come up? You want to come in front? Okay, so anyway, we'll start this retina session. I'll be delivering the first talk, and then we'll have very important 5 presentations. I thank OSWB as well as Renuka Institute for this opportunity. So as we are talking more on lens, the intraocular lenses, the anterior segment surgeries, so where from posterior segment approach, I just thought of probably we have a topic of this, every eye deserves a lens. So there are few of the video presentations where we have struggled, or sometimes we have not been able to do benefit in the beginning, but we have done something after that. So I don't have any financial interest in this. So we have these missing lenses because of compromised anterior and posterior capsular integrity in case of trauma, zonular weakness in syndromes, ectopia lentis, in pseudoexfoliation, complicated cataract surgery. And sometimes we need to remove the intraocular lens when you have complications due to ACIOL, iris claw, dropped bag IOL complex, and sometimes in some unusual circumstances. So when we have this managing this missing lens with intraocular lens, sometimes we have a good endocapsular placement which is possible. So this is one of our patients where there was a gross subluxation, and Sione's ring was planned in this patient. So where we put the iris hooks, and then the capsular, and you can see the Sione's inside and fixing the Sione's in the sclera. So it's always better to put the sutures in the Sione's first and then fix the Sione's outside the sclera and then put the intraocular lens in the bag. So these are a few conditions where intraocular lens management can be done very nicely by anterior segment surgeon, but when endocapsular placement is not possible. So this is one of, these are the conditions where you have IOL, you have to put in the sulcus or fix it with the sclera with or without sutures. Can be sutured esophageal, scleral tucking, flanges, intraocular lens, eyelets. So we have multiple techniques for that, and fixation to the iris by suturing or iris claw. I'm not going into the detail of anterior chamber intraocular lenses. So this is one case where you have a nucleus removal and IOL placement in the sulcus in a patient of nucleus drop. So this vitrectomy is very important. So from VR surgeons, definitely we don't usually give IVT in the anterior segment. But for anterior segment surgeons, if you are confident enough to already you have removed the nucleus, probably in IVT in the anterior segment is very important before you put the lens in the sulcus. You can do an optic catch and whatever you're comfortable enough. But a 3-piece lens or a rigid lens is very important to put in the sulcus, not a foldable lens. So this was a 3-piece. I usually prefer to put AR40 in the sulcus. Then you finish off the vitrectomy. This is a dropped intraocular lens which was placed in the sulcus. This is a rigid lens already dropped. So we thought anyway if DBR is okay and we have the previous records of these patients, probably we can just put that. So first you have to bring the rigid lens in the anterior chamber. Then you can dilate the pupil, you can put iris hooks or other artificial techniques and then put the lens in the sulcus. In case of a drop, IOL drop, where you don't have a sulcus, you don't have a bag, so you plan a normal conventional scleral fixating intraocular lens by making scleral flaps in temporal quadrants and then do a typical suture technique. This is one with the esophageal eyelets is being put with sutures. What I wanted to highlight here that previously we used to put 10O proline in these patients, but because of long-term degradation of these sutures, I prefer to put 9-0 proline instead of 10O now to fix this scleral fixating intraocular lens. This is one thing that we have to tie from, we have to pull and tie from both sides to have a well centration of the intraocular lens. This was the IOL flanges, the Amenes technique, which I do quite often in patients where you have a, you don't have a bag. So this is, I follow a 2 millimeter technique. So I use a 27 gauge needle, 2 millimeter intrascleral flap, and then it goes inside. So you have intrascleral pathway for the haptic. You feed the needle with the leading haptic, you bring it out, and assistant has to hold this haptic very carefully while you deal with the trailing haptic. So similar technique from the other side. You pull it out. I usually put a battery cautery to make the bulb in the intraocular lens haptic, but presently I'm doing with endo laser, and it has very good results. I'll show you one of our patients. This is the right side. You can see this is almost 4 years. I did Yamenase in both eyes. After 4 years, nice intrascleral flanges, small green dots. And this was mild protruded intrascleral flange. Patient didn't have any complaint though. So after 4 years of Yamenase. So this was a patient who had a SFIL drop. So these were done 10 years back. And you can see, if you depress, you can see the free edge of the SFIL. And there's an islet we can see. So there I prefer to do a lasso. So we actually do a similar technique of SFIL, except you pass on the suture, you make a lasso, you enter the lasso inside the vitreous cavity. So now you have a lasso loop here. And this is the free, the open haptic of the SFIL. So what I try to do, I put one on lasso on one side of the eyelet and the other one on the other side of the eyelet. And then you pull it up. So you have a nice fixation to the eyelet. And once it is fixed, you just pull up to fix the SFIL. One point that the other end also can open up. So you have to be a little careful and you have to check whether the other end is doing nicely. Otherwise, you can do a redo of this whole technique. This is a PMMA IOL refixation I did long back. When you have this, one side of the sulcus is not really good. So I tried to fix it in the iris. It's just like a iris tucking, where I pass the suture through the iris as well as the haptic. And this side was in the sulcus. And once it is done, you just bring out the suture and tie a knot outside and then pass it over the iris. So you have a 1-point fixation to the iris, otherwise patient remains absolutely stable. So this is iris claw. This video, I thank Dr. Anirudh Maiti for this video. I usually don't do much of iris claw. So this is one technique which is very short procedure, very helpful in camp setting, and does give excellent results in very good hands. Only thing is that this enclaving of the iris claw is very important. You tuck it in the mid periphery of the iris, so it doesn't bother of dilatation. Dilatation usually is good. I think Sangeeta also can add to this technique. And very nice entration. Very small procedure, 10 minutes, done. So this is a SFIL with Gore-Tex. This I've just kept it because for anterior segment surgeons, this is a very good technique. You have to just be a little used to putting trocars in eyes. Here the Gore-Tex is being used for cardiac surgery. So this Gore-Tex suture actually is very effective and very easy. You just put the loop outside in the lens, cut both the ends. So this is, cut both the ends, sorry. And then we put a 4 into 2 millimeter flap, put the 25 gauge cannulas, and then take a intraocular forceps to bring out the suture from both sides. So you bring out from both ends here, and then simultaneously both ends from other side. Remove the cannulas and tie the knot inside the scleral flap. Very easy technique and very stable lens. Only issues, there are few reports of inflammation with this Gore-Tex. So these are not being published yet. So, but otherwise this is a very good technique. Very easy to handle, and the sutures are so clearly visible, very less possibilities of entanglement also. You cut the knot, so it's beneath the scleral flap and very centered intraocular lens. So just one point of caution, don't be mad to put a lens. So this is a very interesting case, look very carefully. So you can see a very nicely put lens, pseudophakic retinal detachment we thought of, but once doing surgery, the IOL was not moving, it was not very stable. There is nucleus matter inside the retina, subretinal nuclear matter. I thank Dr. Krishnendu Nondi for sharing this video. You can see very nicely centered lens, but if you see carefully, the lens actually was a flex, C-flex, what you used to see, a looped haptic. So patient was operated not in this country also. So this patient, when he came back, this was the condition. You can see the intraocular lens, a C-flex lens, which was cut. And the haptic was folded, one up over the iris and one beneath the iris to fix like a iris claw. So this is a foldable lens, but you can see that. Nice technique, but probably not to be followed. And that's why I've written, not to be mad to put a lens while you have such a big problem inside. So there are new advances. I'll not go into details. And just to have this PPV and base streaming a must before sutured, non-sutured SFIL. Definitive learning curve is there, but stability is much better with the sutured intraocular lens. Inexpensive SFIL in this part of the world, it's not very expensive. It comes around $400 and $500. Newer sutures and flaps gives an edge over the iris fixated technique. And 3-piece foldable intraocular lens are the game changer, but can't be too adventurous to compromise long-term visual outcomes. And sutured SFIL is advantageous in high myopes as well as sclerocorneal scar. Thank you so much. These are my acknowledgements. Thank you. So I think we take one question from the panel and then we'll go with the next talk.
I was just asking, what is the advantage of this 9-0 proline, 9-0 suture over your 10-0?
So that SFIL lasso what I showed was a 10-0 proline done 10 years back. So I'm getting a lot of SFILs where the sutures are getting degraded and now they're coming with a dropped SFIL, which were done maybe in 2014-15. So it started around 8 to 10 we are getting degradation. So I've changed it to 9-0 proline.
And this Gotex is harvested from goat intestine, is it?
Gotex is it's an artificial suture, sir.
These are artificial
suture,
synthetic ones.
Artificial suture, non-absorbable.
But it looks so thick, no?
It looks thick. It's thick. It's thick.
But it's not.
It's for vascular surgery. It
doesn't have an antigenic property.
No.
Okay.
But there are few, I think, reports not published yet. But it's a very easy technique for anterior segment surgeons also. Because SFIL, sutured SFIL and Gore-Tex, if you tell, just you have to put cannulas. Otherwise, it's very easy.
So the one problem with Gore-Tex is that now we are seeing it, because many people tend to do it now, is that it is getting exposure. A lot of patients come with Gore-Tex exposure and you have to put scleral patch.
And flaps, initial part also, yes, it depends upon a lot on the scleral flap thickness.
Good presentation.
Well, for
such should foreign body sensation not disturb the patient?
Actually, sir, it depends upon the scleral flap, because your suture is going beneath the flap. As a pocket, the suture will be inside. But there at Demallo showed that there are few instances where the flap is thin and it is getting exposed because it's relatively thicker compared to a 9-0 proline.
And Sultan, do you have any experience with CMT flex? Because nowadays we are doing.
No. Sir, actually, I have done once. I don't have the video. Okay. Only thing is that I'm still not convinced about pulling it out because there are instances of breaking of the eye. But I think in experience, just like iris claw, if you have done, definitely you can share.
It's a nice lens and it takes less time.
Very stable, very stable.
And I believe I have done a lot of cases, but I believe the glued IOL is the best one. I mean, you can.
Yes, Yamane's when a flap technique. Yeah, it was there. It was mentioned. I have not put a video.
And thanks to PECO, because in most of the cases we get a good rim. So first of all, you have to check the rim, and if it is possible, you should implant multi-piece IOL over the rim. That is the best.
But CMT lenses you don't get below 14 till now.
Sir?
Below 14 diopter you don't get.
So then you have to put these other lenses. So I think we'll go ahead with the next presentation. We have Dr. Sangeeta Roy. So she'll be having a very interesting case of cataract in iridophondral columoma from the perspective of a VR surgeon. So we have very excellent anterior segment surgeons here. And let Sangeeta present the case.
Good afternoon, everyone. Thank you, OSWB and Dr. Anirban for inviting me. Now, why being a retina surgeon am I presenting a cataract surgery? Because this is a specific case where the VR surgeons, they face a lot of difficulties managing the posterior segment. What are the difficulties that we mainly face while doing a posterior segment surgery in iridophondral colomas? The PVD induction is very difficult. It is, the PVD is very tightly stuck with the retina and it is very difficult to induce the PVD. There are many, whenever we do retina surgeries in drop nucleus, there are always chances of retinal detachment. Come what may, there is always a chance of retinal detachment. In these cases, there are more risk of retinal detachment because PVD induction is very difficult and there are pre-existing breaks also, especially at the intercalary membrane part, there are pre-existing breaks. And it is very difficult to rehabilitate these patients because it is very difficult to do, because of the coloboma part, it is very difficult to do biometry or any kind of rehabilitation in these patients. So my case is a 45 years old male patient presenting with diminution of vision in both eyes. Right eye vision was PL positive, PR inaccurate, and left eye was hand movement close to face, and PR accurate in all the quadrants. On examination, both the eyes, patient has both eye type 1 fundal coloboma according to the Idamann's classification. Right eye already had a dropped nucleus, but since the PR was inaccurate, I didn't take up that eye. And left eye had a grade 4 nuclear sclerosis, and with this kind of eye, he has done a BSc, he was taking tuitions for science students, he was doing a very normal kind of life. And this patient went to multiple surgeons for left eye cataract surgery, but he was refused by multiple cataract surgeons because of the difficulties of to be faced during the cataract surgery. So this is a small video of the surgery. So this is how the patient presented to me. Inferiorly, there were few zonules, but mostly there was an inferior subluxation, so I tried to dilate the eye with the help of iris hooks. And then the lens was not very stable, so I was going step by step, that if I could do the rexes, then I will go to the next step. I was not thinking much about this case. So I could manage a very small rexus. As you can see, bits by bits, I could manage a very small rexus. It was not at all an ideal rexus. And I'll just fast forward very quick. And I did a very mild hydrodissection because I didn't want to put too much of force. I didn't want any drop in this patient because I know, being a VR surgeon, it is so difficult to manage drops in these cases. And then I tried to fix the inferior bag with the help of a capsular hook. This is a very good instrument. This gives very good stability to the bag. And before that, I had already tried a little bit of phaco. I tried to do it without putting this hook, but then I realized that it was not possible. And then very slowly with low parameters, I started my surgery. And as you can see, I was going very slow. I was not putting full force. I was not putting full vacuum, anything. So slowly I could take out the whole nucleus bits by bits. It took a lot of time, but I could take it out. This I was a little bit afraid of surge because this was almost the last piece, because I was thinking if the whole back comes out, then so luckily the nucleus came out without any rent. The subluxation was, the bag was still, I was still feeling that the bag was unstable. Then slowly I did the IE, I removed the cortical matter. Here also my parameters were very low. I'll just fast forward a little bit. After clearing there was a little bit of cortical matter left, but still I put my CTR in place. As you can see, while I was trying to put my CTR, the whole bag was moving. Now at this point I was totally stuck. I didn't know what to do, whether to put multi-piece, whether to put single piece. Dr. Siddhartha has left, but I called Dr. Siddhartha inside the OT, and then we discussed and we planned to put a multi-piece lens in this case. As you can see, the first, leading haptic went inside the bag, but at that moment there was a jerk and I could not go inside with the trailing haptic, and the trailing haptic, when I tried to put it inside the bag, it didn't go inside the bag. because of my small rhexis, and I left it in the sulcus. I didn't want to do much because twice I tried to put it in the bag and the whole bag was moving, so I left it like that, removed the iris hooks, and then closed the case. So this is how it looked at the end of the surgery. It is not a perfect surgery, but at least I avoided any retinal complications. So what I feel is it should be done early. We should not wait till this stage for a cataract with idofundal coloboma. It should be done at early stages, because what happens is if you see a nuclear sclerosis grade 2, but when you go inside, the cataracts are relatively harder than what they look clinically. So we should go early, and it should always be done under a VR backup like we do posterior polar cataracts, and preferably, not always it is possible, but preferably the patient should not be left effacing these patients. If you ask me what will be my preference of lens, if the bag support is not there, if the sulcus is not there, then I would go for a scleral fixated lens. No other type of lens I would prefer. So those were my take-home messages. Thank you so much for listening.
Thank you, Sangeeta. I think, Sangeeta, just one query. You started, when you took up this case, with a probable SFIL backup, right?
Yes.
So it was referred in that way, that
yes, everything
probably you will need a SFIL.
No, it was referred to me for cataract surgery only.
Okay.
It was referred because and it was referred by an anterior segment surgeon only. He didn't want to take up the case. He wanted me to do the case under VR. I was the VR backup also.
Okay. So any comment from the panel?
Vision was hand movement before the surgery, and after that his best corrected vision is 6/60, and that is the maximum vision that he can get. He is mobile now.
Definitely an improvement.
He is 6/60, and near is N12. What I am scared about this patient is, I am just scared about the progression of the bag. I have fixed the bag, but I'm just scared whether if it progresses and if the whole bag and CTR complex, if it drops. So I was just thinking whether it would have been better had I put a CME ring at that time.
So
I was not sure whether it is going to stay or not, sir. I was in doubts, actually. Yes.
And CTR was in place, yes.
CTR ring in place. Actually, the leading haptics of multi-piece can break the capsule sometimes.
Yes.
Because
but
chamber
this
is
was
shallow.
no financial interest, but this was Alcon multi-piece, and I am more comfortable with that lens. I feel that the haptics are more pliable than the other multi-piece lenses.
But your space is very narrow in
yes, definitely.
Size,
because of small rhexis, the place is narrow. Here, I was totally stuck about what to put. So I called Dr. Siddhartha inside, and then I was not sure.
Single piece.
Yeah.
One last one. Dimmalu, you wanted to ask?
Some piece goes down.
Nuclear space goes down.
Yes, yes.
And once it goes down, you have to convert it to
I had to convert.
I think
in
that
fact,
was initially that Sangeeta was handling.
I was all prepared for everything,
no, so
actually.
Everything is done. The lens is put. Sometimes that one of the nuclear matter goes in while the chattering happens.
No, I was very, I was prepared for all those things, but what I did was I did a very slow phaco. I never put the full vacuum or full, so that there is less chattering. I was doing it under OSWB, so there was not much of chattering and all. But yes, that's a possibility. In fact, vitreous came from that part. So I did a localized vitrectomy also in that part.
Okay, nice, Sangeeta, very nice presentation. We'll go it with the next talk by the Shoma Mondal. Shoma, it's written coloboma RD. But he had managed a complicated cataract surgery beautifully. So I thought it's better we'll go with that and then take home messages from that. Shomo, please.
So very good afternoon all of you. Thank you OSWB, Dr. Anirban and Renuka Eye Hospital for inviting me for this talk. In the last moment I have just changed my topic. So this story goes like this. A 65-year-old gentleman has suffered a grossly mismanaged cataract surgery. So when he came, when he came to me, the situation was like this. There was a badly placed ACIOL with uneven scleral tunnel, and the torn retina margin was seen behind the pupil. And to add a cherry on the top of the cake, there was a 360-degree hemorrhagic CD, and retina looked like something like this, very hazy. So by seeing this scene, I thought I should run away from this case. But after that, I thought that the duty of ear surgeon is to think of go for the last. So this is the Mission Impossible Save the Eye project started. So first of all, I explanted the ACI well, and there was a very badly made stellar tunnel. So after that, I secured the wound with multiple sutures. There was severe hypotony of the globe with almost undetectable IOP, zero IOP. So I had to put multiple sutures, and AC maintainer was put. I thought I should enter the globe with a limbal incision because pars plana port will invariably goes into the subretinal choroidal place. So after I could manage some amount of vitrectomy, there was crumpled retina with almost no area to work. So I put a PFCL, but the PFCL was coming out of the eye, and you could see some part of the disc and the hemorrhagic CDs in the posterior pole. So I thought I could try to do some CD drainage, but the globe was so hypotonous, it's very difficult to enter the globe with the trocar. So at last I managed to enter the globe with the trocar, with resulting in some amount of CD drainage. So the blood clots are coming. Resulting in some opening of the globe with visibility of the disc. So I was very hopeful, and I tried this thing in the other quadrants also. So after multiple CD drainage, the globe was some working space was there. So I put some PFCL, and I thought I should abort this case for now to give some time to heal, and I gave systemic prednisolone. Now after 7 days, the retina looked more physiological. What I started like this, it was after 7 days, and after 2 weeks, the retina was more opened with PFCL in situ. I kept the PFCL inside the eye, and this was the second surgery after 2 weeks. I could manage to do a proper vitrectomy with PVD induction. So more PFCL was given to stabilize the eye. And a large area of retinal dialysis is noted. So a thorough laser, 360-degree thorough laser was done. A radial tear was also noted in the nasal part of the retina. That was also lasered. So I purposefully have done some more amount of laser, and PFCL was taken out of the eye, and the eye was filled with silicone oil. So after around a week, retina looked settled with a nicely laser marks, and the oil-filled eye with a settled retina. So after much struggle, you should celebrate your success, and these type of cases, if gives you success,
apology from Justice Department.
There's a motivation you could take the more challenging cases in the future as a VS surgeon. So thank you for your patient hearing.
Thank you, Shomobo. I think very difficult case, botched up cataract surgery, but very nicely managed. A very important take-home message probably that sometimes we need to plan multiple sessions to bring back the vision. So it's not a one-time technique that you do whatever you want to do and you finish it off. He had patience to do multiple surgeries. What was the vision, final vision from above?
So patient is aphakic with oil filled eye, and the third surgery is waiting. I will do a SOR with a secondary I will for this. And right now, best corrector is 460. Not.
So I think it's pretty ambulatory vision.
Patient came with PLP, PR defective patient.
So, any comments from panel? Anybody?
After SOR, which lens are you thinking about implanting? Because you have taken out an
multi-piece SFI. I'll plan for multi-piece SFI.
With sutures, without sutures?
I do without sutures, sutureless. I do scleral tucking of the haptics.
Oh.
Kulpit, you want to add?
Sir, pardon, sir. TPA? No, sir. The whole blood is choroidal. Hemorrhagic CDs. So I was not sure about the TPA will work or not. So.
I would have added one thing that instead of cannula, I would have done a drainage, scleral cut through, so that you get more access to the suprachoroidal hemorrhage.
Shomo, very nicely done surgery. Two questions.
4 by 60
So,
4 by 60, sir, with FAK correction. FAK with, yeah.
One comment first is that when you took the ACIOL, so I want to make a comment that we need to clear all the vitreous around the IOL, or else because it's a very badly managed surgery, normally the vitreous is all around the IOL, and when you pull the IOL, actually the retina also might come with the IOL. So that is one point that you should always do at limited vitrectomy around the IOL so that the IOL is free of the vitreous.
So that was done, but that was not shown in the
one thing. And another thing, how many days after the cataract surgery you have taken up the patient for surgery?
Almost 3 weeks. The patient was roamed around in many hospitals.
So have you started the systemic steroid pre-operatively so that helps in resolution of the CD?
Actually, the patient was coming from far. So patient has no time to stay in Kolkata. So I had to take the patient for OT. But after I started systemic steroid after first surgery, so patient has developed a few adverse effects of systemic visolon. So I had to wait for another 2 weeks to take the patient for next surgery.
So maybe I will be asking this question to the other people who are there. So if you start the systemic steroid pre-operatively, could you manage the case with one single surgery? Rather than putting PFCL tamponade and taking
probably
up the
hemorrhagic CD, systemic visolon will not work in hemorrhagic CD as long as you are not draining.
No, but the patient was already started, and I think he stopped for adverse effects.
He didn't start for the
after first surgery. I started.
He started after the first surgery. My question: if you start a pre-operative steroid, give the patient steroid for 5 days and take up the patient for surgery after 5 days, then I think you can get away with one single surgery.
Yes, actually, patient has came to me after 3 weeks, so it is the ideal time for a hemorrhagic CD drainage. But the choroidal blood was started liquefying.
Okay, I think very nice presentation from Abu.
Sudipta sir, one question. I wanted to ask Boiragi sir. He was asking about the TPA. Do you feel there is any role for RTP injection in case of suprachoroidal hemorrhage drainage? Like you were asking the question.
Usually, as he said, no, after 2 weeks the blood gets liquefied, and that is the ideal time. So most of the time it is okay if you drain after 2 weeks time. I didn't know that it was after 2 weeks, so that's why I asked that.
Thank you.
Thank you. I will go ahead with not getting the breaks. We'll get into exudative RD now. So Anindo is having a presentation on inflammatory phases and ghosts in exudative RD.
My sincere acknowledgement to Dr. Anirban Chakraborty, the Renuka Eye Care team and OSWB academic wing for this particular platform. Today I am concentrating few ugly phases of exudative RD with an inflammatory interest. So this is the exhaustive list of causes of the retinal detachment. I am concentrating in this small segment of it. So coming to a case one, it's a pretty straight case. A 43 years old female presented with a bilateral dimness of vision with a deafness and a history of the headache. Anterior segment has significant reaction as well as a vitreous body, and there was bilateral exudative RD. So this was the presenting fundus photograph of the patient. Sorry. And we decided to go ahead with the fundus fluorescent angiography. If you look at the angiography serial images, we can appreciate this pinhead leaks with pulling of the dyes, an entire posterior pole. This is the left eye in the picture. We can appreciate the similar kind of picture. So it was a case of a acute onset VKH disease, and we decided to go ahead with further imaging. There is a diffusely thickened choroid, and there was shifting in the fluid. This was a case of VKH, was treated with a pulse intravenous methylprednisolone followed by oral steroid and azathioprine in combination, as well as a topical. With 6-month combination of the immunosuppressive therapy and low-dose steroid, patient was nicely recovered. This was the 6 months post-treatment photograph. Coming to a case 2, a 40-year-old female, bilateral dimness of vision for last 3 to 4 years. Her anterior segment was quiet. There was vitreous occasional cells. She was also diagnosed with a case of VKH, was put on oral steroid for a very long duration and low-dose methotrexate. There was no systemic history, bilateral multiple SRF pockets. This was the clinical presentation. The media was relatively clear, but there was gross dimness of vision in both the eyes. We decided to go ahead with the fundus fluorescent angiography. If we look at the fundus fluorescent angiography clearly, we can appreciate the RP is not looking okay. It is looking like a more of a sick type of RP. As well as there are multiple pinhead leaks type of things with pulling of the dyes, and the posterior segment is grossly inflamed. So there are 2 components. One is a sick RP along with the inflammatory component. This is the right eye picture, whereas in the left eye, if we look at those areas, there are RP in the ribs. If we look at particularly these 2 points, we can have the classical ink blot pattern of the leak. So actually we are dealing with it is a little old case. We are actually, and then there was a thickened choroid and shifting of the fluid. So we are actually dealing with a VKH disease, which was later complicated by CSCR. So we tapered down the oral steroid and started the patient on azathioprine, and we wait. But it was not very resolving, like there was vitreous cells, the SRF was persistent. Then we repeated the FFA after 2 months. This FFA picture, the right eye is showing some sort of resolving inflammation, whereas the left eye is still showing the CSL-like leak. So we consulted with our retina friends. This was the picture. It was in 2017 in the cases of OCT. At that time, this pachychoroid spectrum of the disease was not that well explained. So my retina colleagues did a laser in this particular case, FFA-guided laser, and I combined cyclosporine along with azathioprine for this particular case and follow-up every monthly. And after 5 months, the right eye, both eye visual acuity a little bit, we able to make the eye quiet. There was no subretinal fluid. There was subretinal fibrosis. This was the final photograph of the patient. Coming to an interesting case of a 50-year-old female, a right eye dimness of, presented with a right eye dimness of vision for a few days. There was no other ocular complaint. There was no pain, nothing. And she is non-diabetic, non-hypertensive. Best guided visual acuity was little subnormal, left eye was normal, and he was advised for cataract surgery somewhere. So looking at the fundus, if you look carefully, there are some subtle yellowish type of subretinal lesions. If you trace the vessels, there is a little bit of elevation. So this was the presenting OCT picture. There was an SRF as well. So I decided to, I was inquisitive. I was looking for the source of the subretinal fluid. I decided to go ahead with the angiography. If you look at the angiography phases, you can appreciate this hypofluorescent in the areas. There are multiple hypofluorescent in the areas. And the staining of the disc later on in the phase of angiography, it is hyperfluorescent. So it may be a case of undifferentiated choroiditis, which was presented with the subretinal fluid. So I investigated the patient, started on steroid and had a close observation. So this was the presenting OCT, and this was the after 10 days of the steroid. So undifferentiated choroiditis can also present with very early choroiditis can present with subretinal fluid. Even there may not be much signs of inflammation. Coming to an interesting case of a 45-year-old male who was a security professional, it is also a pretty straight case, diagnosed as choroiditis and was on steroid. This was seeing the left eye, he was given steroid. There is subretinal exudation, and there is exudative RD. The right eye lesion was new onset. So I did a angiography, and it was a classical in the case of a multifocal CSR where steroid is completely contraindicated. Coming to a case 5 of a 55-year-old one-eyed patient, a history of a penetrating trauma and severe visual impairment. There is no systemic history. The other is showing a exudative retinal detachment. This was the presenting the picture. If fundus fluorescent angiography showing a classical pinhead leaks many with a diffuse leaking in the disc. So we treat the patient with intravenous methylprednisolone followed by oral steroid and azathioprine. Patient recovered well in 6 months prolonged therapy. This is interesting in the case of a patient, young 56-year-old patient with a dimness of vision for 5 days. And the AC was quiet and there's occasional vitreous cells. He was only complaining of a dull aching pain he was bothered about. This is a classical presentation where we could, this is a multicolor image, you can get a localized exudative RD. Go ahead with the fluorescent angiography, you can appreciate pinhead leaks later on pooling. And this was a photograph where this choroid is localized thickening is there, and you can appreciate an early T sign. So this was actually a case of posterior scleritis with a very textbook-like presentation, dull aching pain and the age. So we treat it like a posterior scleritis. In this particular male, a 78-year-old male, presented with a dimness of vision for some duration. He was hypertensive and ischemic heart disease. Base guided visual acuity was 624 N18. In this particular person, there was also a pocket of subretinal exudative fluid in the left eye. There was not much of vitreous cells. Patient was not complaining of any pain or anything. So at 78 years of age, we are very scared of what we are actually dealing with. So we decided to go ahead with the, this is a OCT picture. Sorry. Sorry for not a very good kind of video. We can appreciate the presence of subretinal fluid. What I mean to show here, just look at this RP in the choroid in the complex.
This is last one.
It is looking stable, and this is also the RP choroid complex is more or less looking normal for the age. We did an ICG as well as a fluorescent angiography for the patient. This is the ICG pictures. You can see there are hypocyanescent dark dots, HDDs, which are classically described in choroidal interstitial inflammation. And whereas there is multiple pinhead leaks and there are capillary leaks. And this is the FFA picture, and this is the ICG picture. So the pictures are more going in favor of inflammation. I was a little hesitant, the patient having no complaint of any pain or anything. So are we dealing with at all a posterior scleritis? I went back to the literature. Yes, 17% of the cases of posterior scleritis also can present with without pain. I have spoken to Dr. JB. He has a paper from Shankar Nethralaya. So I started treating the patient with oral steroid. I'm following up. So my take-home message was a detailed history and a clinical evaluation. The laterality is very, very important. A Vickage disease is never an unilateral disease. Its presentation may be asymmetric. So always we look for the source of the fluid. That is very important. We have to do very detailed imaging. Maybe if ICG is available for choroidal imaging, that is very nice. If we do not have, at least we can have the FFA, a detailed choroidal imaging by ultrasonography. Systemic examination is very important to check the BP. If the patient is having malignant hypertension, that can present with so many different phases of it. The early referral to the specialty is definitely required, and aggressive management is required in case of a proper pan-uveitis spectrum.
Thank you, Anindo. I think very interesting cases. I'll just take a quick comment from Dr. Amitav Kumar. Sir, because a lot of times we have these exudative RDs, a lot of people are treating with steroids, and sometimes we get this steroid into CSR. So what will be your salient points on this if you're managing these patients?
Yeah, first of all, at the very outset, thank you, Anindo, for presenting that rainbow of uveitic entities which can cause exudative RD. Just one word of caution to start with, that do not rush with a surgery in a case of exudative RD. Probably that would be the last option if that exudative RD is not responding to your medications. We have had cases where we had to undergo go ahead with the surgery, even for exudative RD. In case there is a steroid-induced CSR, there's no other option, but you have to stop the steroids right away. You need not taper the steroids in that situation. Excepting there would be some patients who have had solid organ transplants where steroids cannot be stopped totally. So the dictum is to bring them down to a minimal level. And the only other option would be to put the patient on immunosuppressives, be it azathioprine or antimetabolites or cyclosporin or mycophenolate, mofetil or methotrexate, whatever you want. So in case there's a steroid-induced CSR, you can still use topical steroids, because there's so many CSR patients who undergo cataract surgery. So topicals can be used, but oral and systemic parenteral steroids should be avoided and stopped.
Thank you, sir. I think we'll go ahead with the next presentation from Dr. Smita Shadhu. That will be, there is a change of topic. It was ocular toxo, but now it will be ocular sarcoidosis.
Thank you. Good afternoon. Thank you, OSWB and Renuka Institute, for giving me this opportunity. So, I would like to start with some ocular sarcoidosis, some clinical pulse. It's a totally, I will talk about a totally clinical entity. So, this is a slit lamp picture of a patient who came to the outdoor, and it has been taken by a phone. It is not a slit lamp photograph, it is just on slit lamp and phone. So the patient was a 65-year-old female who came day before yesterday and had blurred vision in left eye and had recurrent redness in left eye from past 20 years, but was not treated well. The right eye was doing well. The vision was 6/9, and she had a little bit of cataract in the right eye, while in the left eye, her vision was counting finger, and she had a complicated cataract. So on slit lamp examination, what I could see was that there were broad-based posterior synechi, ironed out iris, few large old keratotic precipitates were there was complicated cataract, and there were tented peripheral anterior synechi at 7 o'clock and 5 o'clock. So this is not so clear. Fundus picture of the right eye. The left eye, we did B scan. There was no view of the retina. So in the right eye, what I could see were some depigmented as well as very few pigmented patches also. Spots, not patches, there were spots. So in my mind, it was that it must be ocular sarcoidosis. And I advised a battery of tests, which included blood test, Mantoux test, serum, ACE, chest X-ray, HRCT, blood sugar, urine calcium, and liver function test. So I would like to discuss something about ocular sarcoidosis. That ocular sarcoidosis is a granulomatous disease affecting multiple systems of the body in genetically predisposed individuals. And it can involve the eye in various ways, like dry eye, adnexal granulomas, or inflammatory or intraocular inflammations also. So in the Western literature, it has a bimodal peak, that is the age distribution varies. It is seen either in children from 2nd to 3rd decade or in old age from 5th to 6th decade. There is no gender predilection in the younger age group, but after 50, women are more affected in men. While in Indian scenario, what we see that the mostly affected people, we have a unimodal peak, and the mostly affected people are from the 5th to 6th decade with a female preponderance. So typical features we know in anterior uveitis, it is granulomatous inflammation, mutton fat keratotic precipitates, iris nodules, posterior synechiae, tented pars. So I have a few clinical pearls to discuss. Like if we see a hypopyon and we have anterior uveitis, then it is extremely rare that it can be a case of sarcoidosis. And it is usually bilateral, And the keratic precipitates will be large mutton fat, and there will be Bisaka's nodules, Kepi's nodules. There will be ironed out iris, that is the loss of iris pattern. And delayed presentation, which the patient I saw, so delayed presentation or improper treatment leads to severe anti-uveitis with complicated cataract. So the clinical pearl is that iris nodules and posterior cyanicia indicate moderate to severe inflammation, and tented paths are specific for sarcoidosis. We can see that the peripheral anterior cyanicia that are seen, they have a broad base at the cornea and a narrow base at the iris. So these are called tented peripheral anterior cyanicia. The intermediate uveitis, it can be snowbank, snowballs, and in posterior uveitis, it can occur as a granuloma, multifocal choroiditis, vasculitis. So this is a picture of intermediate uveitis with a very minimal vitritis and snowbanking. So this is a snowball formation in a very enlarged view. Presence of minimal vitritis is one of the hallmarks of ocular sarcoidosis. It can appear as a choroidal granuloma, or usually the small choroidal granulomas are seen mostly in the inferior half than in the superior half. It can appear as an optic nerve head granuloma, multifocal choroiditis. So a few points about vasculitis in sarcoid-related uveitis. Here the vasculitis usually involves the mid-peripheral retinal veins, and it is of non-obstructive type. It usually does not cause any vein occlusion, but exceptions are always there. It can happen. Different kinds of vasculitis are candlewax, skip, confluent, occlusive, combination of the same. So this is a candlewax dripping, skip vasculitis, a combination of both. So complications, it can be uveitic cataract, cystoid macular edema, retinal neovascularization with preretinal hemorrhage, epiretinal membrane, peripapillary CNVM, fibrosis. But a patient with scleritis, in an old age, we usually think it is associated with rheumatoid arthritis, but in a patient who is of fifth decade, and especially a female patient, we should think that it might be because of sarcoidosis. A topic that I want to discuss is tubercular sarcoidosis. It's a separate entity where either it is seen in patients who had tuberculosis and developed sarcoidosis, or in patients who have coexistent tuberculosis and sarcoidosis, or in patients who had sarcoidosis and developed tuberculosis later. So in such patients, we will see both pigmented and depigmented lesions, Mantoux positive, and recurrences. These are the various investigations, out of which the most important investigation is the chest X-ray, in which bilateral hilar lymphadenopathy is the hallmark of the disease. So Skading's classification, in stage 1, stage 0, there is no abnormality seen. Stage 2, there is bilateral hilar lymphadenopathy. Stage 2, parenchymal infiltrates are there. In 4, there is fibrosis with shrinkage. So we know that serum ACE is the serum ACE level is the basic test, but still it is not pathognomonic of sarcoidosis. It may be raised in other diseases also, while in sarcoidosis it might be normal as well. In calcium metabolism is deranged, so the uveitis workup includes, yes sir. Take-home message is ocular involvement may develop in the absence of systemic involvement. Hypopyon uveitis is extremely rare in sarcoidosis. Inferior half is more affected by sarcoid granulomas, and negative Mantoux is an important test result to establish the diagnosis of sarcoidosis. So I want to discuss whether anyone has experienced cases with presenting or fitting into the criteria for tubercular sarcoidosis, because the patient that I saw, he had a fundus picture of both depigmented as well as pigmented spots. So I have a doubt about it. So
any comment on this, anybody? Sorry, regarding this, if you can have a quick comment on this.
I think the sarcoid cases, their treatment duration is much, much more than other uveitic entities. The other thing is, if you have a disc granuloma, you must rule out a neurosarcoid as well. And I think it is better to do an HRCT now.
Yeah.
We have switched over, if you're imaging a patient and you're suspecting a granulomatous etiology or TB or a sarcoid, I think you should go ahead with the contrast-enhanced CT straight away instead of doing a chest X-ray, because chest X-ray misses almost 40% of the findings. And obviously, a tissue diagnosis from a biopsy with a non-caseating granuloma would be the gold standard. But we don't do tissue biopsy in many cases.
Thank you, sir. Thank you, ma'am. Very nice slit lamp images. I think very textbook information. Thank you so much. I think we'll go ahead with the last talk by Dr. Anirban Chakraborty. So he'll be speaking on a specific case on masquerade.
Neurological manifestation patient. I got 3 cases so far with third nerve palsy and parotid gland. This is known as Hereford's disease. So that also you have to keep in mind, that third nerve palsy and parotid swelling.
Sure. Okay, so Anirban, so your case on mass beneath the eye.
Thank you, Sudipto sir. So my topic is, thank you. So my topic is mass beneath the eye, a great masquerader. I'll go straight to the case. A 57-year-old male presented with dimness of vision in his right eye for 7 days with mild periocular pain. He was on regular medication for diabetes mellitus, hypertension, portal hypertension, liver cirrhosis and dyslipidemia. BCVA was 20 by 1200 in right eye and 20/20 in the left eye. Ocular adnexal examination and IOP were within normal limits in both eyes. Anterior segment examination showed mild conjunctival injection, 1+ cells in anterior chamber in right eye. Left eye was unremarkable. Coming to the fundus picture, this was the fundus picture which showed a huge yellowish orange mass involving the posterior pole with inferior exudative retinal detachment. We did an OCT through the mass which showed SRF with intraretinal fluid, thickened choroid with a lumpy bumpy appearance of the choroid. Coming to the B scan showed a mass with the outer hyperreflectivity and moderate to low inner reflectivity along with a shallow subtenon fluid. So it was a confusing picture. Coming to the FFA, we did an FFA which showed early blocked fluorescence, because early blocked choroidal fluorescence because of the choroidal mass, and which showed diffuse, gradual, dispersed, scattered hyperfluorescence in the subsequent phases and late staining, along with a hot disk. We did an MRI because we were confused whether it's a malignancy or it's an inflammatory pathology. MRI showed, you can see there is hyperfluorescence, hyperintensity in T1 weighted images and hypointense T2 weighted image in T2 weighted images. Then we did investigations which showed complete blood counts were within normal limit. ESR was raised. Fasting and postprandial sugar were also raised. HIV and TPH were negative. LFT was deranged because patient was already having liver cirrhosis. Kidney function test was within normal limit. MAN2 test was negative. All the inflammatory markers of RA, ANA, ANCA and serum ACE were negative. We did an MRI brain, CT chest and abdomen to rule out any evidence of a primary malignancy, which were all came out to be negative, and there was no consolidation or lymphadenopathy as well. So after figuring all this, we came to a diagnosis of idiopathic nodular posterior scleritis with associated exudative retinal detachment in the right eye. We advised him 3 doses of IVMP, but because his blood sugar levels were raised, IVMP could not be given. The physician refused. Hence, he was given a course of 1 mg per kg oral steroids under strict blood sugar monitoring. After starting the oral steroids, gradually over 3 days, we showed immediate flattening of the mass, and over a period of 3 months, the mass flattened fully, and the patient regained a vision of 20/60 from 20 by 1200. Here is the subsequent OCT pictures of the patient over a period of 3 months, which ultimately led to RP degeneration, but the mass fully resolved with the resolution of the SRF. Coming to the discussion, NPS is an uncommon scleral inflammatory disorder which can present as a choroidal mass causing diagnostic ambiguity. Our differential diagnoses were amelonotic choroidal melanoma, choroidal mets, choroidal hemangioma, osteoma, granuloma, and as well as primary vitreoretinal lymphoma, which can also be a great mimicker. coming to choroidal melanoma, this is the pictures of a choroidal. I've taken from the literature. This melanoma showing a blackish or a brownish kind of a mass, which has as we all know, which presents with outer hyperreflectivity and inner hypo to low to moderate reflectivity in the B scan. OCT pictures shows a dome-shaped mass with shaggy photoreceptors, double circulation on FFA, and OCT angio shows vascularity within the tumor. Metastasis can present as a creamy colored mass at the posterior pole, which shows irregular hyperreflectivity on the B scan. Lumpy bumpy appearance on OCT with SRF with exudative detachment, and however there are no vascularity of the tumor in on OCT angio. Hemangioma is generally presents a little differently with a orange or reddish colored mass with uniformly high hyperreflectivity on B scan. It's a very smooth shaped elevated mass on OCT with vascularity within the tumor in case of OCT angio. Coming to a granuloma generally presents as a very bright yellow orange colored lesion which shows high hyperfluorescence on FFA. And generally it is known to show the contact sign on OCT. Now coming to PVRL can also be a mimicker which also presents as a creamy colored subretinal mass with typical intraretinal, subretinal and sub-RP deposits. Osteoma can also be in a differential diagnosis, but maybe not in this case, but it's not, the features are a little different. Osteoma generally presents with horizontal lamellae kind of features on OCT, and there's a typical pseudo-optic nerve appearance on B scan. Now points in favor of NPS. Now in this case, patient had periocular pain, conjunctival and scleral congestion, inflammatory cells in AC, B scan showed T sign, and FFA showed a hot disk, which were in favor of NPS, and ESR was also raised. 0.6 NPS for MRI showed hyperintense image on T1 weighted images, and it was hypointense on T2 weighted images, which is very typical of a melanoma. However, inflammation can also mimic this kind of picture sometimes. It can show hyperintense pictures on T1 weighted images. OCT showed lumpy bumpy appearance, which is it generally signifies a metastasis, and presence of liver cirrhosis, which we were suspecting may be due to the melanoma metastasis into the liver. So that's why we were confused, but ultimately treatment with steroid led to a superb response in this case. So ultimately this led to the diagnosis of a nodular posterior scleritis. Now my question to the panelists in this case is, what would be the approach to such a case? How to rule out PVRL? How to rule out metastasis, any need for a PET scan in these cases, and role of immunosuppressives because the patient was already on very high blood sugar levels, so steroids, IVMP could not be given. So role of immunosuppressives in these cases. Thank you.
Thank you, Anirban. I think definitely a lot of ambiguities. But one point I just wanted to add, because ultrasound was very typical of inflammatory lesion. So
yes, the subtenon fluid
and reflectivity was also very heterogeneous compared to what we usually see in tumor lesions. That is one thing I feel that goes more in favor of inflammatory lesion. But anyway, Pate, any points from the panelists? Anybody else?
Posterior scleritis, pain on eye movement will be there. Whatever other differential diagnosis you have given, they don't present with pain. And scleritis pain is very, very much, not a very minimum, it is maximum pain.
That was the problem, ma'am. The patient was having very mild kind of pain, mild conjunctival injection, not very too many cells. That's why we were a little confused. The pain feature, he was not giving that typical very prominent pain feature. That was where we were getting confused. But the subtenon fluid was very clear on B scan. That was true.
To wait, the
patient was not that symptomatic.
Not that symptomatic. That is the problem. Patient was not that symptomatic.
Recurrent is a very common thing.
Yes.
Kulpit, you want to add anything?
Very nice case. Very beautifully presented, but I think a good clinical examination, because those inflammatory markers that you see, that first points towards is an inflammatory pathology, neither choroidal metastasis or the melanoma, usually they will not be having cells, and a good ultrasound. I think these two things points towards what actually we're dealing with.
Right. The one thing we were confused with was the huge size of the mass also made us a little confused.
So
I've never seen such a huge mass in case of posterior.
The photograph was very,
so
I think you were perfectly fine in keeping masquerade as your differentials, because of primary uveitis at the extremes of age, you must rule out masquerades because That is number one. Number two, I would be very skeptical in putting this patient on immunosuppressives because he already has a cirrhotic liver.
Yeah.
So I don't think
So,
you will be able to put
my question was, if the patient didn't have a liver cirrhosis, then would you put him on immunosuppressants?
Yes, I think that would because he's a diabetic, so you would want to wean him off steroids as early as possible and top it up with immunosuppressives.
Thank you. Thank you, sir.
Okay, thank you so much for this very nice and interactive session. I welcome Dr. Rajesh Majumdar Chaudhary and the oculoplastic group for the next session. We will take a photograph, group photograph.
A very good afternoon to everybody. Now we are going to have our oculoplasty session. In upcoming 40 minutes, few important and interesting aspects of oculoplasty and ocular oncology will be discussed. We have 4 speakers. Each presentation is of 6 minutes talk followed by 2 minutes discussion. We have our esteemed team of panelists, Dr. Chandana Chakraborty, Dr. Sabita Katot, Dr. Madhushmita Behra, and Dr. Muhammad Shahid Alam. I will request to come on stage and have their seats. Okay. Our first speaker is Dr. Rajesh Majumdar Chaudhary. He is practicing oculoplasty for many years in India as well as abroad. His topic is decision making for the eye removal surgery, tips for the comprehensive ophthalmologist.
Thank you, Shanchita. So eye removal surgery is an important surgery which even comprehensive ophthalmic practitioners can face. So one of my very favorite oculoplasty surgeons, he is a doyen of this specialty, mentioned about what happens when you remove the eye. The feeling is that, when you remove the eye, you may actually come to an end of the relationship you have with the patient. That's far from the truth, because that actually starts a lifelong relationship with the patient for the surgeon. So it's very important that we have an optimum decision-making process which will ensure proper psychosocial and cosmetic outcome for the patient, to consider non-surgical management of a blind eye. And in that situation, timing of the surgery is very vital. If you operate too early, then you probably may have lost a chance to ensure that the eye could have been kept. If you operate too late, then you may not get the most perfect and relevant cosmetic outcome. And of course, the type of surgery, you'll have to make a decision regarding the type of surgery. So to consider non-surgical management of a blind eye, so when the patient comes to you with a blind eye requesting for eye removal, I think what I would do is I would ask the question, does the eye cause you pain? If the answer is no, then we have to consider other management techniques. I would consider in that kind of situation a scleral shell. So the ideal patient for an ideal patient who will benefit from a scleral shell is someone who does not have eye pain, of course with a decreased corneal sensation, because you think about you're wearing something in the eye. The patient will be slightly enophthalmic, slightly thysical, no intraocular tumor of course, and a blind eye. So patient who has got a mildly painful blind eye, we would treat these patients initially with some steroid and a cycloplegic drop to decrease the inflammation. And if the pain improves, we can consider fitting the scleral shell. If the pain persists, then unfortunately eye removal may have to be considered. So the types of eye removal surgery which you would do normally in our day-to-day comprehensive practice, we can do an enucleation. You're all trained to do that. Evisceration is also something we have been trained to do as well. Exenteration is a topic which merits a separate presentation, so I'll not really go into in that particular aspect in detail. So when is this necessary? So consider primary orbital malignancy, periocular malignancy which has gone beyond the orbital septum, or in infection, especially fungal infection orbit. Because what happens if you know the nature of the orbit, the formless nature of the orbital fat makes it very difficult for you to understand where the tumor ends, where normal tissue begins. So types of exenteration, just a little discussion on that. So normally total and subtotal. Total exenteration when there is a lid involvement, and subtotal when there is no lid involvement, ideally. So enucleation, what you do in that particular surgery, you remove the eyeball, we cut the extraocular muscles, optic nerve is also cut, but the orbit generally is left undisturbed. Evisceration, the scleral cup is opened, intraocular content is scooped out, and luckily the extraocular muscles, the optic nerve is left undisturbed. So whether enucleation is the right surgery or evisceration, how do you decide? Is it surgeon's choice actually? More and more surgeons nowadays are choosing evisceration over enucleation. Enucleation is becoming more and more rare. So absolute indication enucleation, in my opinion, would be an intraocular tumor and a thoracical eye, painful thoracical eye, where you cannot really think about putting a proper normal size ball implant inside. And previously, there was a theory that, incidence of sympathetic ophthalmia was higher in evisceration compared to enucleation. Therefore, the thought process at that time was that enucleation is preferred over evisceration, especially in cases like trauma, post-VR surgery, or perforated corneal ulcer. These conditions were supposed to cause more incidences of sympathetic ophthalmia. However, the recent data we have shows that there is really very, very, rare happenstance of sympathetic ophthalmia post-evisceration. So for us, the indications for evisceration in daily practice nowadays is a panophthalmitis or a painful blind eye with a conjunctival scarring where you have difficulty in removing the tissue. So what are the factors which favor evisceration over enucleation? Evisceration obviously has a slightly less operating time. Eye movements are better because you have maintained the eye muscles, you haven't disturbed the eye muscles. And less disruption of the orbital tissue and less post of enophthalmos because the scleral cup is there. So is everything hunky-dory evisceration? Probably not, because sometimes in painful blind eye, the pain may persist as you do not cut the posterior ciliary nerve. The choice of implants, again, a small discussion on this. Porous solid, muscles attached, not attached, pegged or non-pegged. My personal practice is that I use porous implant and with donor sclera for enucleation and solid PMM implant for evisceration. So to consider this particular implant, you have to replace the volume. That is very vital. And to summarize, we have to explore all medical options to start with, have a frank discussion with the patient and the caregivers. I prefer evisceration or enucleation normally, unless it is otherwise indicated. We have to understand the implants, that's very vital. And sparing use of exenteration, because it's a very, very destructive surgery. And ensure that you have provided a lifelong medical and psychosocial support to the patient. Thank you.
Thank you, sir, for giving us a very useful guideline. But as we are running out of time, we can have the questions at the end of all the talks. So our next speaker is Dr. Anirban Bhaduri. He is the currently HOD of Shushrut Eye Hospital, Oculoplasty and Oncology Service, and his special area of interest is retinoblastoma. He will talk about OSSN, current management paradigm.
Yeah, good afternoon, and thank you, Dr. Anirban, for having invited me to your program. There is a pecking order in ophthalmology, and I'll be very, very blunt. There is a pecking order in ophthalmology. Oculoplasty comes on the shit end of ophthalmology. And you can make that out because all the young gentlemen who were present at the back rows, they just walked out when Rajasdas started speaking. So that is the kind of respect that oculoplasty commands. Oncology is even worse. Right? So, it's not even worth taking the trouble to make a presentation. I wanted to know how many of you treat OSSN. Okay, and how many of you treat OSSN with surgery? And how many of you give primary chemotherapy for OSSN? Okay, so today, what I wanted to share was how we take decisions in the management of OSSN, because a lot of interesting things have happened in the last decade. And so OSSN was a term that was coined in 1995. And the reason was because when we were students, we used to hear about CIN, CIS, invasive squamous cell carcinoma, right? But clinically, you really could not tell the difference between each. So Lee and Hurst, they came up with this term, ocular surface squamous neoplasia, which is an umbrella which covers the entire spectrum of disease from dysplasia to carcinoma in situ to invasive squamous cell carcinoma. And so these are examples of OSSN which are superficial, but squamous cell carcinoma is invasive and it can even go and invade the globe, as in this example. It can even invade the orbit and surrounding structures. So it can go through the punctum, into the sac, into the nasal sinuses as well. That's the other spectrum of OSSN. So your decision of how to treat will depend on the level of invasion beyond the basement membrane and also level of invasion in the other structures around the conjunctiva. The other thing is, what choices do we have? So when we trained, surgery was the gold standard, and as the raise of hands in this room showed, that we still practice surgery, okay, as a primary modality of treatment. But changes have happened. Chemotherapy is coming up in ascendancy, and the reason is because now we have methods of assessing which are the tumors that have not crossed the basement membrane clinically. So that is why we are now able to select patients for primary chemotherapy. Radiotherapy, of course, is still an adjunctive therapy. So chemotherapy is something that can be used as a primary treatment or also adjunctive treatment. The third part is, how do you make the decisions? What has happened is there have been advances in imaging. We were familiar with CT scan and MRI when we had orbital invasion or intraocular invasion. UBM has been there for a while, but ASOCT is what has changed the way we take decisions in the treatment of OSSN. The other thing which I missed out is that you have the options of surgery, chemotherapy, and radiotherapy. What if you combine treatment? So there are situations where you can do that, and that is what we term as multimodal therapy. Okay, how do you recognize OSSN? The problem is that OSSN also mimics other conditions, and other conditions mimic OSSN, the common being pterygium and pinguicula, right? So these are the characteristics which help you to diagnose an OSSN. One is keratin. You can see keratin here. You can see keratin here. Intrinsic vessels. So this is a very high magnification image taken on a slit lamp. You see these loops of vessels within the tumor. Those are intrinsic vessels. The third are episcleral feeder vessels. We are very familiar with them. So you have feeder vessels here as well as here. What about stains? So rose Bengal is the classical stain that was used. We used Lissamine green, but we are coming back to rose Bengal because the staining is much better. Toluidine blue is what is being practiced in some nations. We do not have access to toluidine blue at this point in time. The last is some patients, and especially in us, because we are a pigmented race, you might have pigmentation in OSSN. So remember that pigmentation does not mean it's a melanotic tumor. Okay, some OSSNs are misdiagnosed as melanomas, but that pigmentation is a secondary pigmentation in response to a tumor growth, as you see in this example. The other problem with OSSN is that sometimes there are difficult presentations where OSSN mimics other conditions. Some of these pictures will be familiar with you, to you because some of these pictures were contributed by Dr. Honavar when I was working with him. And Dr. Swati Kaliki, who's now the head of department in oncology, she also uses these images. So the first one is a pigmented OSSN, but it's a very large OSSN. Now this was a young man who was HIV positive. Okay, so young people with aggressive OSSN. OSSN is classically a disease of the elderly. So young people, please remember that the patient might be immunodeficient. The second is a diffuse OSSN. This is the corneal OSSN. Just look at that haze. And the first patient that we encountered was a patient who had undergone PRK, okay, to remove that corneal haze. But how do you recognize a corneal OSSN is you see that opacity, and then you look at the finger-like edges, what we describe as the fimbriated margin. Time is over. Can we stop? Should we continue? Okay. Then you have this situation where you have a peripheral ulcerative condition with a perforation. This too was OSSN. But how did that come up? That came up during the histopathology, when this corneal button was removed for. This is something I learned the hard way. So we all thought this was necrotizing scleritis. Dr. Honabar made me do the biopsy. So this is again another presentation where there is scleral invasion. The sclera gets destroyed. And how you recognize it? By this undermining of this conjunctiva here. Okay. The last is orbital OSSN. So misdiagnosed, untreated, badly treated OSSNs sometimes end up in this situation. Okay. I was talking about the imaging. Two things that have happened. We were talking about ASOCT and UBM. How does that help us in decision making? Let's look at UBM first because that is older technology. Now, UBM has lower resolution, but that is much better than an ultrasound, a typical B-scan ultrasound. Now, UBM helps you to see the anterior segment well. And you see this. You have invasion inside the angle. You have invasion of the ciliary body. Okay, so macro invasion can be picked up by UBM. What you cannot pick up is micro invasion. All right, the other disadvantage, of course, it's a contact method. Let's look at ASOCT. That is what has revolutionized the way we treat OSSN. Shorter penetration, but much better resolution, and you can actually pick up micro invasion. What do you look for? One is this abrupt change from normal to abnormal. Okay. The second is the hyper reflective epithelium. You see the thickened epithelium, but it is much more reflective than this epithelium that you see here. And the third is, this is where it becomes really important, is that you can actually make out a cleavage plane between the lesion and the underlying stroma. And that helps you to decide whether this is invasive or non-invasive. Because if it is non-invasive, then you do have the option of primary topical chemotherapy. So this is the publication from India. This is from our colleagues in Bhubaneswar, where they showed an additional feature. You can also have a hyperreflective zone beneath the hyperreflective abnormal epithelium. Okay, where would you use this? Now look at this patient. Large tumor, cells in the AC. This is what the CT scan shows. So you see the intraocular invasion, massive invasion. So this patient would go for destructive surgery. Another situation. This patient with a very large tumor, you cannot see what is the extent of the tumor behind the ocular surface. Now where does MRI come in? Look at what the MRI does. It shows that there is a distinct cornea and sclera, does not show any obvious orbital invasion. So this was the patient where we were able to salvage the eye. Okay, look at, we have examples. So this is the patient, classic OSSN, it has all the clinical features. This is the ASOCT. You see that demarcation line? The hyperreflective zone. So this is a non-invasive lesion. This is a situation where, yes, you can do surgery. Surgery is what we've been doing all these years. But this is a situation where you can give primary topical chemotherapy. So this patient was treated with interferon, and the disease went away. Second case, another classic OSSN. Okay, again you have the demarcation line. Now this patient was treated with 5-FU. Okay, so you have these options. You have chemotherapy with mitomycin C, which is more toxic. You have 5-FU, which is more gentle. And then of course you have immunotherapy with interferon, which is the gentlest of them all. But then again, it takes a much longer time to work. So you can use these modalities only if you have an ASOCT which tells you that there is no invasion. All right. This is the patient after 2 cycles of 5-FU. Look at this situation. You have a nodular tumor. The ASOCT, there is a shadow here, right? So up to here, you can make out that it has not gone beyond the basement membrane. Beyond that, you don't know. What would you do here? So this is a situation where we would not be comfortable giving primary chemotherapy. This is where we would go for surgery, which was always been the gold standard of treatment. This is another example, a pigmented oasis, and it's small, placoid, but again, the imaging does not tell you what goes beyond the basement membrane. So this is again a candidate for surgery. And this is how you send your samples. You excise the mass, you lay out the margins, you label the edges so that the pathologist knows exactly what they're looking at. We'll skip this in the interest of time. We'll move on. Okay, this is a situation where you have this lady who has multiple tumors. The cornea is partly ulcerated. So what we did here was, can we go ahead and do surgery in this situation? It's involving the cornea as well as the sclera. The conjunctiva, the tumor is fixed to the sclera. Okay, so you have a situation where you have a invasion possibly involving the sclera. So this is after giving mitomycin C, 1 cycle. The tumor is decreased in size, and now you can see that what we showed you in that necrotizing scleritis patient, remember, you can see scleral invasion here. That is confirmed by UBM. But there is no significant mass lesion to be excised, because then you will have to remove a part of the sclera and a part of the cornea as well. So here you can use the third modality. So this patient was referred out for a plaque brachytherapy. All right, so now we are using 2 modalities, chemoreduction and plaque brachytherapy. This is the patient after treatment. She's completed 2 years of follow-up. All right, this is the UBM post-treatment. The last one. Okay, 87-year-old woman, we showed you this picture earlier. Large mass overhanging the lids. And the MRI showed that there was no intraocular invasion. So we started this patient on topical chemotherapy. Finally, we excised the residual mass along with partial sclerectomy, because we knew that sclera is involved, right? And what happens is that the histopathology showed that this patient continued to have base positivity. So the amount of tissue that was excised, including the sclera, the entire sclera that we had excised was involved. That means there is microscopic residual disease. This patient again goes for plaque brachytherapy. Okay. This is her, she's completed 2.5 years of follow-up. So salvage eye with good vision. All right, this is what we follow now. This is the algorithm that we use. If you have a placoid or a nodular tumor, but there is no fixity, how do you check for fixity? You move the conjunctiva around the lesion with a Johnson buds, right? Do an ASOCT. If it is non-invasive, go for topical chemotherapy. If it is invasive, or you cannot definitely say that the basement membrane is not involved, go for surgery. All right. Second situation is, what if it is fixed? Do a UBM. If you have scleral invasion, you can go ahead and do surgery followed by plaque brachytherapy. But if there is intraocular invasion, then you'll have to go for an extended enucleation. And this is the worst case scenario where you'll have to do an orbital exenteration. So that is what I have for you. Thank you. Any questions? We can take it in the end.
Thank you, sir, for a very nice presentation. My question is, as interferon alpha is not available now, as topical chemotherapy, which one you should prefer?
So this happened last year. Last year, interferon went off the Indian market, and we had to stop doing giving interferon therapy. Then what we did was we came back to 5-FU. We've had a very bad experience with 5-FU in the past, all right, including a lot of corneal scarring. But the new protocol for 5-FU is that you give that 1% drops 4 times a day for only 1 week, and then wait for 3 weeks. Give a window period of 3 weeks, see the patient again after 1 month, and you can repeat cycles if required, and it works very well. Okay, so that is what we've been doing now. Interferon has come back, so only one interferon is now available. Earlier there were 2. So Reliferon, manufactured by Reliance, is back in the market. Okay. Sorry? For interferon. So, see, first thing is you have to have proof that it has not crossed the basement membrane, right? Which is going to be based on your ASOCT. With interferon, you give 1 million units per 1 ml, right? That is the concentration. 1 drop 4 times a day, and you give it continuously. Here, what happens is 1 cycle is 6 weeks. So you reassess your patient after 6 weeks, and then continue giving the drug until the disease is resolved completely. With all topical chemotherapy, you have to understand that once your disease is resolved, you will give 1 more cycle of the drug. Subconjunctival injection only if you have a very large lesion, yes. But there again, the condition is going to be that it is non-invasive. So if it is very extensive, yes, you can give subconjunctival injection.
5-FU, MMC and interferon.
Expert.
No, only for interferon. 5-FU and mitomycin, you will not give subconjunctival injections.
Only interferon. Only interferon.
Only interferon.
Do we need to confirm histopathologically before starting chemotherapy, or the diagnosis is just based on clinical signs which you have described before starting chemo?
So if you have somebody with your experience, it would be on the basis of clinical diagnosis.
So it's not mandatory to do impression cytology or something like that?
No. So it would be a clinical diagnosis. If you're going to do surgery, you might as well excise the entire thing.
No, if I am intending to
contemplating
start
topical chemotherapy, it will be on the basis of clinical diagnosis.
Your diagnosis should be accurate. Another thing is especially in case of corneal OSSN, and where multiple quadrants has been involved. In those cases, you have to, there is no way of surgery. You have to start with the topical.
Corneal OSS, you have the Bowman's layer. Right, that is going to usually protect the corneal stroma. So corneal OSSN, very good this thing. So corneal OSSN was the only condition where we used to give topical chemotherapy before ASOCT came out. Right.
That is the last thing.
Very much so. So mitomycin C is what we have most used to, right? We've been using it for more than 15 years now. So mitomycin C would generally be used for as a neoadjuvant chemotherapy, where you want to reduce the size of a tumor before you go ahead and do excision biopsy. So if you saw that the fourth and the fifth example, primary chemotherapy, sir, if I would have a choice, I would rather use interferon or 5-FU because they're much more gentle. With mitomycin C, if you've used it, you'll realize that it can really come and bite you. There's intense congestion, lot of discomfort for the patient, and usually when you give the second cycle, the inflammation is much worse. So we only use it for chemo reduction, or rarely where you have a situation where the tumor is coming under control and then, there is no further improvement. That is when you can give mitomycin C.
How frequently we need to do ASOCT?
How frequently? So you do it once when you make your initial assessment, and then you do another ASOCT to document that your treatment is complete.
So we think we should move to our,
yes, I think so.
Third presentation. Our speaker is Dr. Salil Kumar Mondal. At present, he is a professor of ophthalmology in RIO, Kolkata, undergraduate as well as postgraduate examiner and teacher. His topic is early division of modified Cutler-Beard procedure using novel tissue expander for breech flap formation and novel FKPF for tarsus replacement in upper lid tumor.
Hello. And the title is too much bigger for understanding. The study is just started. After finishing of my study, and the title becomes shortened. No financial interest. Upper lid reconstruction is always a challenge to oculosis surgeon. A small defect can directly close, and a larger defect, when 60 to 100% involved, it needs a tarsal plate replacement followed by architectural support. The Cutler-Beard procedure typically is a two-stage procedure and it is a modified. In the first stage, we use a novel tissue expander, the balloon of the 10 or 14 French silicone Fullis catheter, used as an expander device to recruit the extra tissue from the skin on subcutaneous muscle complex to form the breech flap, and novel filamentous knitted polyester fabric is suitable for replacement of the tarsal plate, allowing early division at 2 weeks or 14 days for early visual revision instead of 6 to 8 weeks. This approach improved the structural support and cosmetic results in early rehabilitation, and it is useful particularly in a one-eye patient. The study is to assess the safety, outcome, efficacy of early division of CVE and novel use of filamentous knitted polyester fabric to replacement of the tarsal plate in 70 to 100% defect, and to estimate the functional aesthetic outcome. Method: prospective interventional study, target 30 patients. Second stage CVE was done in absolutely second week of 14 days, the created defect, a pre and post-operative measurement, MRD1, PFH, LPS action was noted. The balloon of 10-14 phase silicon catheter was used as a novel expander device. Baseline Doppler flowmetry at marked area after short duration tissue expansion, then deflation, again DF, to assess the flap vascularity. Now comes to the procedure. This is no interest. This is upper lid tumor. First, to area the elliptical marked area, the surface area is marked by a formula, but is known as S equals to pi into long axis and most. This is the baseline Doppler flowmetry. We have to assess the number of vessels, blood flowmetry, PI index, and vascularity index. Balloon of the 14F catheter used as expander device. You have to check the IOP whether the force transmitted to the eyeball or not. Deflation of the balloon on 4th day. Again you do Doppler flowmetry. Then you have to see the vascular level, number of vessels, lumen of the vessel, all are increased. This study shows that increased vascularity helps and tissue recruitment helps your formation of the new tissue for breech flap formation. Now, the rest of the treatment, everybody knows, remove the tumor with a 4 millimeter wide apert to free the margin control with frozen section biopsy and assess the created defect when it is at almost 80 to 85%. Now, the breech flap formation is here. This is a rectangular flap which tracks from the lower lid. Peculiarity of this study, when you do an expansion of the tissue, splitting of the breech flap is much easier. We did more than a 300 cutler beard, but these findings helps during expansion, short duration expansion is easier. Now here is a posterior lamina, this is anterior lamina. Posterior lamina of the advanced length flap join the posterior lamina of the upper lid. Now this is a novel filamentous knitted polyester fabric element which is fashioned as a tarsal plate dimension. The specification is 28 millimeter long, central wide is 6 millimeter, multiple hole thickness is 6 millimeter, and flexible in all the direction. That is much more advantage. Now here the posterior lamina of the both advanced vent flap and the upper lid join to make the posterior lamina bay, where this filamentous knitted polyester fabric implant is fixed with the 5O polygalactin suture. After that, the anterior lamina is sandwiched. And this FKPF flap helps in structural support of the tarsal plate. After 14 days, this is that stage 1 cutler beard procedure is complete. Usually cutler beard procedure second stage done after 6 to 8 weeks. That is a long duration. So you are thinking how to rehabilitate the patient early. Can it be made within the 14 days or 2 weeks? Here the another incision made here to make the hammock flap vascularity from all the way. Stage 1 modified cutler beard procedure done. On 14 days, with a convexity downwards incision made to separate the lid. Convexity downwards incision made with a slanting will make it overhanging conjunctiva to cover the eyelid margin for eyelid margin reconstruction. Here we apply double arm suture because this double arm suture helps to prevent the corneal complication. If there is corneal complication there, you can put a bandage contact lens. Now, we have finished within 14 days of cutler beard procedure. 100% defect and 80% defect of the upper lid best treated by the cutler beard. No way. So, Only the disadvantage of this procedure is a long duration, 6 to 8 weeks wait for the tissue to form. Now we use a newer approach for tissue recurrent for expansion of the tissue and FKP. This is the post-op period of the patient. So result is pre-op MRD1 minus 1.83 with standard deviation to 4. Pre-FH value 1.62 with standard deviation to 11.25 with standard deviation. Pre-op LPS action 1.5 to 14. So comes to a conclusion, tissue acceptance is excellent. No such graft failure, infection, exhaustion of FKPF. Overall arterial support of the lead is well maintained. Short duration, rapid expansion of the skin muscle complex, so increased vascularity, proof by Doppler flowmetry. Nowadays, a lot of author thinking, and they have a concept that increased angiogenesis. But how to prove? Only the Doppler flowmetry can prove the increased vascularity of the flap. And even the next area, you can use the Doppler flowmetry and do reconstruction. Thanks for your kind attention.
Thank you, sir, for sharing such an innovative and unique method of FKPF implant, particularly where the lace, and I think in severe facial burn, trauma, where lace tissue is available for grafting. The questions we will take later. So, one question, sir, infection, is there any difference? You have used silicone also plate, I think.
Though first my publication on silicone plate, which is established, but silicone plate is mostly for 6 to 8 weeks. That is the usual cutler beard procedure. That is proof. But in this case, we have seen that immature tissue is there because we open at 14 days. It's almost immature tissue. The immature tissue recruitment by the balloon expansion. If the tissue is expanded with the help of temporary expansion, you can use the reconstruction. In immature tissue, silicone plate is not applicable. Okay. Only this FKPF, this is the material which is much more applicable. Still now we did 5-6 cases, almost all the patients are okay. No extrusion resulted. That is why in early division, this is our advice not to use a silicone plate. You can use a FKPF.
Okay. Is there any difference in your extrusion rate and infection between the silicone plate and FKPF? No.
Even I say, I have a patient we operated just 3 months before. The patient had all drug allergy. So all the surgeons, they refuse. The whole of the West Bengal, Eastern zone, they comes to me. Then I say, only the treatment is surgery. And they refer to, I will refer to radiotherapy or chemotherapy for chemoradiation. Well, no, the treatment is surgical. Then I go to anesthetist. Can you do anesthesia with this patient? There's no risk. All the drug allergies there. Only 4 twin campus, that patient have no allergy. Ultimately, they have done anesthesia. I'll do cutler beard without post-op antibiotic and any painkiller. And the patient is okay. So, and infection is, if you do a sterile manner, doesn't require an antibiotic. This is my proof it. Any question, anybody?
Okay, then I think we should move to our last presentation. Our last speaker is Dr. Shauruk Pathak.
Good afternoon.
He is attached to Renuka Eye Hospital and Shushrut Eye Hospital and has his own practice. His topic is surgical challenges, a bouquet of interesting cases.
Good afternoon. Thanks OSWB and Renuka for choosing me as a showstopper. I will share with you some very common plastic cases I came across in last few months. A few lead and periocular injury cases and 2 or 3 lead tumor cases. To start with, it's the patient is a mother of a doctor referred from Bardhaman. It's a simple upper lead injury from a pet dog. Why I choose this case, the most important thing is the anatomical proper apposition, that is gray line apposition. The PGTs, any PGTs here? Please raise your hand. because in ocular emergency cases, you have to deal this type of patients. So proper apposition is most important. Next is an interesting case. This is a lower lid injury from a pet dog in a almost 17-year-old female. এটা নিয়ে একটা মজার গল্প আছে, সেটা হচ্ছে আমার এক রেটিনা জুনিয়র, সে আমাকে ফোন করে বলছে যে একটা কেস পাঠাচ্ছি, সিম্পল দুটো সুচার লাগবে, তুমি করে দিও। আমি তো করি না, তুমি করে দিও। তো আমি সকালবেলা যখন আউটডোরে পেশেন্টটা দেখলাম, তখন দেখি যে এটা তো সিম্পল মোটেই নয়, ইটস এ বিগ লিড ইঞ্জুরি অ্যান্ড দেয়ার ইজ এ লোয়ার ক্যানালিকুলার ইঞ্জুরি। তো আমি আমার ওটি স্টাফকে ফোন করলাম যে আচ্ছা এটা তো লোয়ার ক্যানালিকুলার ইঞ্জুরি, তার মনোক্যানালিকুলার স্ট্যান্ড লাগবে। তা আমি যেটা বলেছিলাম আনতে, সেটা কি আনা হয়েছে? তো ওটি স্টাফ বলছে স্যার মনোক্যানালিকুলার স্ট্যান্ড সেটা কি খায় না মাথায় দেয়, মানে দের ইজ নো অ্যাওয়ারনেস অ্যাবাউট মনোক্যানালিকুলার স্ট্যান্ড। সো কী করা যাবে? তখন আমি ভাবলাম যে এক কাজ করি, আমাদের যে আমরা ডিসিআরে যে বাইক্যানালিকুলার স্টেন্টিং ইউজ করি, সেটা আমি কী করি, তার যেটা এক্সট্রা বেঁচে যায় সেটা আমরা ইটিও করে রেখে দিই। তখন বললাম অ্যাটলিস্ট তুমি অন্তত সেইটা দাও। আমি তখন একটা ওই সিলিকন টিউব ওই লোয়ার ক্যানালিকুলাসে দিয়ে ইঞ্জুরিটা রিপেয়ার করে ছেড়ে দিলাম। অ্যান্ড আই অর্ডার্ড দ্য মনোক্যানালিকুলার স্টেন্ট ফ্রম ইমপ্লান্ট হাউস and procured it. In the next day, I again opened the part in the near the canaliculus, opened the sutures, put the monocanalicula stent and sutured it. So this is a monocanalicula stent. It's not very commonly available in Calcutta, but now it is available. Orolab makes it. The name is Oro stent. No financial interest. So this is a patient after the monocular stent was placed in situ. And this is the post-op, 3 months. This is a very common injury with a wooden stick. What I trying to show this is, it looks common, but sometimes foreign body is entrapped. So before suturing, you must rule out any foreign body inside. Another case, a case of patients of Parkinsonism, a fall. Just simple suturing is enough. Now, few tumors I would like to share with you. This is a lower lid tumor, 5-year-old male, and the patient was being treated as Calagian. So the look was like malignant tumor, so I did an excision with safe margin and with a reconstruction by tensile flap. And in the excised specimen, there is one suture, and I placed in the nasal margin, and I wrote that the sutured part is the nasal. And the histopathology was mammalian gland carcinoma. The margin was free of tumor. This is the post-op follow-up. Another case is a larger tumor, more than half of the lid is involved, and I did manage to get it opposed. The histopathology was still mammalian gland carcinoma. This is a very simple case, a cystic swelling just below the brow. CT scan was done, it's not available here. The deeper structure was not involved. The simple excision was done, and the histopathology was hemangioma. That's all. Thank you all.
Very nice presentation, all well-managed cases. Now over to panelists for questions.
We are hungry then.
No, সবাই hungry নয়, কেউ খেয়ে এসছে কিন্তু।
In case of Dr. Rajesh is there. In case of enucleation or evisceration, he has almost covered everything. Just few tips. While you are putting the taken the decision that is in a painful blind eye, you have planned for an enucleation or evisceration, please do an USGB scan, because many times this has come up as a case of intraocular malignancy. So that is there. Next is that while putting the ball inside, silicone ball, you have to be very careful that it should be placed in the proper position. That means in a case of enucleation, it should be posterior, within the posterior Tenon's capsule, not anteriorly. If you put it in the anterior Tenon's capsule and suture it, invariably it is going to be extruded after few days. So these are the things I think one should. And another thing is that while suturing the conjunctiva and the tenons, you have to be very, very meticulous, because many things we have come across, like a case of pyogenic granuloma, a case of retention cyst. So only meticulous, good suturing is needed, this conjunctiva.
Thank you.
That's all.
Thank you.
Ma'am, another question. In evisceration or enucleation, in PL positive eye, though no working vision is there, is it medico-legally?
No, this is not medically accepted, but for the interest of the patient, sometimes you can just make it a PL query or PL negative and can go ahead. Officially, documentation will be PL negative.
If patient wants and it is a
Yes.
disfigured
Yes.
eye, then we can go ahead
Yes,
with
yes.
this evisceration
Yes.
and enucleation in a PL positive
Yes.
eye also. Any question from Dr. Madhushmita Vera?
For panophthalmitis, if you are planning evisceration, is it advisable to go for ball implant at that time?
Why not? Always. Even in case of retinoblastoma, after enucleation, you could. Previously, our teachers, they taught us that don't put implant in the case of retinoblastoma.
No,
But-
infective cases.
Yes.
We can go for that.
Yes, you can do.
Exactly. At the same
If there
sitting,
is,
we can go for
active
evisceration
infection,
with ball
should you go
implant.
for-
Yes, because you are taking out the whole thing, na, inside. Nothing will be there.
Initially, it was like that. We will go for evisceration after 1 month. Then we can think of secondary implant.
No.
It's not like that.
No. At the same sitting. At the same sitting.
Dr. Sabita Katroch, madam.
After exenteration, prosthodontics, I don't know what is the situation out here, but there is an implant which is, they are doing, prosthodontics are doing, where they put magnets, in the orbital rim, okay, and then attach the implant. It is made, I don't know what material, and then it just sticks to these 3 magnets. You have to work out the weights and the number of magnets and all that, but it is supposed to work very well, and this is something very new to me. I mean, I learned it recently. I mean, I think, and the prosthodontics were doing a very good job of it, because this is something which is really neglected, So I think if we get it here, it will be great.
So as far as my exenerated implant is concerned, so the silicone implant is the best thing, where like they have to glue it. This magnetic implant, the magnetic implant which you are talking about. So this had been there in literature, like around in 2000 there was a paper published. Then it was discontinued, more for the reason because those magnets, which are fixed to the bone, they over a period of time it gets eroded. Then you get a discharging sinus, chronic discharging sinus with infection in those. So initially it works well, but over a longer period of time it gives trouble. So that's why it didn't took off.
But the adhesive part, they say the problem is that the patient has to really clean it well every 3-4 days.
So what
Even
in
the
those patients,
adhesive
what
doesn't
I
work
do,
very well.
so I ask these patients to have 2 implants. One is that silicone one with the adhesive, and another is the spectacle mounted one. So the spectacle, which is mounted on a spectacle. It's nothing to do with the socket.
The regular one, which
The regular
we
one.
used
So
to,
at home and regularly they can wear that
this
spectacle mounted, and whenever they are going to some parties or functions, there they can use that silicone one. Yeah. And primary implant in panophthalmitis, so that you have to assess on table. So if you see that the scleral shell is not infected,
yes,
you can put an implant. But if the scleral shell doesn't appear healthy, then there are high chances that there will be extrusion. But anyways, if it extrudes out, anyways you are going to put a secondary implant, so you are not going to harm the patient. Only thing is, once you put the implant and if it is infected, the suturing becomes quite difficult.
Any other question from anybody? Okay, then we have come to our end of our oculoplasty session.
So we come to the end of the program here, and I would like to thank everybody on behalf of OSWB and Renuka Institute for coming here, and it's okay. for coming here and gracing the occasion. I would especially like to thank Devashish sir, Rupok sir, Shivashish for helping me manage this program, and for all the panelists and the speakers to coming here, especially Rajesh sir, Arup sir, then Shutova ma'am, Shudipto sir, who all managed, Udbuddho, who all helped me gather all the speakers here and make this program successful. Thank you. I won't delay much because everyone is hungry. Thank you for coming here. Thank you so much.
I think he just missed out to thank our sponsors for today. A big thank you, without whom we would not have been possible to make it functional today. We thank our audiovisual team. We thank our fabricators. And most of all, I thank Anirban and Sir, Dr. Oshit Chakraborty, for coming forward on their own to hold this program on behalf of OSWB. Thank you, Anirban. You have done a great job. We really appreciate your efforts and look forward to such efforts in future also. Thank you. So please let us all have lunch together. Yeah, please. Please, yeah.